Strong, I got a feeling I got a feeling coming on. A feeling coming on. Strong, I got a feeling coming on. A feeling coming on. I got a feeling coming on. Feeling coming on. Strong, coming on. A feeling coming on. I got a feeling coming on. Feeling coming on. Strong, strong, with me. It takes control, it's easy. Sometimes it takes all me. It takes a lot of honesty. When it comes on the street, it takes control and it frees me. When it control on my knees, it takes control and I'm ready. I'm feeling coming, coming on. I'm feeling coming, I'm feeling coming, I'm feeling coming. I just woke up from a dream where you and I had to say goodbye. And I don't know what it all means, but since I survived, I realized wherever you go, that's where I'll follow. Nobody's promised tomorrow, so I'm not aware. It's the last night, it's the last night. If the world was ending, I want you to you. There's no time, and our time was to hold you just for a while. And tell me, I swear, think I wanna be next to you. Oh, lost in the words that we sing. I don't even wanna do this anymore, 'cause you already know what you mean to me, and all love's the only war worth fighting for. Wherever you go, that's where I'll follow. Nobody's promised tomorrow, so I'ma love you every night like it's the last night, like it's the last night. If the world was ending, I wanna be next to you. If the party was over and our time on earth was through, I wanna hold you just for a while and time with a smile. If the world was ending, I wanna be next to you, right next to you, next to you, right next to you. wanna be next to you.
Sun is going down, time is running out, no one else around me. Steady losing light, steady losing my mind, over shadows and gravity. Without you, there ain't no place for me to hide. Without you, there's no way I can sleep tonight. What I do for a little bit of peace and quiet. Without you, I keep slipping into bad dreams. But there's no you and I. No sound when I cry. I love you and I need you to set me free from all of these bad dreams. Waiting on the other side. No sound when I cry. I love you and I need you to set me free from all of these bad dreams. All of these, baby, please come around. Help me settle down. Hell is having some cloud in my head. What you waiting for? Something physical. I can do this by myself. Without you, there ain't no place for me to hide. Without you, there's no way I can sleep tonight. What I do for a little bit of peace and quiet. Without you, I keep slipping in a bad dream. But there's no you and I. No sound when I cry. I love you and I need you to set me free from all of these bad dreams. Waiting on the other side. No sound when I cry. I love you and I need you to set me free from all of these bad dreams. Baby, please. All of these, all of these.
Tell me if there's a problem. I'd rather you let me know, so I can work on it till I can't work no more. Honey, if there's a problem, I'd rather you told the truth, to put my mind at ease when I make love to you. And I shouldn't feel like this so soon. Shouldn't feel like this so soon. Honey, if there's a problem, we can take it slow. And if you want to, baby, you can take control.
telling me all night long. Gasoline and groceries, the list goes on and on. This 9 to 5 ain't working. Why the hell do I work so hard? I can't worry about my problems. I can't take them when I'm gone. 1, here comes the 2 to the 3 to the 4. Tell them bring another round, we need plenty more. 2 stepping on the table, she don't need a dance floor. Oh my, good Lord. Someone pour me up a double shot of whiskey. They know me and Jack Daniels got a history. There's a party downtown near 5th Street. Everybody at the bar getting tipsy. Everybody at the bar getting tipsy. Everybody at the bar getting tipsy. I've been boozy since I left. I ain't changing for a check. Tell my mom I ain't forget. Woke up drunk at 10 a.m. We gon' do this shit again. Tell your girl to bring a friend. Oh Lord. 1, here comes the 2 to the 3 to the 4. Tell them bring another round, we need plenty more. 2 stepping on the table, she don't need a dance floor. Oh my, good Lord. Someone pour me up a double shot of whiskey. They know me and Jack Daniels got a history. There's a party downtown near 5th Street. Everybody at the bar getting tipsy. Everybody at the bar getting tipsy. Everybody at the bar getting tipsy. Here comes the 2 to the 3 to the 4. When it's last call and they kick us out the door. It's getting kinda late, but the ladies want some more. Oh my, good Lord. Tell them drink some. Someone pour me up a double shot of whiskey. They know me and Jack Daniels got a history. There's a party downtown near 5th Street. Everybody at the bar getting tipsy. Someone pour me up a double shot of whiskey. They know me and Jack Daniels got a history. At the bottom of a bottle, don't miss me. Everybody at the bar getting tipsy. Everybody at the bar getting tipsy. Everybody at the bar getting tipsy.
In my hands. Oh, babe, your touch, it hurts more than hangovers. No, that bottle don't hold the same regret. And my mother says that you're bad for me. Guess you never felt the highway.
Okay. Hi, everyone. Sorry for the delay. Here, there are long queues down at the bottom there, which is, we were trying to wait for more people to come, but we might as well just start. I'm Robin. I'm from Kaligo Medical. Welcome to the workshop on ABO incompatible kidney transplantation using the glycosorb ABO column. Without further ado, I'd like to introduce you to Dr. Zanet Vade, who has pioneered these treatments in South Africa since, I think, last year. Yeah.
Okay, there are my slides. She had 10 minutes for that introduction. I don't know, she could have taken a bit longer, but anyway. Okay, well, welcome, guys. I was hoping there'd be more people, to be honest, because I've been telling people I'm trying to get more people to do these ABO incompatible transplants, but hopefully the few that are here will spread the word. Okay, and in fact, I heard that there might be some gaps in the program, and hopefully I can give it to a bigger audience later on in the Congress. But so I'm just going to talk a little bit about our experience at Groote Schuur Hospital and UCT Private Hospital, where we've started doing these transplants beginning of last year. Slide forward. Is it this thing over here? The green button. Okay. Okay, it's over there. Okay, so just to start at the beginning, a little bit about the science behind it. Very little, so just to keep it basic. How do people become ABO incompatible? Firstly, the incompatible barrier, and still in a lot of people's minds now, was thought to be an absolute barrier to organ transplants. And the reason is, I mean, people say, well, you're blood group incompatible, what's that got to do with the organ? But those same blood group antigens are not only expressed on red blood cells, but on almost all cells in the body, including endothelial cells, which line, obviously, the blood vessels of all these organs. So you can get hyperacute antibody-mediated rejection from that. And the preformed anti-A or anti-B, or both what they call isohemagglutinin antibodies, develop soon after birth. So in humans who don't have that cognate antigen, by that I mean if you've got an A blood group, you will develop anti-B antibodies, and B, you'll develop anti-A, and if you've got O, you'll get A and B. And why does it happen even if you've never had a blood transfusion or organ transplant? They think it's from exposure to A and B-like antigens in the nutrients that we consume, and also bacterial infections. And like I said, they almost always will induce a hyperacute antibody-mediated rejection in a recipient who's ABA incompatible, and obviously that results in very poor outcomes. If you don't know, when we talk about hyperacute antibody-mediated rejection, we talk about rejection that happens within minutes to hours after a transplant. Okay. So people have started doing these transplants. There's a little bit of a background about the history. So as far back as the late 1980s, techniques were developed to overcome these antibodies. And initially, this involved splenectomy, plasma exchange to reduce the titer of the antibody to a level that would be safe. And a lot of this pioneering work was done in Japan because of their religion. They don't believe in deceased donor transplant. So if your only donor is a living donor and they're AB incompatible, you've got to find a way to make it work. So subsequently, it was found that rituximab, which is, as we all know, anti-CD20 monoclonal antibody, which triggers destruction of B cells, which obviously then produce the antibodies, you could safely use that instead of splenectomy, obviously, which is a lot easier to do and doesn't have that long-term consequences that splenectomy would. And plasma exchange, although was still needed to reduce the antibodies, and this technique, as anybody that's done plasma exchange and knows a little bit about it knows, is that it's a non-selective way of removing plasma, and it reduces all antibodies, and including not only antibodies, other proteins as well, including clotting factors, and you often do have clotting problems around using plasma exchange. So it's broadly immunosuppressive, and it increases the risk of clotting and infections. So that brings us to ABO immunoabsorption. So in the early 2000s, there's a Swedish company called Glycorex Transplant AB. I think they're AB, I don't know if it's from the AB incompatibility. They developed these columns, which they branded as Glycosorb ABO, which is the very columns we're going to talk about. And they contain a synthetic terminal trisaccharide A or B blood group antigen, which is covalently bound to a cephorose matrix. That's how it actually works. It's the antigen is in this column, and they develop different columns, so an anti-A column, an anti-B column, and actually an anti-AB. So you can actually do a transplant from an AB donor to an O recipient. You can remove A and B antibodies simultaneously. And they develop protocols in combination with using rituximab, and the main leader of that was a guy called Tiden. They published that, and it was mainly done at the Karolinska Institute. So just to bring us quickly now to what the circuit looks like, it's a two-stage procedure. The first one is plasma separation, like the normal plasma exchange, which you can do either with a plasma filter or actually with a centrifugal plasma exchanger. Both acceptable. However, you're going to normally separate plasma, from blood. But instead of discarding the plasma as you do with plasma exchange and then replacing with an albumin or FFP solution, you don't discard it. You run that plasma through the ABO column. I don't know if you can see on the circuit, the glycosorb column, which is there in the middle, and then the plasma goes back to the patient. So there's no replacement solution required. It's actually very nice and neat. And the only antibody you're removing is what the column is designed to remove, either A or B or A and B, if it's that column. And I've got a picture here, and you can see the two dialysis machines. there's lots of ways to set up the circuit. The one that we've adopted for simplicity is to use two standard dialysis machines. The one does the plasma, it's got a plasma filter instead of obviously a dialysis filter, and then the plasma then is run through the column, and the second machine is just there as a pump. It's only pumping the blood at 50 mils per minute, because most pumps don't run that fast. So we're using the second machine just as a pump. And then the plasma is returned to the patient with hopefully less anti-A or anti-B antibodies in it. And it's a continuous circuit, so you can run it for as long as you like. The actual column is very difficult to saturate, and you can theoretically do even a very high antibody titer can drop to an acceptable level with one very long session. So there's been various publications on this, and I'm just going to look at one large meta-analysis from 2016, which showed that they looked at various aspects. I don't know how well it shows, but on the, is this the pointer as well? No. That one? Is there a pointer in here? I'm not sure. Anyway, on the left-hand side, you can see that graph showing PEX, which is plasma exchange, on the top, and immunoabsorption at the bottom. It doesn't look like you can see a dramatic difference there, but when they compared plasma exchange to immunoabsorption, on the little table at the bottom shows that the graft survival at 1 year was 94% and plasma exchange 88%, and the patient survival was also better. So that was quite a big meta-analysis of a few thousand patients. And I mean, on the other graph, which is not, I mean, it also showed that rituximab was better than splenectomy. Okay, and there's various studies. I'm just taking this one that shows that rituximab and glycosorb, if you use that technique for your ABO-incompatible transplants, in the long term you get similar outcomes to ABO-compatible transplants. So it's actually not, you should get just as good outcomes if you do it properly. Okay, so this is how, we've developed our own protocol. I mean, looking at other protocols and tweaking it for local conditions. But this is the protocol that we've developed. So it's quite simple, really. 4 weeks before the transplant, you do your final CDC cross-match. And you must do that before you give the rituximab, because it's actually the 4 weeks before we give the rituximab, but you do your final cross-match just before that, because rituximab can interfere with the cross-match result. Okay, and you can get false positive cross-match results. And then you give the dose. It's 375 milligrams per meter squared, so a standard dose. It normally works out between 600 and 800 milligrams, and I just round it off to the nearest 100 for convenience. And then 2 weeks before we start tacrolimus and MMF, and we dose that based on weight. Even the MMF we dose on weight. We say if you've got a small patient, we give a low dose of MMF. And then 1 week before, you've got to stop your ACE inhibitor or your ARB, because you can get a reaction on patients that are on those drugs because of the column. There's an interaction, I think it's to do with the Cepheureux matrix. So flushing and anaphylactoid reactions do occur. So you've got to stop it. I think they recommend at least 5 days, but for convenience, we've said a week. And then we also check your tacro levels then, because you've been on it for a week and you should be get a reliable, steady state. And then the admission for the transplant is just the day before. So it's unlike using plasma exchange, where you might have to do multiple sessions and bring them in a week or even longer before. You can just admit the patient the day before. So if you're looking at a cost point of view, you're saving a lot of money on hospital admission and multiple plasma exchanges by just bringing the patient the day before. So then what we do is you measure your antibodies. So we've measured the antibodies initially. You measure them on the morning they come in, and then you calculate how long you're going to need, and I'll show you how you do that. And obviously, again, you'll check your tacrolimus levels and MPA levels if you want to again. So just some practical tips around this. So if you don't know how to work out plasma volume, that's the formula. It looks complicated, weight times 1 minus hematocrit times 0.065, and some people adjust it for male and female. We don't really. It's 0.065 works out to be about 1 over 15. So if you can't remember, I just weight 1 times 1 minus hematocrit divided by 15. And your plasma volume is obviously dependent on your hematocrit 1 minus the hematocrit. So the higher your hematocrit is, the lower your plasma volume is. So a good tip is to make sure your patient's got a good HB, because then your plasma volume will be smaller and it will be easier to then, quicker and more efficient to get the antibody level down. And how we work it out is basically 1 hour of immunoabsorption at the maximum rate that you're allowed you can run through the column is 50 moles per minute. So you can treat 3 liters of plasma for every hour once you've got to the maximum rate. I mean, the text will go through this in more detail in their talks. And yeah, another practical thing is always do more longer immunoabsorption to avoid needing a second session, because we have needed a second session, which is normally on the morning of surgery, which is always a bit of a scramble. And keep going with the immunoabsorption until your blood bank has confirmed that the titer is where you want it. So those are just some practical tips. Also start as early in the morning as you can, because these can go on quite long, and the techs, they get a bit anxious when it's 6 or 7 o'clock in the evening and they're still waiting for results. So, but that's, yeah, so start as early as you can. And then a last point, which I don't know if the company will agree with me, is that on average, I found that 1 plasma exchange is supposed to halve the titer, but on average, we found that you need about 2 plasma exchanges. So we've actually modified our treatment chart to reflect that. It looks complicated, but basically your target, our target that we use is a target of titer of 4. Some centers go as high as 8, some centers go as low as 2. We've gone for 4, which is pretty, I think it's pretty conservative. And if your antibody titer is 4, you don't need immunoabsorption, okay? So we've had 1 patient like that we did, and we didn't give them immunoabsorption. If it's 8, then you need to get it down to 4, and like I said, you need two plasma volumes treated. How to work out the plasma volume? It's a little formula. It's very easy. I mean, it's just got to do, if your plasma volume, if your plasma volume is 3 liters, then it's 1 hour or 2 hours in this case. But yeah, so there's an easy table there to work with. We've set our cutoff at 256, which is quite high, but you can theoretically do it even if the antibody titer is even higher. And then basically the transplant should happen within 24 hours, and it's normally even shorter than that after the titer drops to less than or equal to 4. I've talked about the induction we talked about rituximab. We use basiliximab. We don't even use ATG unless there's a concomitant HLA, DSA. The prednisone, IV methylprednisone, solumedrol dose is the standard, whatever your unit uses. We've got I sort of inherited a funny protocol of 500 the first day, 250 the second day, and 125 the third day, and we've just kept on using that. But there's I don't think there's any standard one, whichever you need high dose methylprednisolone. And then basically you've got to check your antibody titers every day for the first 10 days, and then you can be a bit more relaxed after that, up till 2 weeks. If the titer goes up to 8 and there's no signs of rejection, you can just watch. If it goes up to 16 in the first 10 days, or if it's more than 32 after 10 days, you're a bit more relaxed there. Even if there's no evidence of rejection or deteriorating graft function, then we basically will restart the immunoabsorption or plasma exchange if somehow you can only get, if you can't get immunoabsorption until the titer drops down to an acceptable level again. After 2 weeks, you can actually ignore the titer basically. The titer often can go up without causing any problems, and this is called accommodation. So accommodation is not well understood. It refers to what we call acquired resistance to immune or inflammatory reactions, and it's not only something that you see with ABO incompatibility, you can actually see it with HLA incompatibility. It's not really well understood, but there's 3 mechanisms that have been proposed. There's resistance to injury via various mechanisms, not well understood, depending on which pathways are activated, and this can limit susceptibility to ischemia, reperfusion, and rejection. And then there's either changes in the antibody, in the antigen, and how it interacts with antibodies, or the antibody itself can structurally change so that it doesn't recognize the antigen. But basically, after 2 weeks, you're almost never going to get a problem with ABO incompatibility. For rejection, you should do a biopsy, obviously, to confirm a rejection. The signs of antibody-mediated rejection are the same for ABO and HLA, and the findings on histology are the same. The C4D staining on the biopsy without any other signs of antibody-mediated rejection is not an unexpected, and actually it may be a sign of accommodation, and you don't treat for rejection. If you do think there's a rejection, you can just, again, try to remove the antibody with the immunoabsorption column. If you think it's HLA mediated, then you can't use the immunoabsorption column. You've got to use plasma exchange because you want to remove an HLA antibody, which that won't. And I mean, I don't know how often this is done, and we certainly haven't done it. If it's somehow resistant to using immunoabsorption, then you can do splenectomy. It's a option, but I think that would be quite an extreme option. And a little footnote, if they require FFP for any reason in the first 4 weeks, is the recommendation, you shouldn't give them their own blood group FFP, because that would contain antibodies against the organ, okay, because it's ABO incompatible. The safest to give FFP from an AB donor which has got no anti-A or anti-B antibodies. There are other permutations which would make it safe, but it's actually quite difficult to explain and understand. So the safest is to just give FFP from an AB donor which has got no anti-A and no anti-B antibodies. Otherwise, you can actually induce rejection by giving that FFP. But if they require blood transfusion, you must give them the recipient their own blood group, pack cells. Okay, so we published our first experiences last year after the first 3 cases. But since then, since January last year, we've done 10 cases at the 2 centers, 4 at Groote and 6 at UCT. And just to say, 1 patient did develop rejection, and we'll talk about that case, and actually lost the graft. And we've had one death with a functional graft. So overall, I think the outcomes are reasonably good. And the ones, besides for those 2 patients, the other patients have very good GFRs. We did see an unexpected high incidence of urological complications, especially in the first few patients, which we still can't really explain. And because of that, we have seen quite a high incidence of recurrent urinary tract infections. So this is just a table of the patients, the 10 patients we've done so far. This is their creatinines. You can see they obviously all come in with high creatinines. The one, that reddish color, I think it's patient 8, had some delayed graft function and then recovered. The light blue one with the up and down spikes in creatinine was the one that rejected. And the one patient actually died at day 6. I'll tell you about that. You can see that's the one over there. So these are the immunoabsorption sessions. There was 1 patient that needed no immunoabsorption. I told you the one that came in with a low antibody. 5 only needed 1 session on the day before the transplant. 1 patient needed a 2nd session only on the morning of transplant, but 2 patients needed 3 sessions, including a 2nd session on the morning of the transplant, and the 1 patient needed 4 sessions, and he's the guy that actually ended up rejecting. So these are the antibody titers. It's a bit confusing. This is a log table. So when you see 0, that means a titer of 1. When you see 2, that's a titer of 4. And so you can see that's our target titer. Everybody got down to that level on the day of surgery. And then the ones that went up, we had to immunoabsorb further. And the one in blue is the one, like I said, that ended up rejecting, that we couldn't control. So this is the patient we're talking about. So just be aware of this kind of scenario. It was our 4th patient. So after that publication in the SAMJ, all went well until day 7. And the creatinine had come down to 150, and the antibody titer was nice and low. But then the patient developed oliguria and anuria, and we biopsied the patient immediately. And it showed that he actually had an extensive graft pyelonephritis with C4D staining, but no signs of rejection. So we thought, okay, he's got graft pyelonephritis, and actually then subsequently the blood cultures became positive, and he had a Acinetobacter. And actually, there was a patient that came from Port Elizabeth, and he'd had lots of bladder issues, and he probably had a latent bladder infection when we transplanted him, but he wasn't passing much urine, and we didn't know about it. So this is the one thing. I think you need to make sure that your patients don't have unsuspected urological problems and latent infections. So we treated him with antibiotics, and we started dialysis because he actually required dialysis. But then on day 9, his antibody titers started to rise, and we did an immunoabsorption session. Despite that, on day 10, it was up further, and we did another session. But on day 11, which happened to be on a Saturday, his antibody titers had shot up extremely high. And we actually didn't have a tech available that could do immunoabsorption because all the techs weren't trained. And this is part of what we're doing here. We want to make sure that we have enough techs that know how to do this. And we didn't think that plasma exchange was going to have any effect because immunoabsorption hadn't. And the immunoabsorption is much more efficient. So it was a matter of, are we going to do plasma exchange in somebody that's septic? And it's probably not going to work. So we opted not to do that. And in fact, the patient, and we also didn't want to do splenectomy for the same reason. So he recovered, and he fully recovered from his sepsis, but he stayed dialysis dependent. So we repeated the biopsy, and it showed he had extensive necrosis of his graft, which was in keeping with severe antibody-mediated rejection. And I mean, he had a nephrectomy. So that's the one case and this is actually well described. I mean, it can happen later, but obviously also earlier, where and it can occur at any stage really, but a septic event can basically trigger a rejection event, and it's thought that it's related to a rapid increase in IgM cross-reacting antibodies, and that induces rejection. So an infection makes you make antibodies which are then anti-A or anti-B-like, and they can induce rejection. The second case was our last case, unfortunately, a month ago. He was again doing well until day 5. He had no issues. In fact, we took out his temporary dialysis catheter. He was a PD patient, so we thought, okay, that's going to be a septic, possible source of sepsis. His antibody levels stayed low. But after we took it out, he suddenly became very short of breath. And we thought, okay, has he had an air embolus or something like that? But when we actually did a CT scan and CTPA, there was no, or pulmonary embolus, but there was no air or pulmonary embolus, but he had diffuse lung infiltrates and, in fact, needed high-flow nasal oxygen. And he was coping with that, and in the middle of the night, suddenly arrested. And then we found out the next day that his swab was positive for COVID. So that's just a month ago. So just remember, COVID is still around. And then subsequently, we also found out he'd refused COVID vaccination. So, and again, from out of town. So you don't always get the full story when patients come. Also, unfortunately, from the Port Elizabeth area. So, yeah, we haven't had good luck with our PE patients. Sorry if there's anybody from PE over here. So the two that didn't work out were both from PE. And again, if you look at some meta-analysis of ABO incompatible outcomes, so this was actually done using the plasma exchange, which is now a bit more immunosuppressive because the reasons I've mentioned, that if you look at ABO compatible versus ABO compatible, this is 26 single-center studies where they compared them. You can see the graft survival at 1 year is pretty similar, but infectious cause of death is much higher with ABO incompatible transplants using plasma exchange. There's more antibody-mediated rejection, and there's more non-viral infections. So that brings us then to who would you consider doing this on? Okay, it's obviously not for everybody, but I would say the first one, and maybe the most common one, would be if you don't have an ABO-compatible donor and you're unlikely to receive a donor on a cadaver, on a deceased donor waiting list in the next year or so. Because obviously the longer the patient's on dialysis, the less well they're going to do in the long term when they do have their transplant. And that's especially as we in South Africa don't have a functional KPD, kidney pair donation program available. Because if you do, that's the best option. It doesn't help your O donors that much, your O recipients, because O recipients, you'll struggle on any program to find an O donor for them. The other option is if you've got an ABO-compatible donor, but they're highly sensitized and would need plasma exchange. And the final one, which is similar, is that you've got your ABO-incompatible donor is a good or an identical match. so likely to give you better outcomes in the long term. Because remember, the rejection is a short-term issue with ABO incompatibility. I don't know if I've got a few minutes. I think I'm going to just go through some examples of patients that we've had. I think this was the third patient we did. So her treating nephrologist was from Christian Barnard, one of our neighboring hospitals, asked me what do I think about doing this transplant? So it's a lady, she was about 40 at the time. She'd had a transplant previously from her uncle. And then she had a pregnancy, and she actually rejected just after the pregnancy. I don't know the circumstances around that. But now she's back on dialysis, and she wants another transplant. And her aunt, now the uncle's brother, offers to donate a kidney. And I don't know if you can tell without pointer now, so firstly, if you look, it says patient aunt on the table. Then it says ABO, blood group 00, so they're compatible, right? If you look at it's ABC and DP, DQR, and DPQR and PQR, all three of them, yeah. I can't see. Let's look over there. It's quite small. There's only a 5 out of 12 mismatch, but she's got 3 DSAs, the B07, the DR15, and the DQ6. And they're all fairly high MFIs. So she's got 3 donor-specific antibodies in a class 1 and class 2. And then if you look at the T-cell cross-match is negative, but the CDC B-cell cross-match is positive. And actually, it's not on this table, she had a flow cytometry cross-match, and they were both positive. So this is very high immunological risk, high HLA. I mean, most people would not want to do this transplant because of that. Despite being, you can see they're actually quite a good match, but the mismatch and the DSAs are the problem. So she actually came to see me, and I said, okay, well, yeah, we can do the transplant, but you're going to always be very high risk of rejection. But do you have a sibling, maybe, that could donate to your kidney? She says, yeah, but I was told that they're the wrong blood group. So this is the sibling. So we test the sibling. It's a sister. And now you see the sister's got blood group A. Also a 5 out of 12 mismatch, equally good as the aunt, but only 1 DSA. And CDC T and B cell cross-match negative, and flow cytometry T and B cell negative. So from an HLA point of view, I mean, I think we can all agree, people that have an idea, is that from an HLA point of view, it's a much better match in the long term. But there's that ABO incompatibility. Her antibody titer, I can't remember, I think it was quite high, like 256, it was quite high. But we said, look, I think it's something that we should do in the long term. This will be a better transplant for you. So we gave her rituximab, and when she came back for the transplant, the titer was 16. And we did the immunoabsorption, and I mean, she in fact did need, I think she was the one that needed 3 sessions in the end. But she's over a year post-transplant, she's got a creatinine of 75, and she's happy. I mean, she's got a transplant. And she should, I mean, and even that donor-specific antibody, it was quite high, it was 10,000. We opted not to do plasma exchange, and now I think it's like at about 2,000 or 3,000, the MFI. So, I mean, that's one example. This is one that a transplant we haven't done at Groote. So this is a patient, she had 4 potential donors come, okay? So we're lucky we can test multiple donors. So her brother, her daughter, her friend, and her husband all offered to donate. Now the brother is ABO incompatible, she's B and he's AB. All the other 3 are compatible, okay? But all the other 3 have donor-specific antibodies, which are quite high, like the MFI B07 of 7,000, and the other one in the C is 9,000. Okay, C is not as strong an antigen, but she's got DSAs against all 3. Now the brother, before we wouldn't have tested the brother further. We would have just said ABO incompatible, don't test. But now we test the brother, and his HLA identical. And if you guys can see that, okay. So for us, the brother is the best match. Is ABO incompatible, but is HLA identical. So we are actually going to transplant using the brother. She's also got quite, I mean, a lot of class 1 antibodies, and an anti-A titer is 64. It's not extremely high. So, and we've actually seen this with, when we looked at our transplant coordinators, they went back and looked at the last 5 or 6 years of donors, all the donors, and about 1/3 of donors were turned down because they were ABO incompatible? And how many of them would have been actually a very good option as a donor if you had this option to do an ABO incompatible transplant? Okay, so in the end, to do an ABO incompatible transplant, you only need of these 4 things. You need rituximab, which we can get. You need to be able to do your isohemagglutinin titer, which we fortunately at Crediskia, I mean, we can do it. We have an on-site blood bank and we can get a result within an hour or 2. I mean, you don't need it that quickly, but if you can get it the same day, that's great. The earlier the better if you need to do the immunoabsorption post-transplant. And then you need the columns, which fortunately now are being imported. And you need, what we're going to find out next in the next couple of talks is how to do it. And without a technologist that knows how to do it, then you're going to be stuck. So I'm going to hand over the tech. So we've got Daniel there. So this is just when we did the first one, the company in Sweden wanted to put out a press release because I didn't even know. We were the first people in Africa to use their column. And then our hospital media people, public relations people said, okay, well, we want to make a story out of it. So then they made a story out of it. That's the first recipient. She's happy to have a picture because it was in the papers. And Daniel was the first tech. And that's the column. It's a tiny little thing like that. I think have you got some? Yeah, you can have a look at it. So they're going to show you now how to set up the circuit. And thank you to our coordinators, our technologists, and obviously the blood bank, because you can't do it without these people. But they're going to show you how to set up the circuit and how to do it. Hopefully, the techs here will have a good idea. But I'm sure these guys, especially in private, can travel, and if you want to, they can come to you and do it with you in person. Okay, that's it. Any questions? My time is up, it says, yeah. Okay, Indran, yeah. Roving mic? Just a question. I think.
Thanks, Zunaid, for a very clear talk and a nice, clear protocol. Do you continue measuring the titers following a successful transplant, or do you stop, and when do you stop?
After 2 weeks, we stop.
You stop.
It can go up very high. There's no... It's just going to make you anxious, why check it? And somebody had asked me last night, it was Eugene, do we do protocol biopsies? And I said no. I mean, if the creatinine's fine, then...
And no problem from the medical aids?
It does take a little bit more motivation. That's why the transplant coordinator's names are there. The one is in private, so she's also quite keen that other people do it, so she doesn't have to fight with medical aids. But so it took us a while, but Discovery is actually, which is obviously, as you guys know, the biggest medical aid. They're running a pilot program. So at the moment, on their pilot program, it can only be done at UCD Private Hospital and at Wits Donald Gordon. I don't think Wits Donald Gordon's done any kidney ABO kidney transplants, only livers. But I mean, I wish more of them were here because the livers are not. I mean, the kidneys are not that difficult. Yeah.
Thanks, Zunaid. Fantastic talk. I'm quite excited with what you've actually discussed yesterday. Just want to know if you've got patients who are sensitized. And you say you got multiple donors. You have a donor that's sensitized, another donor that is ABO incompatible, but also, can be a donor. How do you decide that, this sensitized patient is actually better than this sort of ABO incompatible? What cutoff do you use in terms of DSA, to decide okay, the sensitized patient, we'd rather go that route of actually desensitizing this patient, or you know what, okay, I've got to reach a certain level, let's just do the ABO.
Yeah, I mean, it's a good question. There isn't like the one that we ended up doing. She did have a DSA 1, but so it's all degrees. I mean, there isn't an absolute MFI cutoff, I would say, but 3 DSAs across class 1 and class 2 is definitely worse than only 1 DSA. And from an HLA sensitization point of view, I mean, we all know that the most common cause of long-term graft loss is chronic antibody-mediated rejection. So if you're going to go into a transplant when you know that that's going to be the outcome in the end, when you've got a non-HLA sensitized but ABO incompatible donor, then I would always pick that one, like that last example.
Okay. If you've got a patient that you're doing an incompatible sort of transplant, is there HLA match or mismatch minimum that you would look at, or maximum that you would look at? Do you say you've got 3 out of 6 mismatch, we can go ahead, or 2?
No, as long as they don't have a pre-existing DSA, that would be fine.
Okay.
Yeah, I mean,
Okay, thanks.
yeah. Okay, I don't know if there's anybody else that's got questions. I mean, hopefully there'll be more questions to the text. I don't know if you guys want to, are you guys going to just do a demonstration, or are you going to do a talk? Okay.
Thanks, Dr. Bade. So I was going to just run through the really basics of the column now and practical aspects, and then we'll hand over to Daniel and Walter. Some of my information is a repeat of what Dr. Bade has mentioned, and it's, as I said, it's the basics of the column. So I'll go through a few slides quickly. So, as Dr. Bade mentioned, cause of ABI incompatibility is your anti-A and or anti-B, IgG and IgM antibodies, which makes up less than 1% of the total amount of antibodies. And the glycosorb column specifically reduces these antibodies and does not, and gives the rest of the plasma back to the patient, so you're not having to replace fluids or anything like that. This column facilitates transplantation across the blood group barrier in not only kidney, but increasingly liver, lung, heart, and stem cell transplants, which is quite exciting. It's been used for over 20 years in clinical practice all over the world. We have 3 types of columns: an A column, a B column, and an AB column. And each column binds specifically the antibodies of its name. So the A column will bind your anti-A antibodies, B, your anti-B antibodies, etc. In terms of which glycosorb ABO column to use, this is just a table to basically indicate if your donor blood type is A, for instance, and your recipient's O or B, then you'll use the A column to bind your anti-A antibodies, and so forth, as you can see. So the actual column, we have a dummy column that will be used in the demonstration. It doesn't have the label on it, but it's the exact same size, so you can just see it is quite small. But it's made up of a transparent plastic housing with openings for inflow and outflow of plasma. It's filled with biologically active carbohydrates, being your blood group A and or B antigens, connected to an agarose matrix. So Dr. Bade mentioned Cepharose, but it's just the trade name for agarose. It's the same thing. And this matrix is held in place by 2 mesh filters at the inlet and the outlet of the column. There are no chemicals or preservatives or anything inside the column. So just to show you briefly, just a short illustration, as the plasma flows through the column, it will specifically bind to those, and the rest of the plasma will then go back into the circuit and be returned to the patient. So because of the specific binding, there will be no significant effect on any coagulation factors, and there will be no unspecific absorption of protein. In terms of titers, as Dr. Bade mentioned, based on the data from the company, from Glycorix, they say that it's normally reduced by up to 1 titer step per treated patient plasma volume, but we found that it depends entirely on individual patients, and it has differed in our experience here in South Africa. Rebound may occur either due to extravascular antibodies or subclinical infection, and the patients then may require longer treatment or additional treatments, as also mentioned. This is just an illustration to show as the treatment progresses, how it starts treating more and more of the antibodies. So once it's treated all the intravascular antibodies, and the extravascular antibodies then move into the vasculature, and that gets treated as well. And the longer the treatment, the more antibodies are taken out. So during the setup, during the treatment, it's used in conjunction with a plasma separator, either filter-based or centrifugal. Maximum plasma flow rate through the column is at 50 moles per minute, which means you can treat up to 3 liters of plasma per hour. The column is not saturable, so therefore you can run extended treatments. And overseas, some places they've run up to 20 hours or so of one session, one column. And then obviously no fluid replacements are required. And then just the treatment overview, which was gone through. So again, specific removal of anti-A or anti-B antibodies. But once the plasma is separated, then that plasma flows upwards through the column. And then it gets put back into, once it's treated, gets returned back to the patient, and no fluid replacements again. And then it can be used with a wide variety of hemodialysis machines. We've done different setups on the 4008S machine. I'll show you that now. We've also done in South Africa so far the Optia. We've been trained at a center on the multifiltrate. So it can be used with any dialysis machine, pretty much. So today we'll do the setup using the 2 4008S machines. So I just put an image of the different setups we have performed in the country. So the first one is what we will do today, which is what I just mentioned, where the first machine will act as the blood pump, and the second machine will drive the plasma through the column at a much lower flow rate. And then the second image is we've used the 4008 machine as the blood pump, and 3 infusion pumps to drive the plasma through the column instead of using a second machine. This does come with a few challenges, because sometimes the one infusion pump will alarm, then you have to try and figure out, change the flows, and so it's a little bit simpler to use both machines. And then the third one we've performed here at Wits Gordon on the liver cases with the Optia machine. This is also a little bit limiting, because you can only treat a total of 4 blood volumes in one session, and then you have to switch out the machine with a new set and then transfer the column. So you can't run an extended treatment if you'd like to. And that's basically the gist of the column. And then I'll hand over to Walter and Daniel, and they will take you through the setup.
Good morning, everyone. So this presentation is going to be a bit technical, but I hope we're going to learn how to do the setup and also prime. And lastly, we're also going to learn how to monitor the treatment. So Walter is going to be here with us showing how to set up the machines, but I'll also display some few instructions. I don't know if you can see, or you want to come a bit closer? Yes. Okay, cool. shout and say shout out to Umlani. Yes. All right, so basically, like already there's been some talk this morning about how to use different machines to do the same procedure. This time we're going to use 2 machines. So you will use the first machine as the blood pump. So the first step is to test 2 machines like you normally do. We just connect to the water supply. I mean, unfortunately, we don't have a water supply here. So normally we test the machines, and then after testing them, then you don't need water anymore. You can just put the flows off, and then you will proceed to the next part. But now let us wait for Walter to just line the first machine. So normally what we do, we put heparin in the bag of saline to prime the filter with. So we've got that P2 dry filter. So we use 5,000 IU heparin in a bag of 1 liter saline. Even if a patient does not need heparin, but please prime the filter with heparinized saline, but you can rather rinse it out just to make sure the filter is coated with heparin. It's very important. Otherwise, you're going to have problems whereby the filter is going to be clotted and you're going to have blood leakage from the membranes.
So unfortunately, because we don't have the water supply, we won't be able to test the machine. So we're just going to run it using gravity.
Okay, cool. So we covered the first step and the second step, and then we can proceed to third step that is currently busy with. You can also do simultaneously. While the other machine is busy priming, you can also proceed to the second machine. But we like to use pediatric lines in the second machines because the second machine is actually just a pump to pump out the patient's plasma from the filter to pass it through the column. As you can see that blue arrow there, light blue arrow, and then the plasma is going to go back to the patient again. So the plasma will come out from the filter, drawn by the second machine at a very slow blood flow, but actually it's a plasma moving out there. Maximum not exceeding 50 mils per minute. And then it's going to pass through the column, and then it will go back to the patient there by the venous chamber of the first machine. So regarding the second machine, like I said, you need to use the pediatric lines. So you may need to adjust the pump segment. Normally the adult lines have got, I think is it 8.0? Then you need to reduce, I think, to 6.4, the pump segment. Otherwise, when this pump propels the blood and you are using the pediatric lines, you might end up not getting adequate blood flows. So make sure that if you're using different lines, you change the pump segment. But you can always also undo that when you're done. Otherwise, it's going to cause hemolysis when you're putting adult lines and the setup is meant for pediatrics. The difference in the blood volumes of the lines, I think it's about 50 mils. I think one has got 160 something mils, other one has got 111. So, but it does make a difference. I mean, 50 mils of plasma out of the body is a lot at once. And then it might also, if you are actually using we don't like to use the IVEX because we're going to need to have 3 of them to maximize the blood flow and plasma flow because an IVEC normally runs at a rate of 1 liter per hour, right? And then for you want to target running 50 mils per minute, which is 3 liters per hour, which means we're going to need to have 3 IVECs in that case. So now, if we're going to have 3 pumps to pump the plasma out from the first machine, sometimes the pumps, they do alarm a lot, and also you might have 2 very, very long connections now. We don't want that, whereby now patient's plasma is so much outside of the blood that might cause clotting as well. Another advantage of using this procedure, I think Walter has done it already, you can, whereby you can do, yes. Yeah, okay, cool. Yes, yeah, correct. So he just primed the arterial line, make sure there's no air in it. Otherwise, the column has got fluid inside. Yes, pre-filled. So now if you connect here, like dry line, you're gonna really take away the space, the surface area, because it's gonna be filled with the air instead of being filled with saline. So it's very important that you actually prime it very slowly. I emphasize there in red, you prime it very slowly. It takes about 30 minutes to prime that column. Why 30 minutes? Because you will start very slowly. You will start as slowly as 15 mils per minute, right? For 5 minutes, right? Another 5 minutes, 20 mils per minute. Another 5 minutes, right, to get 250. So it's a very slow process. Otherwise, if you're going to do it very fast, you might actually cause like a rapid movement of the air inside the column, and then we're going to reduce the surface area of the column. They don't get as much clearance as you want. So it is very important that we monitor that it is done slowly. So in our setting, it is normally done by 2 people, just to make sure we also check on each other if we're not rushing too fast and with the timer. Yes. Yes, okay.
Just on a small practical point, how long does it take to get to 50 mils per minute? You said about
5 minutes.
No, but from the start to 50 mils?
It's about maybe 20 minutes plus.
Okay, so don't count the first 20 minutes. Only once you get to the maximum, then that's when we've pre-calculated you're going to need 2 hours or 3 hours or 5 hours or 7, whatever it is, and then you start counting from there. So then a practical point, when you get to what you've pre-calculated, how long you're going to need, then you pull your sample, send it to the blood bank, hopefully get your result within an hour, but keep going, as long as possible, because, I mean, obviously, if you're going to have to come back tomorrow and do another session, that's a big cost, for your institution, and it's always then a rush on the morning of surgery. So we've done that. We're in the patient, the donor's in theater. We're busy doing immunoabsorption on the recipient while the donor's in theater, and then but it's if you can avoid it, just do longer session and you'll be fine. Yeah.
Thank you for that. So with the second machine, you don't need to put heparin on the saline. You just prime with normal saline. It's only the first machine that you will need to put heparin so that you will prime the plasma filter with heparinized saline. So it will take Walter to prime this machine 30 minutes, so we're going to have to wait. Yeah, just to remember again, I said we're going to prime with 15 mils per minute, go up gradually to 20 mils per minute, after 5 minutes, right to 50, right? At the meantime, maybe I want us to relook at estimation for the treatment. Although there'll be other talk tomorrow, that's going to be a bit thorough in terms of the calculations and the duration of treatment, but just to get an idea how long the treatment will be. It will depend on the antibody titer of the patient. That's the first thing. Secondly, it will also depend on the patient's plasma volume, right? So just for the sake of this practical, we're going to assume that the patient has got the plasma volume of 3 liters. So in that case, because we can run 50 mils per minute, so we are able to run 3 liters per hour. So we are able to treat 1 plasma volume per hour in this case. Is it fine? Now let's say a patient is a bit maybe bigger or has got higher plasma volume, then we're actually going to take more time to actually treat 1 plasma volume. Say for instance, one's got a plasma volume of 4.5 liters, and here we can only treat 3 liters per hour, which means it's going to take us 1 hour and 30 minutes to treat only 1 plasma volume, right? Is that clear? So if now one has got if we need to treat, let's say 7 plasma volumes, and one has got a plasma volume of 4.5 liters, and for you it takes you 1.5 hours to treat 1 plasma volume, which means you're going to have a very long session of treatment in that case. We have to say 1.5. If a session should be 7 plasma volume, we have to say 1.5 times 7. That's the number of hours we're going to need to put a patient on. All right.
It's done now. So I don't know if you want to come closer and have a look.
Yeah, it's a lot of simulation, so don't mind the micro air bubbles. Cool.
So with the arterial line, we'll be drawing the plasma from the plasma flux, go into the second machine, and it's going to return via the host or column, via the blue line. And it has to be back to the venous line, back to the patient. So you've got a special adapter for the heart. Yes, extremely specific. Okay. So, because of this circuit comes a standard. So, that will be coming with the conditional criteria. So, this and this column here, selection here, because this is standard, you need this tubing here to connect to the column. This comes with the columns.
I think normally if you've got the lines, the only thing you're going to need is this thing called Hansen connector, right? That's only a bit of a challenge to get it, but yeah, the rest just comes standard because you've got your HD lines in the unit, also got, the connections, just that only part that you might need to buy separately. Also, the company supplies you with the connection that connects the column. So any question? As you can all see, just once again,
This is for the blood flows, right? From the patient, as per normal. From the patient to the blood pump, and the bubble trap, venous, back to the patient. All right? So this is from the plasma flux, draws the plasma out to the second machine, blood pump, go the arterial line, all the way to the blood pump again, go to the trap, go to those, to the column, absorbs all the antibodies from there, venous chamber, after venous chamber, goes back into the blood, going back to the patient. You don't have to switch because you're not going to be running the dialysis here. You switch it off. Dialysis goes off, so you have to do that. And the Hansen connector, we just keep them.
You're setting it up on this one.
I think was too
So that's
fast.
the only thing you set up on this one.
On the machine.
Okay.
Just go down. Yeah, thanks. Okay. So we've learned to prime now. I think we can proceed to the treatment.
Yeah, told them about the pump.
Yes. Yeah. Sure. Yeah. I hope.
The maximum responsibility on the is 250. Okay.
Okay.
Oh, you can still use this. We have used it with the other lines.
Yes. So this is the second one whereby you can actually use the pediatric lines. Something's dripping. So we may need to adjust the palm segment in this case, but I don't want to change it because it's not imaging. Then you might need to reduce it. Normally it's 0.8 for adult lines. I think for pediatric it's 0.65. So, yeah, something like that, yeah. But you just need to adjust that accordingly so you don't have so much plasma of the patient outside of the body. Comparing this line to this one, I mean the pediatric lines to these ones, you are saving about 50 mils. Yeah? So it's got about 50 mils less than adults one, yeah. So that's it.
And we can also have the dialysis at the same time.
Yes, I wanted to mention that actually.
Yeah.
Yeah.
You can do the dialysis and the plasma exchange at the same time.
Yeah, but I wouldn't recommend that. But you can do it, but not the best thing. Reason being, we're going to put a dialyzer here. We're going to put a dialyzer here.
This is a plasma filter. Yeah.
Just, yeah. Here. Yes.
I don't know if Robin, you want to put that picture up there? The three machine. Yeah. Material line will go through your dialyzer. And after the dialyzer, you will have your interdialyzer. The line that goes in between the filter and the dialyzer. Then you have your dialysis.
Just think of
So
patients.
you either you do the dialysis the day before the IVO transplant, or just have it all together the day before the transplant.
Just dialyzing,
Yeah.
plasma exchanging, and even absorbing. It's
Yes. Yeah.
and then
Okay, there's a display here.
Okay. You can see the picture there in the middle. There is a filter there. And the plasma flux on top. Yeah.
And the other practical thing is that is it on the second machine where you can see how much
Yes.
plasma plasma you've treated.
Yes, but I can't test it at the moment.
Yeah,
unfortunately.
they can't show you now, but you can look at how much plasma has gone through, so you can work out if it's matching your calculation how much plasma volume you want to treat. Yeah. Yeah.
Yeah, okay. Yes. I think I can go back again to the slide. Go back again to the other slide. Yes.
Can we do this on
Yes.
a normal multi-filtration machine?
Yes, yeah, yes, but you have to do some special balancing whereby you actually tell the machine that you are running at a particular rate, like 50 mils per minute, but then you have to put bags that just even put water. And then you let the bags, instead of going to the patient, they go to a drainage. Yes, but sometimes when they balance, yeah, imbalance. Yeah.
Because because we don't have any filtration, nothing's coming out. So this is where you want to come into.
Machine that can do this.
But it's doable. It's doable with a multifiltrate. The cost, yeah, there's the lady.
I mean, if you look at doing, it depends on how high your antibodies are, but I mean, on average, you're going to need 3, 4, 5 plasma exchange sessions. That's also got a cost. You're going to need an extra week in hospital. That's also got a cost. I mean, literally, these ones, I admit the patient the day before the transplant, like normal. I mean, sometimes we admit them at midday, but now we admit them in the morning. That's it. So, I mean, how much are you saving on cost on days in hospital, multiple plasma exchange sessions? You just do one session.
But what's the average cost?
The column itself cost about, I think, 60,000 rand. But I mean, 60,000 rand is like not even 2 months of dialysis. I mean, there's nothing, if you can get a patient off dialysis, that's saving you a lot of money. Yeah?
Yeah. Yeah, that's my dad. Sure. That's my All right, let us proceed to finalization of the treatment now. There's few things to mention under treatment. Thank you so much. Okay, so now let us speak about the actual therapy now. So there's few instructions also to follow there. So the first one, you need to start the first machine slowly as usual until you reach your target blood flow. You need to get to a blood flow of at least 250 mils per minute. So if you can't get to that, which means you're going to actually even have a longer session. But I'll explain that shortly. And then you also need to give the patient heparin bolus. We normally give something like 4,000 or 5,000 IU as a bolus. And then we maintain it with something like 1,000 IU per hour. But as a rate, you can actually personalize it and then adjust it accordingly. And then also, we're going to try to improve our protocol whereby maybe we're going to stop giving patient heparin at least 8 hours before the transplant. But for now, we've just been checking the ACTs there and there. And then, once you've reached your target blood flow on the first machine, only then you need to start your second machine. All right, so don't start the second machine while you haven't reached your target blood flow on the first one. And then on the second machine, you need to start it slowly again as the way you primed it. You need to start it slowly as 15 mils per minute and go up slowly every 5 minutes. Right up to 20 to 25, maximum 50 mils per minute. I mentioned there in red, not exceeding 20% of the blood flow of the first machine. So which means if you cannot reach the blood flow of 250, you can't run it at 50 mils per minute. So you have to run it a bit slowly. And then of course, which means you're going to treat less plasma per hour if you are running it a bit slowly. So it's very important that you try by all means to get a blood flow as fast as 250. I think, so for some people can see on the diagram here, I think we managed to get something like 250 there, 240. So actually we're able to reach 250. Yeah. So that's when now we're able to run the second machine at a maximum flow of 50 mils per minute. Again, we need to monitor the machines for all the alarms. Maybe Walter want to talk about most common alarms?
The most common alarms here is obviously with the plasma exchange, you need to be very careful of the blood leak. Because with the multifiltrate, it comes with a blood leak sensor. Here, we don't have a blood leak sensor, you just got to be there next to the patient monitoring the filter. And clotting. So that's why you need to do your ACTs and just making sure that the plasma flux is still okay. Plasma filter. Never changed it before.
Okay, no, it's fine. So also depending on the duration of the treatment. So if going to have a very long treatment and maybe a patient got high clotting factors, you might find that you might need to change the filter, the plasma filter, not the column, maybe after 4 or 5 hours, and then you continue again. So advantage of having this circuit is that it is very easy to change the set. Even if you need to change it 3 times, you can change it. It's not as costly as when you're using, the Optia, right? Because this is just normal HD circuit with just an extra plasma filter. But normally, we haven't changed them more than once, actually just more than twice, I mean. So in most cases, it runs well with just one plasma filter for up to 6 hours. I think there's one session that we ran, it was 11 hours, and it ran nicely without any clotting factors. I don't know if Dr. Padiwana mentioned about it, bleeding or any issues.
Yeah, I mean, maybe just to say, if you do long sessions and there's lots of heparin that the patient might have got, obviously you might want to check your PGT or your whichever, if you've got a TEG or whatever, the next morning and see if there's any clotting abnormalities you might have. So that's a practical point. He hasn't gotten there, but I see on point 6, discontinued therapy after your target of 2. I mean, our target for surgery is 4. But like Robin mentioned, sometimes you do get a rebound overnight. So what I do is, if it's 4, when we send the sample to the blood bank and we've kept the circuit running for an hour or 2, I can assume it's going to be 2, by the time they disconnect. And then they send another sample to check it, and then we check it the next morning as well. So if it's 4 and you've run and it's hopefully 2 the next morning, and it might be up to 4, it might not the next morning if there's a bit of rebound. But yeah, so it's, those are little practical steps, but if you want to make sure that the titer is down.
I don't know if I want to mention anything about using citrate, because in other machine, not this one, we can also use citrate. How do you feel about using citrate in this treatment overall?
Okay, so when you use the Optia machine, they normally like using citrate anticoagulation. Personally, I'm not that familiar with using that form. I mean, maybe people that use citrate regional anticoagulation will have a better idea. But the issue with using citrate is normally, even on the Optia machine, which is the centrifugal machine, a lot of the citrate is lost discarded in the ultrafiltrate. Here, there's no loss of fluid, so you can actually get an accumulation of citrate. And like Robin mentioned, I think that it's only set to run for a certain number of plasma volumes or blood volumes, whereas for this you might want to go for longer. So I think you should find a system that your techs know and that you know, and that you get familiar with. I mean, we've adopted this system and we're comfortable, so we don't really want to change to other systems where there might be other unexpected issues. So we haven't gone with the Optia machine.
Thank you. Yeah, just to mention that we also got an option to use Optia. At that time when we began this, we never had Optia, but now thanks that we have got an Optia machine to use it. But I haven't really looked closely as to how we're going to, in future, use one machine that's got designed actually for this treatment, not improvise. But just to mention a few things that maybe is something we're looking forward to, is the improvement in the anticoagulation. Because now with the Optia, you are only allowed to use citrate. And then think about the number of treatments going to actually have here. It's going to actually result sometimes in accumulation of the citrate in the patient's blood. You might actually have hypocalcemia, which I think is more concerning. You don't want the patient to go to theater with low calcium. Very rarely, you can actually also have pH changing to become a bit high. So we're trying to avoid doing very long session anyway, if we're going to use the citrate. So at the moment, we are trying to get the protocol that involves using heparin in the citrate machine. The company doesn't really allow that to do that, but they've done some research. So once we have found that, you will be able to actually try to use combination of citrate, and then we use heparin. So, because normally what happens is this. With the Optia machine, if we reduce the citrate going to the patient, the circuit might clot, all right? But if we run it normally for very long, we're going to have hypocalcemia. So we're going to avoid that by actually giving patient heparin, so that even though we're running citrate slowly, it doesn't actually clot. Yeah, so but we're going to work on it. Yeah, so thanks to Dr. Day, I think we covered that part. That I think if the ISO hemagglutinin levels reach 1:4, 1 in 4 is happy with that. How about 1 in 8? Are you happy or not?
The other point I wanted to make is that you do the titer test while the patient is still on the machine. And before you get the results, you must still continue treatment. Only once the titers have come down to 1.1 to 4, only then you can stop. If not, you just continue.
Yeah, thanks for that. I think that point number 7 as well, that is going to be checked in the morning of transplant, so it must leave the machines almost ready to do a short session in the morning. That will be very unlikely to be done with heparin because the patient must go to theater, so must just need to flush the second and the circuit more often. And then I want to speak about the, not complications, but maybe small side effects that are related to the treatment, not the column necessarily, right? Firstly, when you see the blood pressure dropping, it's very unlikely because it's a closed circuit, right? And you're not removing any fluid. So if you're going to combine it with dialysis, that's when you might see the blood pressure changes, so of which I don't really recommend. And then that's the first thing. And then patient might also have a drop in temperature. I mean, you cannot just rely on the ambient temperature, whereby if it's a cold day, there's no warmer in the circuit, the patient's gonna feel cold. So that's why we see you improvise there. We put a Prismaflex warmer there, just to warm patient's blood. You can see that green machine. It's got an insulator of the returning blood to the patient. So just to minimize the complications. But actually never had any serious complication related to the treatment. Yeah, thank you. Any other question?
The risks, the multifiltrate can be actually an option. Oh, okay, I was saying I understand here the cost effectiveness. I understand that. But when we weigh with the risk maybe of running one machine, have you tried using the multifiltrate and how are the outcome of that?
Simulated using multifiltrate, but never actually done the treatment. You must just remember that you need extra connections so that people will want to say something.
With a multifiltrate, you're talking about the cost? Yes, you can run it with one machine. The same way you can run with one machine, but you're going to have the infusion pumps. This is just one of the options. Multifiltrate, one machine, 2 machines, or one of these machines with the infusion pumps. But with the infusion pumps, you're going to need a lot of extra connections. Whereas with this machine, you just only need your standard lines.
Okay, just maybe let's go to the setup for the, the Fresenius multifiltrate. So in that setting, remember you're going to prime the filter as usual, right? But then during treatment, you don't want to give a replacement fluid to the patient because they're not removing any plasma. So which means you're going to hang like even just plain bags of saline right on top of the scale. And then those bags shouldn't go to the patient, they need to go to that drainage bag, right? So you need to put another connection so that you drain actually supposed to be the replacement fluid goes to the bag, right? So if now you're thinking we're going to treat, let's say in a worst case scenario, maybe 10 plasma volumes, or let's say 7, right? 7 plasma volumes, right? And the patient's got a plasma volume of 3 liters. So we're gonna need to put 8 liters there on top of the scales and run them to the bag. You know? It's a bit too much, right?
Really, you just put a smart bag there. Problem solved. Instead of having saline because you're gonna waste. So if you smart bag there on the machine, problem solved. Yeah? Smart bags, yeah, it goes. You can also reinfuse it again. Yeah, just one bag will be enough. Any more?
Good morning, colleagues. My name is Zuleika Khan, and I am from KZN, Verulam Dialysis Center. So this is far and fast in KZN, right? We have literally a dormant transplant program. Daniel and Dr. Barte, would you all consider, if we have to send a team down to Cape Town, for us to literally get skilled in this? That's the first question. And then secondly, is there a possibility for these columns to ever be reused? What are your opinions on it?
Well, we welcome anybody that wants to come learn how to do it. I mean, we've had 2 patients from KZN coming to us, so I think it's much better for the patients not to have to travel. You know, it's obviously it's quite a stressful time, and normally their family has to come with them and everything. So it's quite a cost for them. I mean, besides for the fact that it's an environment they're not familiar with. I believe there are some places that reuse the filters. They are expensive. I mean, what Daniel has done is he's kept saline running through the column overnight in case we've had to use it the next day, which fortunately at Grootes Care we haven't. But I think that's a question you should ask the people that import the thing, not for ourselves. We haven't reused it yet. But I mean, we haven't, at Grootes Care, fortunately, we haven't had to. At UCT, we've done like this. I think there were 3 patients that needed another session the next day. Yeah.
That's correct, yeah. The company does not like us to reuse their column. They say we compromise the sterility. Yeah, but basically, if one can check in the literature, there's some people who try to reuse them. It's just the concern that you may need to reactivate those anti-A or anti-Bs in the column, which is going to be compromising everything. It's no longer the same. So, all the studies and whatever we've done, it is based on using the column ones. So, no matter what we do, we buy at least 2 so that we can actually have a backup should something happen, maybe even after transplant. So, normally, let's say a patient needs anti-A column. So we'll order 2 anti-A columns, and then we might find that we actually use 1, then we keep other 1 for next time. And the company, I think, is also willing to exchange us just in case they say we ordered anti-A, and then we get other patient needs actually anti-B, anti-B column, then they can exchange. I don't know if Robin want to mention anything about reusing.
No, so to be honest with you, there are centers around the world, or 1 or 2, that are reusing the column. We cannot recommend that, but it is being done. So it's not impossible. Yeah, that's all I can say.
Yeah, I think someone also asked about the cost. Yes, yeah, cool. Yeah, all right. I'm not going to go in detail about the cost, but I can just brief you. To estimate how much does it take to treat only 1 plasma volume? Okay, cool. To estimate how much does it take to treat 1 plasma volume of a patient that's got 3 volumes of plasma using the albumin?
Look, we did. I mean, it's going to be very patient specific how much you need to treat and how long. But I mean, definitely 1 column. If you can do only 1 column. It's cheaper than doing plasma exchange, I would say. If you end up needing more than 1 column, then it's going to become more expensive. But, I mean, I had that table. Of the 10 patients we did, 5 only needed one session, and 1 needed none, actually. So, you know, I would say on average you're going to need between 1 and 2, but it's going to be very patient dependent. And like I said, if you just do 1 very long session and can convince your tech to start early and finish late, if it's a high titer, then you'll probably only need 1.
Yeah, that's correct. We did some estimations with when you are using plasma exchange. But remember, with plasma exchange, you can only treat one plasma volume or to 1 to 1.5. You can't really treat anything more than that. And then we find that in that case, it cost us maybe something like 45,000 for one session. So maybe normally you need to treat 5 times. So you can see how costly that is compared to buying one column. The column may sound a bit expensive to buy, but actually it is quite cost saving if you're going to do 1 or 2 sessions only. But I think once you do more than 2, yeah, it gets a bit expensive in that case. And Dr. Pate, any overall cost involved in terms of blood test every morning and stuff like that?
Well, I mean, it's the only extra testing is the anti-A or B titers, which is a very cheap test. I think I don't know the cost, but it's probably a couple of $100. So that's the only extra testing we do, and obviously checking blood groups. I didn't talk about when we have patients with a non-A1 blood group. I don't know if you guys are familiar that you can get, there's different A blood groups. The A1 is the commonest. A2 is the next most common. It's about, it varies between 10 and 20% of the population. And then there's other A blood groups, which are also non-A1, which are quite rare. I don't even know them all, AX and various other ones. So, but any non-A1 blood group is a much lower risk transplant. The antigen expression is about 25% of what A1 is, and so you can afford to accept higher antibody titers before doing the transplant, at least 1 or 2 steps up. So, but it's not that there's no risk, but it's a much lower risk. So we have a reflex test now with our lab. Any donor that's an A blood group where there's an incompatibility, we check their A subtype. So the lab, we've got a special form we've designed with our blood bank so that they can test it. And then, you do pick them up, it's about 10 or 20%. And that makes the transplant much less stressful when you've got a weaker A antigen.
In terms of the survival, how does it look like compared to those ones that are compatible, like duration?
Well, we've only got those 10. I mean, 1 patient died. Unfortunately, it was COVID-related, and 1 rejected. So at the moment, I think those are not bad outcomes, but obviously, hopefully we'll get better at picking up the problem patients. I mean, both of those were theoretically avoidable. If we had done a COVID swab on that patient, we probably wouldn't have transplanted him, and if we had done a more thorough urological workup on the one that ended up rejecting because of infection, we probably wouldn't have transplanted them. So if you do have patients coming from out of town, in fact, most of our patients at UCD Private were from out of town. I think only 1 was, of the 6 were from Cape Town, and the critical care ones all were from Cape Town. I mean, I didn't mention that first patient we transplanted, I put the picture up. She was waiting 10 years on dialysis because she's blood group O, and the O list has gotten longer and longer and longer. And COVID as well didn't help with that. And when she heard that her brother who had offered could now potentially be a donor, she jumped at the chance. And I mean, it's completely transformed her life. I mean, from being a patient that comes to dialysis 3 times a week to running her own business now and having a different quality of life completely. I mean, she's told a funny story. She used to, after the transplant, she would still get up and get ready to go for dialysis and realize, hang on, I don't have to go for dialysis anymore. Yeah. So, yeah, I mean, we don't realize what a difference having a transplant makes for patients. I mean, and if this is another option for them, I think we shouldn't deny them that option. Well, I mean, I showed some of that data, that overall the outcomes are as good as ABO-compatible transplants, with those caveats that I mentioned about infection. So, yeah, I mean, I think it's definitely, if that is the only option available or the better option compared to the more sensitized donor, I think we should really be offering this to our patients. I mean, it is available. It just needs the nephrologist to overcome their fears and the technologists to be trained and available to do it. I mean, I think it's doable. I mean, it is being done in South Africa, I think really should be available in other centers, and that's what we're trying to promote for our patients. And even in other countries, Botswana, it looks like they're keen. Okay, so I mean, any?
I'll speak now in time enough. So you guys are developing a regime, right? So you guys are developing a regime which we all will basically adopt. How welcoming are funders from the private side in terms of paying for this treatment? Because we do have a very difficult time.
I haven't heard of any patient that's been turned down. I mean, it's a bit more motivation involved. I've got a pretty standard letter now that I just cut and paste the name and the antibody titer and whatnot. It's quite easy. It's the transplant coordinators that have to spend more time on the phone. But like I said, like with Discovery, they know we're running this pilot program. If you just send it to that email address, you'll get it approved. I mean, it's not that difficult. I don't know of anybody that's been turned down. They know that it's cheaper to have a transplanted patient than a patient on dialysis for the rest of their life. I mean, like I said, it costs the same as like 2 or 3 months of dialysis. I mean, why wouldn't you want to transplant a patient? And I mean, besides for the actual, immunoabsorption column and that one session or maybe 2 or 3 sessions, they get an extra dose of rituximab. Otherwise, it's standard immunosuppression for these patients. So it's definitely, I mean, if you're saying a normal transplant should be approved, there's no reason why you shouldn't want to approve this, because it doesn't cost that much more and it gets the patient off dialysis. We're probably running over our time. I don't know if there's not much else. I think some of us want to go to other sessions. So do you think we should wrap it up? Anything else that you guys want to say? I mean, I think you can maybe talk to them. I think there's another talk coming after this as well. So just to say thank you to everybody. I don't know, Robin, do you want to, it's your sponsored workshop. You want to say anything?
Yeah, I just want to say thank you to Dr. Wade for your informative talk. And then thank you so much to Walter and Daniel for running the setup of the machines. And thank you everyone for coming. And if you want any more information, you are welcome to come and see us in the back right-hand corner of the main area. Yeah. So thank you.
I just woke up from a dream where you and I had to say goodbye. And I don't know what it all means, but since I survived, I realized wherever you go, that's where I'll follow. Nobody's promised tomorrow, so I'ma love you every night like it's the last night, like it's the last night. If the world was ending, I'd wanna be next to you. If the party was over and our time on earth was through, next to you.
Next to you, right next to you. If the world was ending, I'd wanna be next to you. If the party was over and our time on earth was through, I'd wanna hold you just for a while and die with a smile. If the world was ending, I'd wanna be next to you. If the world was ending, I'd wanna be next to you. I'd wanna be next to you.
Sun is going down, time is running out, no one else around me. Steady losing light, steady losing my mind, over shadows and gravity. Without you, there ain't no place for me to hide. Without you, there's no way I can sleep tonight. What I do for a little bit of peace and quiet. Without you, I keep slipping into bad dreams. But there's no you and I. No sound when I cry. I love you and I need you to set me free from all of these bad dreams. Waiting on the other side. No sound when I cry. I love you and I need you to set me free from all of these bad dreams. All of these, baby, please come around. Help me settle down. Headless habits of cloud my head. What you waiting for? Something physical. I can do this by myself. Without you, there ain't no place for me to hide. Without you, there's no way I can sleep tonight. I do for a little bit of peace and quiet. Without you, I keep slipping in a bad dream. But there's no you and I. No sound when I cry. I love you and I need you to set me free from all of these bad dreams. Waiting on the other side. No sound when I cry. I love you and I need you to set me free from all of these bad dreams. Baby, please. All of these, all of these.
Tell me if there's a problem. I'd rather you let me know, so I can work on it so I can work no more. Honey, if there's a problem, I'd rather you told the truth, to put my mind at ease when I make love to you. And I shouldn't feel like this so soon. Shouldn't feel like this so soon. Honey, if there's a problem, we can take it slow.
telling me all night long. Gasoline and groceries, the list goes on and on. This 9 to 5 ain't working. Why the hell do I work so hard? I can't worry about my problems. I can't take them when I'm gone. 1, here comes the 2 to the 3 to the 4. Tell them bring another round, we need plenty more. 2 stepping on the table, she don't need a dance floor. Oh my, good Lord. Someone pour me up a double shot of whiskey. They know me and Jay Dale's got a history. There's a party downtown near 5th Street. Everybody at the bar getting tipsy. Everybody at the bar getting tipsy. Everybody at the bar getting tipsy. I've been boozy since I left. I ain't changing for a check. Tell my mom I ain't forget. Woke up drunk at 10 a.m. We gon' do this shit again. Tell your girl to bring a friend. Oh Lord. 1, here comes the 2 to the 3 to the 4. Tell them bring another round, we need plenty more. 2 stepping on the table, she don't need a dance floor. Oh my, good Lord. Someone pour me up a double shot of whiskey. They know me and Jay Dale's got a history. There's a party downtown near 5th Street. Everybody at the bar getting tipsy. Everybody at the bar getting tipsy. Everybody at the bar getting tipsy. Here comes the 2 to the 3 to the 4. When it's last call and they kick us out the door. It's getting kinda late, but the ladies want some more. Oh my, good Lord. Tell them drink some. Someone pour me up a double shot of whiskey. They know me and Jay Dale's got a history. There's a party downtown near 5th Street. Everybody at the bar get tipsy. Someone pour me up a double shot of whiskey. They know me and Jay Dale's got a history. At the bottom of a bottle, don't miss me. Everybody at the bar get tipsy. Everybody at the bar get tipsy. Everybody at the bar get tipsy.
20 in my hands. Oh, babe, your touch, it hurts more than hangovers. No, that bottle don't hold the same regret. And my mother says that you're bad for me. Guess you never felt the high we're on right now. And my father says I should run away, but he don't know that I just don't know how. Well, if it's unhealthy, then I don't give a damn. 'Cause even if it kills me, I'll always take your hand. It's unhealthy, they just don't understand. And when they try to stop me, just know nobody can. You're still gonna be my man. Hey, 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 still gonna be my man. Hey, hey, hey. Oh, this body high gives me sleepless nights. It's a million times when I need your cookie. And my red eyes, they are twice as wide. It might look like pain, but to me it's bliss. All my friends may say that you're bad for me. Guess they never felt the high we're on right now. And my sister says I should run away, but she don't know that I just don't know how. Well, if it's unhealthy, then I don't give a damn. 'Cause even if it kills me, I'll always take your hand. It's unhealthy, they just don't understand. And when they try to stop me, just know nobody can. You're still gonna be my man. Hey, 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 still gonna be my man. Hey, 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 still gonna be my man. Hey, still gonna be my man.
know that this could feel like that, but I just can't stop. That my defenses drop. I know that I was born to kill any angel on my windowsill, but it's so dark inside. I throw the windows wide. I know, la 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 la. I know, la 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 la. Still I don't let go. On fields of flowers grow. Oh, it feels like I'm falling in love. Maybe for the first time. Baby, it's on my mind. You blow.
Good morning, everyone. We're just going to wait a few more minutes because of the unexpected long walk from the coffee venue. Okay, so let's give everyone a few more minutes to get here. Thank you.
This is for a lifetime. I know that in this kind of scene of two people there's a spark between. One gets torn apart, one gets a broken heart. I know, la 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 la. I know, la 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 la. Still I don't let go. And fields of flowers grow. Oh, it feels like I'm falling in love. Maybe for the first time. Baby, it's on my mind. You blow. It feels like I'm falling in love. You're throwing me a lifeline. This is for a lifetime. I know.
Okay, good morning, everyone. Welcome to our post-tea session. This is always a very interesting session. And this morning it's my great honor to welcome Sasha Ziga from overseas to present a talk on moving towards a more sustainable future with green dialysis. Sasha is the global nurse manager for the B. Braun dialysis clinics around the world, and he has been involved in dialysis for many years on both national and international level. And it really is our great privilege and honor to welcome him here today. We look forward to what you have to say, Sasha. Thank you very much. The floor is yours.
Well, hello, and thank you very much for coming all that long way from that other area. I guess some people are still out there thirsty, waiting to arrive. So thank you for coming and to have some interest in green dialysis. This is a topic, I will make it rather here, then I'm not so much in the light. So a topic that has not been that important in the past, but we're slowly getting there, and it is important. If you look at the environment, there are so many different aspects that we need to consider, and the medical area is not really the number one area taking care of this planet. And dialysis, for sure, is not. So let me start with my disclosures. There is not a lot. I work for B. Braun. So, when we look at dialysis in general, we use a lot of resources. That goes for the whole medical sector, but in dialysis especially. We use a lot of water for all the treatments that we go through. We use a lot of electric power as well. And then we produce a lot of waste after needing a lot of material that we then use as well. Then we throw it away. So there's a lot of stuff that goes through our hands and that ends up in waste at the end of the day. And then we use a lot of chemicals. That's not helping either. So yes, it's cleaning our machines, our surfaces, and some of that stuff is really evil, yeah? Not just for the environment, also for you and me. So if I look at how staff sometimes handle some of the chemicals, you know, you don't want to see this. Yeah, so there's a lot of evil stuff out there. Now, if we look at this in numbers, then it looks like this. So for a regular, average treatment, if I take a full year for one patient, we need about 18,000 liters of water. Is that enough? No. Of course not, because you could potentially also have HDF, and you could have that in post-dilution and pre-dilution, so that number may easily take you up to 30,000 liters per patient and year. Then we need a lot of electric power, and we will cause about 3.8 tons of emission per patient per year. If you look at everything that we need, so that includes equipment, and it includes energy and also transportation. So getting the patient from and to treatment. So all that included 3.8 tons of emission. So those are quite impressive numbers right there. So there is something that we need to do about this. And that starts with chewing gum. So why I'm using this is because it actually really starts with you. If this is the only takeaway from this talk, that you think of chewing gum when you go back, then I did my job. So why? Because this is something we normally consider a little thing that doesn't really matter. Yeah? It's a little chewing gum, who cares? But I used to live in Canada for many years, and that was in Vancouver, BC, and a 2 hours ride from there going to the south, I would end up in Seattle. And in Seattle, they have a very famous fish market. How do I get to that chewing gum now? You go down the stairs, and then you end up in an alley. And that looks like this. So it's a famous alley. People come to Seattle just to take pictures of this and to add their chewing gum. Yeah, so it's the full alley, the whole length on both sides. It's high, it's full with chewing gum, and everybody going there, you know, they make sure to quickly chew something and add it there. It's a very interesting scent when you walk through that alley. It's something like spearmint and I don't know what. Yeah, but what I'm getting at here, to make the long story short, is every chewing gum counts. Yeah? So everything that you do in your unit is already contributing to this. If you consider it a piece of art or something you want to avoid, I actually don't care, but every bit counts to get this done. And what we will talk about now is what you can do. Because there are several layers and things that can be done. Some would be on the industry level. For example, we are considering, do we need to have shorter blood lines? Not so much the line that goes to the patient, but there are so many other additional lines like pressure lines, and I don't know what lines. Can they be shorter? Because if it's just a centimeter and you produce thousands, then it's thousands of centimeters, meters that add up and that don't go to waste and that don't need the resources to be produced. But we are looking a lot more at what you can do. Also, I will mention a few things that are not available in South Africa, and I was initially considering taking them out of the presentation, but then I was thinking, no, because I want you to see, because you need to know what is out there. You know, I want to make you hungry. That's it at the end of the day. So you see what is out there and that there is something that can be done. And if it's not available yet, perhaps it will come sooner or later. So when we look at green dialysis, we look at the whole unit, the full environment that we have. So that includes the building, transport, logistics, the whole technology we are using, and standardized processes, consumables, and individual behavior. And what everybody can buy into, and we also need everybody to buy into, is the personal behavior. So we will start with that. So first of all, we need to create awareness. It's about you doing the thing. It doesn't help if you expect others to do the thing. And sometimes it's just a very small thing. We will look at some of the small things. One here would be turn off the stupid lights. Yeah, so you could, for example, have a movement sensor in your stock. Why would you need the light to be on there all the time? And in other areas, yeah, you may not want that movement sensor with your patients, but in other rooms, again, remember the chewing gum. It's just one thing, but it does something in the overall because you're using less electric power. Then we have separate waste. Yeah, well, that's a no-brainer, but I actually mean it. I do travel a lot and I do see a lot. And one of the things I really like to see is if we separate waste and we make sure that we have, the stuff that can be recycled, that goes extra, but it's also to have meaningful waste separation. We all have those sharps bins in our units, and what are they there for? Well, guess what? I would think for sharps, but then when I go and look, I find sandwiches, packaging, you name it, because people go like, yeah, well, it's garbage. At the end of the day, it's dumped, so that's it. A bin like that is very expensive. Then it goes for incineration. That's also very expensive. If it fills faster, it needs to be disposed of faster. So if only things go in there that are supposed to go in there, it takes a while to fill that thing. And here is the thing that will count for many of the clinics, even if they don't consider the green aspect that much. It saves you money. Yeah, who would have thought? Green dialysis in many aspects will help you save a lot of money. I have some numbers from our own clinics that I can show you that are part of the presentation a little later. You will save thousands of euros and rands. Of course, there are also fields where we could invest to get a better outcome, and even that pays back. So green is good, yes, for the environment, but also for the cash flow, for what we have, for what we need to spend. Keep your eyes on things that you can improve. Now, what do I mean with that? In one of our clinics in Malaysia, we have a head nurse, and she made it her task that we want to improve. So every year, the local head nurses must present 2 things that can be improved. So that's part of their task, part of their KPI, what they're measured against, and I actually like that. So for them, it's not so much about green aspects in general, it's about what can we improve. And if you look at your clinic, there's always something that you will find and where you can go like, we could do this a little better actually. The other things are kind of no-brainers, like set the indoor temperature wisely. Well, what does that mean? Don't crank up the AC like there's no tomorrow. Your patients will like it because the way I see it, most patients feel cold most of the time anyway. No matter what you do with the temperature, even if you bring it up to 36, they still feel cold. But why would I want to put it down? Because I find that very interesting observing nurses. Why would I want to bring the AC down to a level that they all start wearing jackets? Yeah, a jacket is not part of your nursing uniform, and if you need it, it's obviously too cold. Yeah, so run it wisely. So avoid waste. We talked about waste separation already, but one thing that I really want to share about avoiding waste is that it's about the whole picture when we talk about green dialysis. What is the whole picture? It starts with having no patient. How about that? I used to work at an acute hospital in Vancouver, and we had a very big renal program. Our renal station had 80 chairs. And we then started with a pre-dialysis clinic because we found that if patients would come early, so now I'm not talking the crash landers, I'm talking everybody else, so those who come early enough, they would go through the pre-clinic and they would be taken care of by the nephrologists there would be pharmacists, there would be registered dietitians. and they would work with these patients. And what happened to us in the hospital was that a couple of months after they started their work, we started having our first empty chairs. We never had empty chairs. And then we started having empty chairs. Not that our numbers really went down, they started filling with a significant delay. So by guiding patients in a smart way, for some patients that means more quality of life because the start on dialysis is significantly delayed just by something small like dietary restrictions or so, or medication. Yeah? So for them it's big, but actually this is also very green because a patient I don't treat, I don't need all the stuff for that I need for everybody else. So that is already a part of it. One other part that we did in our clinic was avoiding waste by making sure that unused stuff from the patient would go back. So if I bring gas, for example, and I don't open the gas, theoretically I'm still supposed to throw it away because it has been with the patient. So we started introducing little bins with a name on it, and everything I wouldn't use for the patient would go into that bin. Next time patient comes back, I will use the stuff from the bin first, and then I will take new stuff. But that way I can significantly reduce the amount of waste that is really unnecessary, because most of the time it's even waste of stuff that has not even been used. So yes, I will have in this case to invest a little in those plastic bins, but looking at what I would throw away and what I keep buying, that is cheaper, I can tell you that. And then, of course, make sure that you are recycling your stuff. And then it comes down to the detail. Yes, you can separate paper and all that, but in my clinic, we had a patient whose daughter was running a company, and she was asking us, you know, all these little bicarbonate cartridges, what are you doing with those? And then we said, yeah, well, they are dumped. They are taken by some supplier, and then they go somewhere, we don't know. And then she said, well, actually, I could use them because our company, we make backyard furniture. And that's made out of plastic. So if we can get the cartridges, would be great. So they came and took our cartridges, and then now probably somebody's sitting on them. We also need to look at our processes, because yes, it is for the patients and for every one of you to buy into the idea, but we also need to establish the thinking in the processes that we follow, because some people go by the book. We have policies and procedures for everything. If it's not in there, they will not do it. So you can adjust your policies and procedures to include green aspects. For example, in reviewing your disinfection routines, if I look at the machine that we work with in the IFU, it says it can stand up to 72 hours without disinfection. So do I have to disinfect it every day if I'm not using it? Why would I want it to turn on every morning and go for routine disinfection? I know for hygiene reasons, I know everything that talks or that speaks for it. But just out of consideration, if you look at the IFUs that the machines come with, and if it's an official statement by the manufacturer, then I would call them up on it and keep those times. It will save significant water and also disinfectant. Looking at water management, the top point up there, also an important point is that you install meters. Because if you want to get better with your water consumption, you need to know what your water consumption looks like. And most meters are installed right in front of the RO, so the incoming water you know. But how do you know what is going to the machines? Well, you know by installing a meter after the RO, and then you know what your actual consumption for the patient is. And then you need to monitor this, and this needs to be a policy, that needs to be assigned to somebody, so you can see what is actually going through, because then you can start working on how to reduce. If you don't measure, it is very difficult to reduce. How? Where do you start? What do you compare it with? Use sizes that make sense. Find suppliers that give you products in packaging that make sense. I've seen stuff in packaging like this, and what was inside was more like this. Why? We don't know. But there are other manufacturers coming up with something like this, for this. Yeah, so it starts with a detail, also with the sizes that I'm using. I know in some countries there is a single-use policy for acid concentrate bottles. If I have single-use policy, a 10-liter canister is a little difficult for a regular treatment if I have to dump the breast. If you don't have that policy, lucky you, but if you do, you would throw a lot away. So pay attention to these small things. Then if we look at the next, we are looking at the building. And in a country like this, perfect for solar panels. It's not that we are expecting everybody to have everything with solar panels and that you can expect those solar panels to do the job and supply you with the complete energy supply that you need. They cannot. We're back to the chewing gum here. Yeah? It starts with that chewing gum. It's what you add to make the picture complete, the thing that you add to save on cost as well, even though there is an investment with that. Another investment would be go for LED lighting. We talked about the meters just a second ago, and then have state-of-the-art technology in your unit. Have meaningful and good working ACs and ventilation systems. Next would be the technology that we use. There would be a water system, of course. If I have a water system, I need to look at what kind of water system do I have. Looking into some clinics, especially the ones that are a little older, sometimes I'm impressed that clean water comes out of whatever that is that I see in the RO room. If you think green, it makes sense to invest in something that goes green. So something, for example, that has an eco mode, so that uses less energy, that also uses less water because it could have a standby mode. So something that will just stop working if it's not needed, and it will not constantly flush and do the thing and create more wastewater going somewhere else. Huh? Have reliable systems. So systems that will last for long. That is also a green aspect. If you have a system, for example, of stainless steel, now of course this is our example here, but there are other companies doing that as well, where stainless steel is used and they will last significantly longer than many of those systems working with some plastic pipes. And yes, it is an investment, but if you look long-term and if you look at the reduction of power and water usage, the money does come back. It just takes a couple of years, but these things will last for a very long time. And that the money comes back, I will show you in a second. Use machines that make sense. Now, obviously, well, right, so you can see that one at our booth. But why I'm showing it is for a couple of reasons. So first, we are certified according to ISO 14001. What on earth is that? You may be familiar with the ISO 9001 that many clinics are certified to, but this one is looking at the environment, at sustainable factors taken into account, and you can also have a certification for that. So we are sourcing all the material that we need to 60% from the EU. So we are not shipping everything from everywhere in the world to put it together and then ship it somewhere else in the world again. All the little factors that play a role. A big thing that I always like to point out, because I see that many units, no matter what machine type you have, are not using, go for online priming. There are so many HDF machines that are just sitting there because nobody says, I want to do HDF. But they still have the HDF functionality. You can do an online priming with that. You can reinfuse with that. There's no need for a saline bag anymore, except you need to give a bolus and you don't have an HDF line in. But besides that, you could utilize that a lot. Empty your blood lines, dialyzers, and bicarbonate at the end. Because most of the time, waste is calculated by volume and by weight, depending on country. There are very interesting regulations in some countries. I just came from one where they have to freeze the full waste coming from dialysis. I found that very interesting. They have massive freezers in the back, and all the garbage goes into a bag, and then it goes into the freezer until it's picked up. So, you know, different countries, different rules. Very interesting sometimes. Now, this is something you may not have seen yet, but I find that to be a very interesting thing in order to go green. You can mix your concentrate on site. So this thing here is called the EcoMix, and you place it next to the RO. And then you have some tanks, and what you get as a supply is that little keg that says EcoCard there. So what does that contain? It's a keg with powder. And that powder keg is connected to the device that takes the fluid from the RO, and then it mixes the acid concentrate that you need. It's pumped into big tanks, and from there the machines are supplied just like they're supplied with water. So it goes through a central supply system. Now, why would I use something like this? Because you can see how many canisters are needed to replace one keg. That is impressive, and now you need to consider that all this needed to be transported, and it is not very meaningful to transport fluid. Fluid is always heavy, and it requires a lot of space. Now, if you look at how many canisters I need to move around before I have moved around that thing. And the next is, in my unit, it's not too nice for the nurses that they have to carry around the canisters all the time. Here, this thing I can move with my little finger. And I can reuse this up to 15 times before I need to put it into recycling. So overall, if I compare up there, you can see for 80 patients, 12,000 treatments, I would need 2,000 kilos of plastic bottles, or 49 kilos of my recyclable EcoCard. So there is a way that we can get concentrate done in a more meaningful way, and it's significantly easier on the environment. Now, I know that it's not available everywhere, so we also need to look at acid bottles. And with acid bottles, we have a change in the bottles that we are producing, for example. So there we have a brand new one, and why I'm pointing that out, because normally I'm not showing that, is that we have one that is now reducing the plastic amount used for the production by 30 tons of plastic a year. That is something. And they're also getting rid of the packaging around it, and that's 8 tons of cardboard. So that's something to consider. Also, there are only 5 liters in there, because we know that most canisters, they do have 6 liters, but when do you ever use or need the full 6 liters? So if you have to dump them, in the first place, they were produced in vain. They were made for nothing, because you are throwing it. So we could have produced it and put it right into the drain. That would at least have saved us the cost for the transport, you know? So take things like this into consideration. Then look at needles. If you look at a standard steel needle that you are using for a patient, then you are looking at this. So we have about 156 treatments for a standard patient. And if I use a safety needle like this one, I'm looking at about 2 kilos of waste for a patient for a year. Now, if you have 200 patients, that's a significant number. So again, it adds up. It's always the small things that count. And once you add the small things, you get a big thing. Yeah? So if I take in comparison, in this case here, the Diacan Flex, which is a catheter needle, then we are reducing that amount of garbage significantly. So it's in the small things already, and those are things that you can do. Yeah? So where we don't necessarily need our organizations. Looking at transport and logistics, well, the more we don't need to transport, the better. So looking at concentrate, for example, and stock, how much room do you have? I remember in my old clinic, we did have a good stock room. We had a lot of room. So when we had the Christmas holidays ahead of us, we would normally order more stuff to have it available because there would be no delivery over Christmas. Now that brings me to the question, if I can handle more stuff because of the Christmas holidays, why can I not handle more stuff when there are no holidays in front of me? Because that way I can reduce the number of transportation needed. Very easy. So if I can before Christmas, theoretically in my world, I can after Christmas as well. Consider on-site preparation. I already said that. The online priming, I said that as well, so I don't need to read these things to you. There is a brochure on that we created together with EDTNA. EDTNA is the European Dialysis Technician and Nurses Association. And I have a slide with the link. There's a free, this brochure there, the Green Excellence in Dialysis, is a free brochure that you can download from there. And where there's also a checklist where you can check where you are at in your clinic. So you can actually measure, there's a questionnaire where you are at, and then you have a starting point. So I mentioned they implemented an environmental management system in our units. What does that mean? It's a framework of policies, procedures, practices that help organizations manage and reduce their impact on the environment. I took that from the ISO website. So this is what you are certified against when you do that ISO 14001. And this is the source for that. So that takes you to the ISO website. Now, for our clinics in the Czech Republic and Slovakia, that's for us, it's one group. They started emptying the dialyzers, and they started emptying the whole bloodline. They also made sure that the cartridges would be empty at the end of the treatment, and they have an RO that has an echo mode, and they also have a machine that has an echo mode. What does echo mode on a dialysis machine mean? It means the machine is not using any water, it's not using any bicarbonate, it's not using any acid concentrate until the patient comes in. So when you deactivate the echo mode, it starts creating the conductivity back again. So by using these very simple measures, they saved 3,000 euros, which equals 57,000 rands a year per clinic. We have more than 30 clinics in that country. And I recently, that was right after I had sent the presentation, I learned that in Pilsen, that's a city in Czech Republic, if you like Pilsener, I need to meet the cliche, I'm German, you know, so Pilsen is the mother town of Pilsener. And there we have a clinic, and they are not sitting at the 3,000 mark anymore. They are saving 10,000 euros a year. So that would be about 170,000 rand a year. And this is not really with a big investment. These are the things that you can do when it's just about those echo modes and emptying things. If you want to have a new RO, yes, that is an investment. These things don't come cheap. But in the long run, if you have that over 10 years, and if it helps you to save 10,000 every year, well, then it's not just greener, then it's also cheaper. And we know money talks, especially when you talk to management. So if they are not big fans of green, they are big fans of wallet. Yeah. So wallet talks. So what we need to do is we need to create awareness among staff. We need to have somebody who is responsible in every clinic, like what you do with other assignments as well. In a standard clinic, you have somebody who's assigned to take care of the emergency card. And why? Because if you don't assign anybody, nobody will take care. That thing will not be checked. So you need somebody who's assigned, for example, to check that extra water meter you installed after the RO, to have the numbers. And then you can start compare. And then you can make meaningful decisions based on numbers that actually reflect what is happening in your unit. Encourage staff to use green modes of transportation. Now that applies a lot to bigger cities, and in Europe we would say, yeah, well, there are lots of cities with great public transport. That may be a thing depending on where you are here. Select suppliers with environmental certification. Just like what I said with, do you have suppliers that give you stuff that is not in this packaging, but rather in the small one? Do you use suppliers where you pay attention that they also look at green aspects of production when it comes to dialysis? Yeah, so that's a responsibility that we have as well, and that is something that goes into these policies and procedures, to that environmental management. That's part of it, that we look at who we work with and where we get our stuff from. This is a checklist, just as a little example that you can use if you are measuring in your clinic, so you have something to measure it against. So this would be something that you would, for example, then again find in the EDTNA brochure. They have that environmental checklist, and you will find it right there if you don't just go for the EDTNA website. So I made a link right to that checklist, and the next page here contains the link to that Green Excellence in Dialysis brochure. I highly recommend that. Most of what I said is in there. And then you have something you can work with. Everybody at the end of the day just needs a starting point. It was with that little chewing gum, yeah? So you need to find out what is what I can do. What can I encourage in my organization? What do we need to look at in the bigger scale? But what is my contribution? And that's where we are back to where we started with that little chewing gum. It does make a difference what you do. If you take this away, I'm happy, and I'm done. Thank you very much.
Sasha, thank you so very much for a lovely, informative talk, and each aspect being totally relevant to each and every one of us sitting here today. I'm going to allow a very short time for a question, if anyone does have a pressing question. Yes, Daniel. Sorry, you can come forward and collect this microphone, please.
Thank you so much. You help us to understand more about how to save like the cost as well, while keeping the environment green. I want to know if you would consider doing the dialyzer reuse as a way of saving the cost, or also going green. How does it look like? And what does the company say in that regard? Thanks.
So reusing dialyzers, that is a thing, right? Do I like that? No. Looking at a worldwide network of clinics, in some countries we do have a reuse. We do reuse the filters. Now, yes, then you need less filters, but you also need to consider the clearances, and you are going through some significant chemicals to do that work. So that's, yes, you do save on that, but then you're using a lot of that. So in an ideal world, I would still be a fan of the single-use dialyzer.
Thank you, Sasha. Thank you, Daniel, for that question. I'm going to allow only one more question due to time constraints. Would you kindly stand up and grab the mic? Thank you. Please introduce yourself.
Hi, my name is Tebogo. Thank you so much for this presentation. And I think there's a need to go green with, as you have explained, with an amount of consumables and resources that we use and the amount of waste that we also produce. But my question is, if a lot of the things that you have presented, I look at them and I look at South Africa and I think, wow, it would be great to have it. But a lot of them I find that are going to be a bit of a challenge in a setting that we are in a setting where water is scarce. I mean, we've got a lot of issues. We've got a lot of issues with safety. We've got a lot of issues with affordability. There's a lot we can do. But as I looked at your presentation, I asked myself, how do we bring it home? How do we make it how do we get encouraged to start in an environment where resource constraints are a reality?
Thank you. I totally get it. Absolutely. I've seen quite a few clinics here as well. At the end of the day, it's two things. It's what you can do. We are back to the chewing gum. Yeah. So it's what you can do, which decisions you can actually make yourself. Then that's your challenge where you can. Well, I did show some things also on purpose to show what is out there. Yeah. Because if nobody shows it, you will not know. So at least it's something that we can see that it's there and that we could aim for. Now, is this something that is a standard everywhere? For example, if I look at our own network, the B. Braun units that we have worldwide, do we have that echo mix everywhere? No. We do not have all of the things we are talking about here, but we identified where we could potentially go for a greener approach. And where we can, we install these things. Also, in some countries where they theoretically are on the richer side, there's a lot of pressure in the healthcare system. So the reimbursement is not great, and there are quite a few units that simply cannot afford it. Very easy. Yeah, so I know it's a resource thing here. It can be a resource thing even if it's a monetary resource in some other countries as well. So at the end of the day, we are left with what can we really do? Can we use, for example, a needle that is not that long needle? Can I turn that light off? Can I get a concentrate jug with less plastic or something like that? So this is something I can do. And I totally get that, yes, the bigger picture and everything that is possible, difficult. Yeah.
Okay. Thank you very much, Sasha. Thank you once again for a very meaningful talk, and thank you for sharing your expertise on behalf of B. Braun. Thank you, Sasha. I'm handing over to Magashni now. Thank you.
Thank you, Sonia. Good afternoon, everyone. It is my privilege to introduce our next speaker to you, Dr. Lauren Hill. Lauren has more than 30 years of experience as a clinical dietitian, an academic and a researcher with a PhD in physiology in the area of critical care nutrition. Her special interest, knowledge, and areas of expertise are nutritional support of critically ill adults, trauma patients, and difficult to treat surgical GIT patients, all aspects of enteral and parenteral nutrition, gut function in the critically ill, and immune-enhancing and anti-catabolic nutrients. Dr. Lauren, we welcome you. Thank you.
Thank you very much. Thanks for the introduction and for the invitation to speak at this session. So I've been asked to talk about the value impact of medical nutrition therapy in maintenance dialysis patients. So you may have felt that my introduction, as with a background in critical care, doesn't really apply to the renal dialysis setting. But in my consultancy work, I increasingly am working on issues to do with the health economics or nutrition economics of medical nutrition therapy. So I'm going to talk to you about this aspect today. So this audience will know very well that the risks for chronic diseases of lifestyle cluster and overlap, and many of them end up with chronic renal disease, including uncontrolled diabetes, unmanaged hypertension, and various other chronic diseases of lifestyle. In South Africa, we have something like a 10%, depending on what stats you look at, roughly 10% prevalence of chronic kidney disease. But we also have a huge number of diabetic patients and patients with poorly controlled or glucose tolerance or undiagnosed diabetes who may very well end up with chronic kidney disease. And then reports from South Africa suggest somewhere between 30 and 50% hypertension, leading to about 6,000 new cases of chronic kidney disease every year. So this, as a previous person has mentioned, is in a health system which is cost constrained or resource constrained, and dialysis being one of many very expensive interventions for managing chronic kidney disease. So we have two sort of broad populations of patients, those who are waiting in the waiting room to start dialysis and those who are in a renal dialysis service receiving maintenance dialysis. So the ones who are in the dialysis waiting room are those who have maybe not yet met the criteria for dialysis, but they might have factors such as, for example, evidence of protein energy wasting from underlying renal disease at early stages. They might have poorly controlled diabetes or hypertension and various features of suboptimal biochemistry. These features or criteria are very amenable to dietetic intervention and nutritional management. So optimizing a patient from a nutritional point of view at this pre-dialysis or waiting room stage by, for example, improving their management of their chronic disease, improving HbA1c, improving their lipid profile, and certainly improving proteinuria, can slow down their renal progression and delay the dialysis initiation, which is the really expensive part of chronic kidney disease management, and then in the meantime also improve clinical outcomes. So I'm going to try and talk a little bit to this in the rest of my talk. So this is an interesting paper looking at changing the way we think about reimbursement for medical nutrition. And this is always a pain point in resource-constrained settings somehow, even though medical nutrition therapy and the role of the dietitian is actually, as I hope to show you, quite cheap compared to other chronic disease management interventions. So there's definitely a disconnect between the evolution of clinical practice guidelines for the management, for example, of chronic kidney disease or other chronic diseases of lifestyle, and where the current reimbursement policies position the value or the investment in medical nutrition therapy. For example, a dietitian will be able to see an uncontrolled, a poorly controlled diabetic patient one time in a year. That is all the medical aids will pay for on chronic disease programs. So we have to change the way funders are viewing the value of that. There's poor reimbursement generally in the out-of-hospital setting. It's more difficult, despite the fact that you see better patient outcomes and cost savings. And there's an incentivized cost cutting on unit costs of things, the cost of an individual unit of a dietitian's time or an oral nutrition supplement designed specifically to manage protein energy wasting in renal patients. And instead giving standardized things which are actually not suitable for the population that you're trying to manage. So coverage policies and reimbursement funders need to relook at this and catch up with the nutritional treatment protocols that are already accepted by the medical community internationally, and then also address the healthcare burden that comes with malnutrition on top of other disease states. And this is true in chronic kidney disease, it's true in cancer, it's true in a lot of other high-cost disease pools. And then to consider the costs and benefits of medical nutrition therapy relative to other healthcare interventions and look at this as an investment decision, which is also what we've heard from the previous speaker. So if we look at the cost differential between patients who are still in the waiting room, the cost here of medications, hospitalizations, consults with maybe general physicians or GPs, including the cost of management of things like stroke or myocardial infarction or other chronic disease-related events, adds up pretty much to the cost of dialysis. Do I have a light? My light doesn't work. So what you're seeing in the gray in the right-hand bar is the cost of dialysis, which is almost as much as the combined cost of all those other costs of managing the pre-dialysis patient for their chronic disease. This data from South Africa shows what this audience already would know very well. The costs of dialysis-related care is very high. Hemodialysis more than peritoneal, and then very high variable costs. The rest of the cost pack is not as much as those two silos of costs. So if you look at the variable costs, and here you're seeing the hemodialysis on the left part of the table and peritoneal dialysis on the right-hand part of the table, the cost of the dietitian is a minute fraction of the total cost of renal replacement therapy care. Actually, for hemodialysis, for maintenance hemodialysis, less than 1% of the global cost of managing a patient on maintenance dialysis. A little bit more for the peritoneal dialysis patient, but still a relatively small fraction of the total cost of care. The problem with a lot of the patients that we see in our setting, as reported here in this table, is that South African patients have a lot more comorbidities, which additionally adds a significant cost burden. And these poorly controlled comorbidities or other related chronic diseases like unmanaged hypertension or underlying HIV may then increase the requirement for dialysis. So what are the benefits of medical nutrition therapy then in a patient with chronic kidney disease? And these are some of them. So the skilled dietetic counseling and intervention with specified medical nutrition products that are suitable for renal failure of various kinds have the possibility to influence all of these bubbles. So reducing metabolic acidosis, controlling phosphate, managing obesity, dyslipidemia, hypertension, glycemic control, cardiometabolic risk, which can be primary or secondary to chronic kidney failure, and significantly reducing uremic toxins. And the impact of this, that it reduces incident CKD in early intervention in chronic disease patients, but it also slows down the progression of chronic kidney disease and reduces uremic complications. In terms of the complications associated with chronic kidney disease and renal replacement therapy, many of these, if not most of them, are amenable also to dietetic intervention. This includes the management of protein energy wasting, a very particular disease-related malnutrition syndrome that is typical in chronic kidney disease and which in itself impacts on prognosis. So a skilled dietitian is able to help you with all of these aspects of managing your chronic kidney patient and the complications. And these are not all of them, this is just the main ones. So I'm showing you here data on medical nutrition therapy, improving biomarkers and delaying patients reaching the dialysis stage. So on the left-hand side, you're seeing the graphs of survival probability. In the blue, the patients who've received medical nutrition therapy interventions, and in the red, those who have not. So patients who received medical nutrition therapy, including skilled counseling and products by a dietitian, had a longer delay before dialysis commenced with a hazard ratio of more than 3. And also significantly more patients presented with normal blood chemistry and with a significantly higher odds of having normal serum calcium and phosphate, so you think about bone health, and higher odds of a normal serum albumin level as well. What about the low protein diet approach? This is a classical old approach to managing the patient, particularly the conservatively managed or the pre-dialysis patient. This has changed a little bit in subsequent guidelines and is not as strict, certainly in the maintenance dialysis patient. But in the patient who is in the pre-dialysis or the waiting room, the low protein diet approach has been shown to reduce the incidence of dialysis commencement by 10% and achieve a cumulative $5,000 cost saving per patient per year, and estimated to save more than $100,000 per year life gained, or $28,000 per year of end-stage renal disease prevented. So this model showed that over 5 years, the low-protein diet approach, everything else being equal, saved 100,000 Rand per quality-adjusted life year gained. This is quite... this does require skilled dietetic intervention. It's not one diet. It's not a standard diet. It will depend on patient factors. So it's... I don't want to give the impression that it's a standard diet sheet, and I'll show you that standard approaches actually are not that useful in chronic kidney disease management. This is an abstract data from the NKF meeting in the States just this year, actually, which showed that compared to medical nutrition therapy and dialysis, there was a $47,000 saving per patient because of the effect of dietary intervention, skilled dietetic counseling, medical nutrition therapy in delaying the onset of dialysis for more than a year, reducing the medication burden for patients, and stabilizing biochemical parameters, which obviously also has a knock-on effect for medication management. What kind of dietitian do you need to have in your dialysis unit for it to make a difference? So this study from Lebanon looked at 3 different models for providing some kind of dietary support or dietetic support for patients in the renal service. They had the dedicated renal dietitian who was skilled particularly in management of chronic kidney patients and who spent 2 hours a month doing that kind of counseling and intervention, versus versus dietitians who were in existing practice, who weren't necessarily renal specialists, but who accepted patients in the hemodialysis program on referral. And then the third type of dietitian that was investigated was the renal trained dietitian, but who was not dedicated only to the renal service, but there was no limit on the number of consults or interactions that those kind of dietitians could have with the patients. And the findings were that dedicated renal dietitians were the most effective in the key outcomes that they looked at, which in this case was phosphate level. They were also the most effective at reducing global societal costs in managing these patients. They didn't have an effect on quality-adjusted life years, but the incremental cost of implementation was actually very low. So it was a low-cost investment with a high-value return for patients. And the use of dedicated dietitians for hemodialysis patients resulted in a general overall lower utilization of healthcare resources, presumably because of the combined impact of lower complications associated with that. The existing practice dietitians who were not renal specialists were not as effective as the renal specialist dietitians in lowering serum albumin. They were also not as cost effective because the impact on hypophosphatemia was not as much. But the renal trained dietitian who wasn't necessarily bound to the renal service but was available to patients at any time and as often as necessary turned out to be the most cost-effective approach for the outcomes looked at. So comparing the dedicated renal dietitian to the existing non-renal dietitian was more cost-effective and less cost-effective than the renal-trained dietitian. So there are different models for including dietetic specialization in your unit with different potential outcomes. Just a little word on protein energy wasting, which is extremely multifactorial and driven by many of the abnormal physiological factors associated with increasing renal failure. But data suggests that this is quite high among chronic renal patients, 20 to 60% according to reports. The importance of this is that it does impact on clinical outcomes. A malnourished patient does worse than a patient where you've been able to maintain nutritional status, both in terms of quality of life, which is a patient-related factor, but also associated with the morbidities and mortality associated with progressive renal disease. So what is the impact of nutrition in trying to manage the malnutrition indicators in this patient population? So here you're seeing the impact of providing an oral nutrition supplement specified for patients with chronic renal failure or chronic kidney disease on serum albumin. So on the left-hand side, you see that patients who received the supplement had significantly higher serum albumin over the course of the 6-month supplementation period. And on the right-hand panel, which I can't point to. On the right-hand panel, you're seeing that over the course of 6 months, the percentage of patients who had low serum albumin reduced. What is always a question mark, maybe in the minds of people working in renal services, is if I supplement protein to reverse malnutrition, I'm going to mess up the urea that I've spent ages getting right, or I'm going to mess up the creatinine. But that's not the case, and that's why you do need dietitians with renal training or with renal insight in order to achieve that. So you can achieve that. You can improve, for example, markers, and this is quite a gross marker of malnutrition, without damaging your renal parameters, your other renal parameters. Importantly, the group that received the oral supplement here ended up having a reduced dose of EPO by about 15%. So if you convert that to numbers in South Africa, EPO is roughly 4,000, 5,000, 6,000 rand a month. A 15% cost reduction is 600 to 900 rand month saving, up to 10,000 rand a year month saving, just for the dose reduction of one single drug for a patient who is in a chronic service. And this more than offsets the cost of the dietitian's intervention. This study looked at the nutritional intervention in long-term outcome in terms of survival. So the program I've summarized here in the blue block contained skilled nutritional education for the patient, nutritional counseling combined with oral supplementation if indicated. And the patients who received that pack of care ended up with those improved parameters, improved albumin or pre-albumin, creatinine clearance, improved lipid profile, improved nutritional status, biochemistry and electrolytes, and an improved NPCR in various subsets of renal patients, compared to the control group who just got standard maintenance dialysis and standard renal care. And the control group ended up with more hospitalizations for infections, cardiac events, and other complications, because these are exactly the complications associated with malnutrition in chronic renal patients, in disease-related malnutrition in general. Hospital length of stay was longer, but not significantly so. But importantly, there was a difference in the 2-year survival in patients who had received this pack of skilled nutritional care or dietetic care. So we know that medical funders are also redirecting from fee-for-service-based care to global fees or bundled payments or capitation-based payments, which are intended to improve the coordination of care. But importantly, it means that the provider is incentivized to actually reduce complications or avoid clinical complications, and to provide quality metrics to actually show the standard of care, the quality of care, by auditing demonstrable quality outcome markers or benchmarking service against what would be regarded as internationally acceptable standard. And so the inclusion of dietitians or dietetic services as part of this global fee or bundled payments reimbursement structures is now important to consider. So the value of adding dietetic professional services and medical nutrition services into chronic kidney disease management is potentially hugely cost-saving to a renal service, despite the cost of maintenance dialysis. So This paper suggests that there are enormous financial incentives to healthcare providers to firstly delay the onset of dialysis, where the main cost driver is. But value-based care models, which is also the way healthcare is moving, which include nutritional management, can slow disease progression, improve control of uremia, manage fluid balance, especially in the South African hot months, the summertime where it's very difficult, aid in anemia correction, and manage potassium and phosphorus load. So I'm showing you this quote: "The medical nutritional therapy implemented by trained dietitians is the quintessential component of integrated multimodal approaches that are effective and safe, as well as feasible and inexpensive." And dietitians are really inexpensive compared to specialist physicians or nephrologists or the dialysis itself. So what are some of the challenges and barriers to this? Medical nutrition therapy uptake or utilization in maintenance dialysis programs is sometimes as low as 10%, according to international reports, especially compared to the selection of patients who really require that kind of intervention. Only 50% roughly of renal clinical service teams actually include a dedicated dietitian or a renal trained dietitian who is available to provide dietetic services and nutritional care to those patients, and less than half of CKD patients had a doctor or other health care professional, which could include nursing staff in renal units, suggest that they see a dietitian. What is important is that the evidence on patient-based surveys suggests that patients who want to see a dietitian, who actually request referrals, are also much more motivated to be compliant with renal diets. And renal diet compliance is also dependent on the extent of expert intervention that they get. So dietary modifications can be challenging, they can be quite difficult to live with, but they can modify disease. The low medical nutrition therapy use is also suggested to be linked to the lack of referrals by doctors, based on the assumption that it will be an out-of-pocket expense for a patient, and therefore a patient that has to pay out of pocket shouldn't be referred, and that there is no reimbursement for medical nutrition care for renal patients in South Africa. This is absolutely untrue. Medical nutrition therapy and the associated dietetic consults are PMB level of care for patients with chronic renal disease in two different ways. They come up as a benefit for patients in palliative care, and they also come up as a benefit for patients in chronic disease programs. So various ICD-10 codes can lead you to this point of being able to access really comprehensive dietetic and nutritional care for those patients, and I'm happy to talk about that in more detail if you are interested. This might be a little bit small for you, but this is a survey of the attitudes of care providers in renal services as well as the patients receiving renal services, and asking various questions about medical nutrition therapy. Is it useful for preventing disease progression? Can it reduce the complications? Is it capable? Is a patient capable of making lifestyle changes so that they can reduce complications, etc.? So everything that I've shown you in the red boxes is the proportion of respondents who agreed or strongly disagreed. And with all these questions about lifestyle changes and the impact of medical nutrition, there was general agreement, strong agreement, obviously, with the dietitians and with the patients and medical providers as well. The thing that did not come up as a useful or perceived to be useful is nutrition handouts or apps or devices that gave standardized dietary approaches. And this is very true in renal patients, especially because the comorbidity cluster may be very different. Some patients may have improved diabetes since they've gotten to end-stage renal disease. You also have to think about veganism or vegetarianism or cultural food practices, which completely change how the dietary education and actual dietary management would be shaped. Some patients are more malnourished than others, some are well nourished. So the standardized approach is generally not regarded as useful. I'm ending with this quote: interventions do not necessarily need to be cost-saving to be considered good value for money, provided they provide guaranteed health benefits. And I hope I've convinced you a little bit, at least, that medical nutrition therapy and skilled dietary intervention can be beneficial in chronic disease management for renal failure. But in fact, medical nutrition therapy is also cost-saving in this group of patients. Thank you very much. I'm happy to take questions.
Thank you, Dr. Hill, for that excellent presentation. Do we have any questions for Dr. Hill? Yes.
So I'm not sure, I have not checked how the current dietitians that we've with have been living, but the reality for us has been that the patients were allowed one consult every 6 months in Panama. It still is as it is now. And I mean, that once in 6 months.
Yeah, I get you. It's not that valuable. Yeah, yeah. Yes, okay, thank you. So this is now, you're asking me the question, ask me for more detail. So this is what I'm going to tell you. So historically, the PMBs have never specified medical nutrition therapy benefits or dietetic benefits. So the PMB level care says medical or surgical management or dialysis, which means that the schemes have been able to interpret what that means. What is medical? Is medical management, does that include dietary intervention or only for transplant patients like some schemes seem to think? So there's been a process over the last years to define that and to put into the PMB definition that medical management of a chronic renal patient includes skilled dietetic consults and products, if necessary, to manage the protein energy wasting or to manage elements of the biochemical derangements of your patients. So there are now 2 regulations in place which are from the medical schemes regulator, have been put in place. The one is if your patient is in the palliative care journey. So that can be any renal code that applies, any renal disease, but you have to trigger that benefit by accepting that the patient is in palliative care because you need the palliative care ICD-10 code to trigger that benefit. If that benefit is triggered like that, the patient will get not one consult per 6 months, but the number of consults that the dietitian feels is necessary to treat whatever the referral problem is. So if the patient is very underweight or the patient has another form of malnutrition, the dietitian will determine how many times they need to see the patient. If it's for a biochemical panel management, the dietitian will determine how, and that will be reimbursed. It does have to be reimbursed based on the motivation of the dietitian, though. So maybe that's what's going wrong in your unit, that the dietitian has to motivate what the treatment plan is going to be, how many consults are needed, if any products are needed, and then that will be reimbursed. So the patient can't themselves trigger it. That referral process has to happen. The better news, though, is that by the end of this year, there will be a new guideline which will allow renal patients to access that exact benefit without triggering on the palliative care code. So they can just use their in whatever their in code is to trigger the same benefit. And we're also working very hard to streamline the motivation process so that it will hopefully improve. So I acknowledge that there has been some difficulty on that. We've been helping dietitians a lot to get the motivations right, but the benefit exists. The benefit does exist. Yes. Yeah, look, albumin is always very difficult in all clinical settings to know how to interpret that with reference to malnutrition. So it's also true, by the way, that even something like a BMI or the patient's weight is obviously very difficult to interpret in chronic kidney disease. So actually, the better tools are things that can look at body composition. And most dietitians have that available in their practices. So they actually will monitor lean body mass or skeletal muscle mass. And the machines that are available to do that now actually do account for excess body water and other things that make more sort of less sophisticated methods not as accurate. But lots of things could be a trigger, like a low albumin could be a trigger for a more in-depth assessment by a dietitian. So it will depend on what setting you work in and to use what tools you have. Yeah.
Dr. Hill, thanks again for a wonderful, interesting presentation. We really appreciate it. Thanks again to Sasha as well. We're going to break now for lunch, which will be down by the registration area. I'd like to encourage everyone to have a look at the stands and please support the companies who are supporting the Congress with their stands in the exhibition area. We will reconvene at this venue at 2 o'clock for a really interesting program on critical care and dialysis. So enjoy your lunch, enjoy the walk down to your lunch, and we look forward to welcoming everyone back here again at 2 o'clock sharp. Just hang on, please. Oh, lunch is outside on the terrace. That's a treat. Thank you so much. Thank you for that information. Thank you.
I just woke up from a dream where you and I had to say goodbye. And I don't know what it all means, but since I survived I realized wherever you go, that's where I'll follow. Nobody's promised tomorrow. So I'ma love you every night like it's the last night, like it's the last night. If the world was ending, I wanna be next to you. If the party was over and our time on earth was through,
recovery. There is one patient in Johannesburg, a 38-year-old female with uncertain genetics, who has got atypical HUS, was in end-stage renal failure on chronic dialysis, and has been getting ongoing complement blockade, who's now off dialysis but running a low GFR of 22. So the outcome is, as you can see, extremely poor. And at least, 33 to 40% of patients with atypical HUS will progress to end-stage renal failure or death, despite the use of other therapies such as plasma exchange or plasma infusions, and at least 80% will land up with end-stage renal disease, permanent renal damage, or death at 3 years after diagnosis without active and adequate therapy. So plasma therapy has been used quite extensively in atypical hemolytic uremic syndrome, but in fact is not particularly worthwhile or therapeutic. And despite intensive use of plasma therapy, at least up to 40% of patients will die or progress to end-stage renal disease with the first clinical manifestation. And the issue at hand is that plasma infusion will give the factor replacement. But to give plasma on a regular basis, if any of you have done it, is a very difficult issue because patients develop reactive disease to frequent FFP infusions. And plasma exchange is really to remove antibodies. And the only real condition that you would remove antibodies is if there's complement factor H antibodies, which in fact is not common as far as atypical HUS is concerned. A statistic of 65% of all patients die, require dialysis, or have permanent renal damage within the first year after diagnosis. And even with some patients who initially improve after plasma exchange or plasma infusion, such as the one case that I've listed, I think, in East London, those patients still have active complement activity and will be at risk for further atypical hemolytic uremic syndrome events. So what is the management? So what factors should be considered for the prognosis and management? Well, there's ongoing renal dysfunction, age at presentation, a clinical history of TMA, family history, history of renal transplant, extrarenal manifestations, and genetic abnormalities. So what factors should be considered? As I mentioned, it's the ongoing renal dysfunction, age at presentation, mortality rate is high among patients who received a diagnosis in childhood, and progression to end-stage renal failure is more frequent among those who receive diagnosis, in fact, as adults. The extrarenal manifestations, patients with atypical HUS are ongoing risk of extrarenal complications, and they can progress despite no overt thrombocytopenia or hemolysis, which may give you really a false sense of security. And remember that if you transplant a child with or transplant a patient with unrecognized atypical hemolytic uremic syndrome, you will almost definitely lose that kidney transplant to a future recurrence of atypical HUS. Genetic abnormalities, ongoing risk of end-stage renal disease, death and extrarenal manifestations, and subsequent TMA and graft loss after kidney transplant can vary among genotypes. And I think as more information is known about these complement genotypes and how they function, I think more information will help in medical management. But despite that, genetic abnormalities have not been so far identified in approximately 30 to 50% of patients. And prognostic information is not available for this population. So what is the evolution of management of atypical HUS? In the early days, atypical HUS was managed with packed red blood cells, platelet transfusion, management hypertension, and dialysis. There was very limited understanding of the actual complement disease. Kidney transplant happened, but the vast majority of those kidney transplants failed with a recurrence. Then plasma exchange and plasma infusion and plasmapheresis was tried. Combined liver-kidney transplantation came about mostly because of a lack of access to complement blockade, but obviously more recently with the availability in certain countries of complement inhibition, one can, if recognized early, keep these patients well and avoid their progression onto multi-organ disease and end-stage kidney failure. But they are going to need infusions, every 3 to 4 weeks of their lives. So as far as the treatment options are concerned, with plasma exchange and plasma infusions, in fact, there's no controlled trial showing that these are either safe or effective in atypical HUS, apart from perhaps a very small group of patients with complement factor antibodies. There are really serious complications in children and adults about giving plasma infusion or plasma exchange or plasma infusions on a regular basis. And despite that, about a quarter of these patients will continue to have severe manifestations of the disease. Dialysis in itself does not provide any protection from renal or extrarenal. Kidney transplantation is doomed to failure because of recurrence of the atypical HUS. Liver transplant, liver kidney transplant, the anecdotal reports, I think the first patient that we did here was the 13th done in the world, and the second one was probably the 16th or 17th done in the world. Most of that has stopped because of access to complement, and in fact, many of these combined liver kidney transplant patients didn't survive. Antihypertensives in themselves is pure medicinal. Packed red blood cells transfusions is really not enough. So my last slide is, what are the risk factor considerations for long-term patient management? One would be genetic abnormalities. So there's an ongoing risk of end-stage renal disease, death, extrarenal manifestations, subsequent TMA and graft loss after kidney transplant varies among genotypes. Ongoing renal dysfunction. Most patients with atypical hemolytic uremic syndrome are at ongoing risk of death or permanent renal impairment, even following recovery from acute kidney injury. Age at first presentation, it's highest mortality rate among children, whereas renal involvement is high in adults, although in our experience, most of the children have actually gone on to end-stage kidney failure. Clinical history of TMA. It just really demonstrates the ongoing susceptibility to complement-mediated TMA experienced by all patients with atypical hemolytic uremic syndrome. There's this large presentation of extrarenal TMA complications, and that may progress despite no overt thrombocytopenia or hemolysis, and a history of renal transplants. So if you have a patient who has lost a renal transplant with some signs or symptoms of atypical hemolytic uremic syndrome, beware of doing a second transplant because you're going to go down the same route again. So thank you for your attention. It's been a pleasure giving you this lecture. Open to any questions if there's any time available. So maybe one advice, if you come across a patient like this, is call a friend. Okay. Thanks.
if anyone would like to engage with Prof. Gottlieb, he will be at the AstraZeneca stand during the tea break. Thank you so much.
Good afternoon, colleagues. Welcome to our critical care session. We are running slightly behind schedule, but I'm sure we'll catch up as the session goes on. We've got some very exciting speakers lined up, but before we get to them, just a few housekeeping rules. Please mute your cell phones. You can scan the QR code for your CPD points once a day only. That's sufficient. And you will find them scattered throughout the venue and in the exhibition or registration areas. Tea breaks and lunch breaks will be in the exhibition hall, Hotla, and then there are 2 lunch symposia today. Just one other one, I was asked by the AV guys to please, for the speakers, not to knock your mics. If you can, just adhere to that. Thank you very much. I'll give over to my colleague.
Good afternoon, ladies and gentlemen. Our first speaker is Dr. Athena Salvador. She's a nephrologist at Netcare Olivedale Hospital in Johannesburg. She's a medical director at the Olivedale Renal Unit. She's also a member of the ISN, ERA, and the South African Nephrology Society. Her research interests are in ICU nephrology, CRRT, and acute kidney injury. Today, she will be speaking to us about the principles of continuous renal replacement therapy in the intensive care unit. Over to you, Dr. Salvador.
Thank you. Good afternoon, everybody. My topic, as it's been said, is principles of CRT in ICU. I'll be going through some basic concepts, going through the different modalities and prescriptions. So CRT is indicated for continuous solutes and fluid removal in critically ill patients. It's designed to replicate the kidney, but it's not the native kidney. There's no tubular function, reabsorption, secretion, and obviously no endocrine function. So the basic concepts of dialysis involve the solute removal, which is with diffusion, convection, and adsorption, and water removal with ultrafiltration. This takes place at the semi-permeable membrane of the CRT machine. Diffusion is the movement of solutes between an area of high concentration to an area of lower concentration through a semi-permeable membrane, and it happens down a concentration gradient until there's equalization of the concentrations on either side of the membrane. Diffusion is influenced by membrane characteristics such as surface area, thickness, porosity, solution diffusion coefficient, which is a function of molecular weight, and porosity thickness and porosity of the membrane, and also temperature. Convection is a process where pressure is applied across the membrane, and then there's water filtration that happens across the membrane, and with that, solutes move across. That's called the solvent drag, and it happens through a transmembrane gradient. Convective techniques is CVVH and SCAF. Convection is influenced by the ultrafiltration rate, by the degradation of the filter membrane, blood solute concentration and molecular weight, and the membrane sieving properties. Adsorption is the solute adherence of the membrane to the filter. We get clogging when there's high adsorption, and protein caking, which is due to electrostatic interactions. Proteins actually get stuck to each other and also at the membrane. Adsorption is the mechanism involved for removing inflammatory cytokines and mediators in SIRS and sepsis. Solute removal is dependent upon the molecular size of the solutes, the pore size of the membrane, and the ultrafiltration rate. The higher the ultrafiltration rate, the greater the solute clearance. Small molecules through the membrane are driven by diffusion and convection, whereas middle and large molecules are primarily removed by convection. The membrane removes solutes with a molecular weight of up to 50,000 Daltons. It allows water and some solutes to pass through, but it's impermeable to the cellular components and the bigger solutes. Proteins and protein-bound substances are also not cleared. So this is a diagram that shows the hemodialysis, which is a diffusive technique, and the clearance is for small molecules of 500 to 1,500 Daltons, whereas convection that happens through hemofiltration clears molecules of up to 20,000 Daltons. Ultrafiltration is the movement of fluid through a semi-permeable membrane. There's positive and negative pressures. So on the blood side, we've got the pressure that's generated by the blood pump, and on the other side of the membrane, we've got the negative pressure that's generated by the effluent pump. So the pressure difference between the positive and the negative, it's the transmembrane pressure, and the pressure difference is what pushes the water through the membrane. A normal transmembrane pressure is usually between 50 to 200 millimeters of mercury. So ultrafiltration is convective, and it's very similar to what happens at the glomerulus. As we said before, the pressures can be positive or negative, and it's influenced by the blood flow rate, by the transmembrane pressure, by the oncotic pressure formed by the plasma proteins and the hematocrit. So ultrafiltration is the movement of fluid from the intravascular compartment. Fluid is removed through ultrafiltration, and it's replaced by the plasma refill rate from the interstitium. If the ultrafiltration rate exceeds the amount of volume that comes from the interstitium, then the blood volume decreases, and that leads to hemodynamic instability. Our goal with ultrafiltration is to find the maximally tolerated ultrafiltration rate. The rate of ultrafiltration depends on pressure applied to the filter. The higher the pressure, the higher the ultrafiltration rate. Filtration fraction is a measure of the ultrafiltration. It is the volume of plasma removed from dialyzed blood by ultrafiltration. The formula is a ratio of the ultrafiltration rate divided by the blood flow rate corrected for hematocrit. A higher transmembrane pressure increases the filtration fraction, and a higher oncotic pressure decreases the filtration fraction. Purely convective modes of therapy, such as CVVH, have always got a higher filtration fraction than diffusive ones. So what happens at the level of the filter? The blood goes through. Ultrafiltration takes place and fluid comes out, and at the end of the filter, we've got a lot of hemoconcentration. The target is to maintain our filtration fraction at 25% to avoid clotting of the filter or clogging up of the filter. But for CRT, we aim for a lower value of around 15%. So to maintain a low filtration fraction, we keep the ultrafiltration flow rate low for CVVH therapies. We can increase our blood flow rate, the pump speed, and that would be dependent on how good our vascular access is. And we can use pre-dilution replacement fluid for CVVH-DF or CVVH. Indicators of the function of our circuit in terms of clotting is the transmembrane pressure drop, and the filtration fraction. The transmembrane pressure is the pressure difference between the blood compartment and the dialysate compartment. It's generated by the push of the blood pump and the sag of the effluent pump. A drop in the transmembrane pressure indicates a leak, and an increase in the transmembrane pressure indicates loss in permeability and filter clogging. Pressure drop measures the pressure in the blood compartment. It's a pre-filter pressure minus the outflow pressure, and a pressure above 200 millimeters of mercury indicates filter clotting. So vascular access is a prerequisite for any extracorporeal therapy, and our first choice is a right jugular vein, and the last choice is the subclavian vein. We need a functional access to deliver an optimal dose of renal replacement therapy. It's usually a double lumen. We need to get the correct French, which is 12 usually, and then we need the appropriate size for the vein that we're going to use. Usually 24 centimeters for the femoral, 15 for the right IJ, left 20, and right subclavian 15, and left 20. So fluid used in CRT is the dialysate fluids, which are crystalloids. They contain electrolytes, glucose buffers, and solutes, and our usually dialysate flow rates are between 600 to 2,000, but it can obviously go higher than that. The replacement fluids are also crystalloids. They are infused directly into the blood at a fast rate, and if they're infused before the filter, it's a pre-dilution technique, and after the filter, it's a post-dilution substitution technique. They increase the fluid flow across the filter and allow for a higher convective clearance. Sometimes we add electrolytes to the replacement fluids to correct for hyponatremia. They contain physiologic concentrations of electrolytes in a buffer, and fluid removal rates are calculated independently of replacement fluid rates. They can be pre, post, or both. Post-filter replacement solutions will deliver solution to replace the removed ultrafiltrate volume and replenish lost electrolytes. All replacement fluids are removed by the effluent pump. So pre-dilution happens at the level before the filter, before the blood enters the filter. And as you can see here, there's a hemodilutional effect. With this technique, there's less clotting of the filter, but we lose out on the solute clearance part. Whereas with post-dilution, there's more hemoconcentration. Our level of solute clearance is better, but there's increased risk of clotting. So the advantages and disadvantages of pre-dilution, mainly there's increased circuit life with pre-dilution. There's no ultrafiltrate limitations. They reduce membrane stress, but we have less solute clearance, as it was mentioned before. With post-dilution, there's higher solute clearance, but there's increased clotting and increased membrane stress. Time in CRT, effective treatment time is the time of where purification is ongoing. Downtime is when the treatment is stopped for various reasons, and the total treatment time is a sum of the effective and downtime. So there's 4 modalities that are actually we use, and it depends on which machine we use and whether we need diffusive or convective clearance. CVVHT stands for hemodialysis, CVVH for hemofiltration, CVVHDF for hemodiafiltration, and SCAF for slow continuous ultrafiltration. In all 4 modalities, water clearance is through ultrafiltration, and with dialysis, hemodialysis and hemodiafiltration, diffusion is used, convection is used with hemofiltration and hemodiafiltration. This is a schematic diagram of what happens at the level of the filter. With SCAF, there's no dialysis, there's no replacement fluid added. With CVVH, the fluid can be post or pre or both. With CVVHD, there's only dialysate, but no replacement fluid. And with CVVHDF, it's a combination of both. So with SCAF, there's no replacement solution, no dialysate solution, and the fluid removal is dependent on the patient's tolerance. With hemofiltration, it's mainly convection, and the replacement fluid is added for volume for the ultrafiltrate loss. There's no dialysate use. With dialysis, hemodialysis, there's no replacement fluids. I'm sorry, I have to rush up. I think I've got a few minutes left. And then no replacement fluids are required. Hemodiafiltration combines hemodialysis and CVVH. It's got a better filter life. It uses dialysate solutions and replacement solutions. So I just would like to go through the dose of CRT. I'm going to have to skip some slides. I'm sorry about that. So there's no trial that has demonstrated any clinical benefit of a specific modality. Actually, the delivery of the actual dose is what is actually important, not as much as the choice of modality. And then coming to the dose is a function of the fluid replacement, the dialysate flow rates, the treatment duration, the dialyzer, and the dose of the anticoagulation. According to KDIGO guidelines, we use 20 to 25 moles per kilogram per hour, but because of interruptions in CRT and downtime, the recommendation is to use 25 to 30. The dose should be frequently assessed, and prescription should be adjusted accordingly. So this is an example of a script, which I don't have much time to go through, but it involves the different part of the treatment. This is a CVVHD script, and that's basically what needs to be included. So ultrafiltration, once you try and stay below the 1.5 to 2 moles per kilogram per hour, and the blood flow, the pump speed should be around 150 moles per minute or more. And just coming to a few examples, I'll finish off now. An example of a CVVH prescription. The effluent rate, which is our dose, is a total ultrafiltration rate with a fluid removal rate. So for a 70 kg person at 30 moles per kilogram per hour, our exchange or effluent would be 2,100 moles per hour. This can be divided into pre or post, or all can be pre or post, or it can be used in a different ratio. If we actually use fluid removal of 100 moles per hour, then the script changes to 2,000 moles per hour and 100 moles per hour. Another example of CVVH script, the effluent is the dialysate rate and the fluid removal rate. Again, 70 times 30, 2,100, that can be dialysate. If we've got fluid removal, that would be an example of the fluid removal. And then for CVVHDF, it's a dialysate rate, the total ultrafiltrate rate, which is the replacement fluid rate, and the net fluid removal. And just to conclude, the rational prescription of CRT is based on an understanding of the basic principles of solute and water removal. Careful daily assessment of fluid input-output, nutritional needs, antibiotic dosing, and evaluation of achieved dose is necessary. And one needs to give explicit descriptions and prescribed dose to meet the goals of therapy with regard to the patient management and also the machine settings. And best practice is based on an individualized approach for each and every patient. Thank you for your attention.
Thank you for that fantastic talk, Dr. Savido. Our next speaker needs no introduction whatsoever. It is Dr. Wachtank Rekviashvili. Dr. Rekviashvili is the clinical head of nephrology at the Wits Donald Gordon Medical Center. He's a member of the South African Nephrology Society, and his research interests are kidney replacement therapy. Thank you, Doctor.
Thank you very much for a kind introduction. I just wanted to ask maybe they can do something about shaking the screen, because the screen vibrates and that might affect kind of the eye tiredness. But anyway, thank you very much. And I just would like to say that I'm virtually standing in for Dr. Jeff Beal, who unfortunately couldn't give this talk because of the family emergency. So I was notified on a short notice to help and replace him. So for those of you who attended this morning presentation at the auditorium, I'll be reusing some of the slides, and I think the topic by itself is quite overlapping. So anticoagulation in CKRT or CRRT, what we know very well is that the clotting is always there. Clotting is there whether we know it or not, and it starts obviously with microclots which are clogging up the filter, reducing clearance. We virtually can only pick it up very late, so it is significantly reducing the dose delivery to the patient, or it could be quite a major basically clotting which requires replacement of tubing and the filter. And that, as Athena says, results in a downtime, and downtime could be as long as basically 8 hours per day, depending obviously when and how it and what is the setup within the center where you're using it. Yeah. So consumable cost is also very kind of significant factor in this case. Anticoagulation, approach to anticoagulation differs from center to center, and I think it is important to have your own center approach and make sure you're comfortable with that. So what we know for sure is that anticoagulation adds risk of bleeding, and we know for sure that anticoagulation increases also complexity and the cost of dialysis. So there are two approaches. In some centers, they routinely anticoagulate everyone from the start. In the others, they prefer to give patient a trial of first 24 hours and see whether the circuit survives 24 hours without clotting. And I believe that second approach is probably reasonable, more reasonable. The reason for that is first you want to know the coagulation status of the patient. And number two, it gives you time to assess patient properly from going into the shock where basically that might affect your treatment, as well as the GIC and so on. So what can we do to basically support that circuit which is not anticoagulated, and the short answer to that is this, to prescribe dialysis properly or as well as we could. We know that blood flow, the faster the blood flow in CRRT or CKRT, the less clotting there is in the filter. There's no particular risk associated with increasing the blood flow. Why? Because the blood flow in this case actually serves the purpose of kind of maintaining the filter patency and the flow ratio, but not affecting the dose dialysis dose delivery as such and prescription. So here on the slide, I don't know whether this lays or not. It looks like I don't have a pointer. But in any case, basically, increasing the blood flow will unfortunately increase resistance within the quintal line or dialysis line and will start triggering alarms. So what we normally do as a good practice for a nephrologist or doctors attending to it before you go home, to make sure that a circuit remains patent, you need to try to lift up the pump speed to the speed which will allow you to go fast but still keep your line pressures within the optimal range, I would say comfortable optimal range, and therefore to basically avoid alarms, because frequent alarms will clot the filter even if there is no coagulopathy within the patient. So reacting promptly to alarms is actually quite helpful. The second point is to minimize hemoconcentration, and for that, as Athena said, we've got option of starting pre-dilution, CVV-HDF, and that is probably our preferred, and probably most definitely our preferred mode of dialysis up to now. For the last 20 years, we started every patient for pre-dilution HDF. At the time when we started, there was no particular guidelines or what the ratio should be between dialysate flow and substitution, pre-dialysis substitution flow. We came up with a figure 2:1, so 2 for dialysate, 1 for substitution. And I must say that one of the latest machines which was just presented for CKRRT has that same ratio. They put in a book and a manual actually. It works very well. And up to now we basically mostly getting away without anticoagulating patients. Obviously it comes at the cost of fluid. The problem in South Africa, the fluid is imported. It's very, very costly. And also it's not only fluid, using pre-dilution reduces the clearance of small solids. So unfortunately you will be clearing less of potassium, less of acids and so on, but at the cost of obviously higher molecular size substances which will be removed. And one point which is unfortunately very commonly forgotten is the temperature. With our mild climate in South Africa, I think it's probably safe in most of the instances to switch off completely the temperature gauge on dialysis machine and basically allow room temperature to cool dialysate a little bit, because cooler dialysate actually prevents the clotting. About saline flushes, particularly, first of all, there's no evidence, and I'm not a fan of it, and we don't use it in our practice. So this is just a list of the coagulation options for the patient classes, and they're very well known to you. Some of them are not even available in South Africa. I don't want to spend time on it. All I want to say that out of all this, only 2 are commonly used. And number 1 is obviously heparin, which is well known to us. And number 2 is regional citrate anticoagulation. So citrate is not new. Citrate anticoagulation was used by the blood bank probably for 100 years. You know that every dialysis, not dialysis, I mean blood packed cells unit arriving to us in hospital as citrate, which is keeping it preserved. But within the CKRT or CRRT circuit, this technology was used for about last 15 to 20 years, and is very well established globally. Probably 30 to 40 countries are using it. And it is actually recommended by KDIGO 2012, but unfortunately not approved by FDA. The fact that it's not approved by FDA doesn't mean that Americans do not use it. They do use it, but they unfortunately had to mix their own fluids within the hospital pharmacies. So we are quite fortunate in South Africa that our fluids come pre-mixed, and we've got specialized equipment for it, so we've got every reason to use it. So regarding the rest of the basically drugs and novel drugs and expensive drugs, unfortunately there is no sufficient evidence to support its use in CKRRT, and some of the centers, particularly in the US, they've adopted their own protocols and are successfully using it. So I'm in no means saying that they're not helpful. They are, but at the moment we have no evidence and no protocols for that. So what is the problem with the heparin anticoagulation? The biggest problem is that, unfortunately, heparin infusion is basically dosing is unpredictable because of the very complex pharmacokinetics. And dose variability leads to high incidence of bleeding, and bleeding incidence with heparin infusion is reported to be between 10 to 50%, which is actually very, very high, and that's actually unacceptable. So this is where the rationale comes for regional citrate anticoagulation, and it has been proven in multiple meta-analysis and randomized controlled trials to reduce the risk of bleeding comparing to heparin by probably 70+%. So it's between 70 to 75%, I would say. It's a major reduction. And also, on top of it, it does preserve your filter patency. So this is an amazing figure when it says only 3% of filters clot in 72 hours. So basically, in 72 hours, you'll be replacing the circuit, which actually has nothing wrong with it. And the dose delivery, because of the lack of downtime, like Athena told us, is actually 101%. And where is that 1% is coming from? It's interesting, but we believe that there is an improvement of biocompatibility membrane related to the citrate. So citrate might actually improve the qualities of the membrane. Unfortunately, there is no survival benefit, and there is no length of stay in ICU benefit, which is quite important for the funders. But it still is like a superior method comparing to heparin infusion from point of view of efficacy and from point of view of safety. So I just would like to bring your attention to, I would say, 3 or 4 main principles which are completely different from what we know about our conventional CRRT. And I think that will be the main take-home message here, that when you face in the machine, you need to think about these principles, because if you don't understand them, it's very easy to make a mistake and actually harm the patient with that. So number one is that we are not using fluid bicarbonate as a bicarbonate source anymore with citrate dialysis. We're using citrate as a source of bicarbonate. So that's number one principle. So normally we do have citrate in our system. It's in very low concentration, and our body easily converts it. The organs involved are the liver, kidney, and muscles. So the main emphasis is always on the liver, but it might be changing. And citrate metabolism may be insufficient in critically ill patient for the amount of citrate you put in after the filter. And because of that, patient might develop citrate accumulation or so-called citrate toxicity syndrome. So watch out for that. Number two principle is that every fluid which goes through dialysis filter, whether it's dialysate or is it your pre-dilution, should be calcium-free. Why? Because if you do not remove calcium, the citrate will not work. Basically, you cannot add additional calcium into the system. So you're dealing with completely different set of fluids. And lastly, the flow rates. So citrate anticoagulation is dosed per liter of blood. So let's say lowest recommended dose is 3 millimoles per liter of blood. So as soon as you increase your blood flow, blood pump, what you've done, you increase the number of liters going through the filter. So if you increase the number of liters, you need to increase the number of millimoles of citrate which will go there. So because of that, the pump, which is a citrate pump and blood flow pump, are fixed. The ratio between them is fixed. As soon as you change the ratio, you're not going to get a result. Okay. The rest of the fluids, unfortunately or fortunately, are also fixed, because if you're delivering bicarbonate-free fluid as a citrate, and then you need to compensate with given slightly different dialysate fluid, it also requires a fix. What I wanted to say in simple terms is that we've got two fluids, which is one is blood with citrate and another one is dialysate, which are actually not physiological to infuse as it is, separately. You can only infuse them when they're mixed at a particular ratio, and because of that, your blood and dialysate pumps are also fixed. So please do not come to the machine and change one pump and leave the others, because that will result in a major change of alkalinity or acidosis status of the patient. So that's one of the major another major principle for it. So here you've got two machines. On the left side, well known to you is Prismaflex. On the right side is a new Fresenius multifiltrate, which was launched about a couple of weeks ago. And the principal difference between the two is actually very small, and whether it relates to any particular new advances at this stage is difficult to say, but I just don't have my pointer. So you can see that Prismaflex uses 3-bag system. Why there's 3 bags is because your citrate on the left side is actually mixed within a bag as a pre-dilution fluid. Fresenius uses 2-bag system. Why? Because it delivers citrate separately into the system. So this is basically the only thing you need to know at this stage. And obviously with progress of technology and newer machines coming up with the more sophisticated processors and software, the safety features where it actually delivers the messages, diagrams, and tables to us to make sure that we do exactly correct thing, it's actually the biggest advantage of it. So this is the journey from citrate where it actually catches calcium within the filter, becomes calcium citrate. Most of this calcium citrate gets eliminated from the filter by dialysate, and some of it, probably within half or that region, is returned to the patient as calcium citrate. So if your body or the patient's body citrate metabolism is actually intact and managing, then what will happen that calcium will get released as an ionized calcium, and citrate will be converted to bicarbonate at a rate 3:1. So basically what it means that 1 molecule of citrate will give you 3 molecules of bicarbonate, which is a lot of alkali. So, and this is how the circuit works. On the left side, you can see that pre-dilution fluid for Prismaflex actually says 18/0. What it means is 18 molecules of citrate and 0 of the calcium, and actually 0 of the bicarbonate as well. So if you multiply 18 by 3, you've got the first bag with the fluid, which has 54 millimoles of bicarbonate. It's a highly, highly alkaline fluid. So infusion of that kind of fluid into the patient without compensation is totally unacceptable. So because of that, you use a dialysate fluid, which is low in bicarbonate. Normally, bicarb in dialysate is about 32 to 35, but in this case, you got 20. 20 is actually very, very low for any kind of dialysate fluid. So that is used to do two jobs. One job is to actually dialysate removes all the toxins together with that calcium citrate, which is in the filter. And number 2, it actually compensates for that alkaline fluid. So if in the middle of the night you're tired and you want to suddenly increase the clearance in a patient, normally what you would do in conventional dialysis, you would increase dialysate flow. In this case, if you increase dialysate flow, you're going to make patient more acidotic. Why? Because you're delivering fluid low in bicarbonate. So this is a principal difference which you need to remember. So this is an example, again, that you've got that first fluid, which is pre-dilution, where citrate is 18, bicarbonate is 0, calcium 0. Dialysate, which is also going to the filter, that's why calcium is bicarb, but post-dilution fluid is already normal fluid because this is given into the patient after the filter, not into the filter. So just to avoid mental gymnastics and to avoid fear of starting that particular technology, I think the manufacturers always come to rescue and then produced a very simple table for us. And that table basically says, well, how much is your patient weighing? Okay, it says 60 kilos. So, and it says if your patient weighs 60 kilos, then just to do the following setup. I believe this is now automated on the newer generation machines, and the third machine, which will be revealed tomorrow, at about lunchtime, there's a launch. You will probably see that that machine does it automatically as well. So you don't need to carry this table with you or keep it on your telephone. So as you see, the first 3 pumps, blood and dialysate, in this particular ratio, and every line, if you take it, is actually a fixed ratio. So what you can do in the middle of the night, if you're tired or if you're not sure what to do, you simply increase all the pumps simultaneously in parallel with each other, and that will be safer for the patient because you're not going to shift patient's pH or base excess with that. But you need to remember that you will be delivering more citrate to the patient because that is designed for the bigger patient. More blood flow, more citrate will get into the patient. So you need to watch out for so-called citrate accumulation syndrome. So this is basically a small diagram which tells you that it's not so difficult to prescribe citrate CRRT. Number 1, you need to decide on dialysate flow. Why? Because that predicts the dose of dialysis. in any CRRT. Then secondly, you need to match the flow as per protocol ratio, and protocol depends on the equipment you use and the filter you use, so I think follow manufacturer's protocol every time. Then prescribe the lowest possible citrate dose. As we discussed, it could be anything between 3 to 5 millimoles per liter. Start with 3. And check PF stands for post-filter. Post-filter calcium, the target is to reduce basically ionized calcium at the end of the filter by about a half of physiological value, or even lower, maybe third or quarter. So, and that you need to regulate depending on how long your circuit lasts. So obviously if your patient has some degree of DIC or any other coagulopathy, you will see that you might give the patient more. And obviously you need to adjust calcium into the patient, but calcium into the patient is delivered through the separate central lines. So like many cases in ICU, you need 2 central lines. So now it comes to monitoring, and some of you will say, no, I'm not going to do it because it's too complex. What I must tell you, it's really not complex and it's easy. And I think for nephrologists, I'm talking about not for the nursing staff, unfortunately, because most of it is done by nursing staff. And I must say the units we're working with are doing a fantastic job and they communicate very well. So post-filter calcium can be checked about within 5 minutes, almost immediately it changes after initiation of that of the technique. And then later maybe double checked about 6 to 8 hour intervals. And if you haven't changed anything, it could be done even at 8 to 12 hour intervals. On the patient side, the good practice is to check it within 1 hour or every 1 hour for 4 hours until you get basically steady state. And after that also the monitoring can be reduced to 8 to 12 hours probably even. So it doesn't include much of laboratory work. It's a blood gas machine. The only thing which we check in more commonly or frequently is calcium. And lastly, is citrate anticoagulation is good for everyone? And the question is, you need to choose your patient, unfortunately, carefully. Initially, we used to say that citrate anticoagulation or RCA is only for healthy sick patients because, you know, once you think about patients who's in septic shock or polytrauma, they all got adrenaline, they all got lactate elevated, they all got liver dysfunction, so it caused a lot of fear initiating, and that's why I'm calling that historical or traditional. That is actually from the current version of the up-to-date. It says that if you got hyperacute liver failure, how they decide it's acute or hyperacute, it's less than 7 days to development of liver failure with very high transaminases. And again, even up to this is cardiogenic shock. And what about other shocks? Why not other shocks? Then if you read deeply around it further, rather now that you understand that there's a different concept to it. And I think more clarity came to us after basically a publication of so-called LCAT study, which is a German-driven study where they looked at use of citrate in particularly liver failure patients. So citrate and liver failure. And they came up with the conclusion that liver failure does not affect metabolism of the citrate as much as probably peripheral tissues, and therefore shock with insufficient oxygen supply, leading to problems with aerobic pathway and mitochondrial breeding causes the basically citrate accumulation. So rather watch out for that. So the liver by itself always, as I said, still needs to be watched, but it's not a main contraindication or any kind of fixed contraindication to start in that. I'll be finished in a few seconds. So potential complications, we all know about complications, but here the difference is you've never seen that acidosis, metabolic acidosis as a result of conventional CRRT. Here it could happen if unfortunately your ratios between the first 2 pumps is incorrect, or if you start accumulating that citrate. Another important stuff is that magnesium also gets bound to citrate and flushed out from the filter, and that explains why some fluids, they have magnesium actually already in the fluid. Citrate accumulation is a scary phenomenon, but what I want to say is that when it starts, it gives the signs up front, and the first sign of it is usually that we will notice that patient requires more and more calcium supplementation peripherally, because the ionized calcium starts dropping. So that's early sign. So there are multiple stages which you can guess that you're going into that process. So it doesn't happen in 5 minutes, and you can take action on it. So first what happens is that basically calcium citrate arriving to the patient will not be metabolized, meaning the calcium will not be released. as an ionized calcium, and your citrate will not be metabolized. So first leads to drop in the calcium, the second point leads to metabolic acidosis. So once you've got that problem where you've got high total calcium because it's sitting there and not metabolizing, low ionized calcium, and metabolic acidosis, then it means that you ticked every parameter for citrate toxicity and citrate accumulation. And this is the message where you need to decide whether you stop the treatment or you try to reduce the citrate dose and actually readjust. The problem with reducing citrate dose is not going to give you immediate alkali supply. You know, it's the opposite. In that case, you might want to use the bicarbonate to do that. So in conclusion, the most patients will tolerate CKRT without anticoagulation, especially if you're using pre-dilution CUHT. And as I said, we're using 2-to-1 ratio. If filter cannot be maintained for up to 24 hours, then you need to think about anticoagulation. I obviously need to think about heparin and RCA. My choice, personal choice, will be RCA. And RCA leads to reduced risk of bleeding, less filter clotting, better filter efficacy, and delivered dialysis dose to the patient. But you still need to choose your patient carefully and remember the principles which we discussed. Thank you.
Thank you very much, Dr. Rekviashvili. Just have a small gift for you. Thank you so much. So our final speaker for the session will be Dr. Gloria Teki. Dr. Teki is from the Chris Hani Baragwanath Hospital and Wits University. She will be speaking about ECMO and dialysis. Thank you very much, Dr. Teki.
Thank you very much. Thank you for the kind introduction to speak. I was asked to speak about ECMO and dialysis, so this is going to be a brief overview of these two modalities and how they fit together. Fortunately, quite a lot of the work has been done for me by Dr. Savada and Dr. Rekviashvili, so we will work around what's already been done. I've got no conflicts or disclosures. Just by way of introduction, the whole concept of critically ill patients is changing, and as patients are living longer, more comorbidities, more complexities, we're learning how to manage much sicker patients. There's advances in care, there's advances in therapeutic modalities that are available to us, and so it's about appreciating how and when to use these treatments appropriately. The whole concept, if you look at the basic concept of critical care, is keep this patient alive as long as you can to address what the underlying insult is and to return things back to homeostasis. So two of the big modalities here are going to be your respiratory support, which is your traditional mechanical ventilation, but when that fails, having the ability to offer something more, which is ECMO, and your renal replacement therapy, which I think everyone in this room may be biased, but it's probably the most important of all of them. So what is ECMO? Oh, sorry, it didn't show my talk outline. So just to give you an idea of what we're going to talk about in the next few minutes, ECMO, what is ECMO? What does the circuit look like? What are the indications for ECMO? And then AKI and this close association with AKI and ECMO, which often occur together. What's the pathophysiology of that? And then to put the two together and say ECMO and renal replacement therapy, when, how, what are the technical considerations, what are the complications and outcomes. So in terms of ECMO, ECMO is one of the extracorporeal life support therapies, which is indicated in patients who have failed the traditional options of mechanical ventilation or anticipated to fail those options for both cardiac and or pulmonary support. So these are among the sickest patients in any ICU with a greater than 80% predicted mortality. And with that goes a very high risk of multi-organ failure, which you can anticipate in the patients. And as we've said, the goals of this therapy are similar to the other critical care goals: to allow time to address the underlying condition, time for the lungs and or heart to recover, and to prevent the effects of injurious mechanical ventilation. So what we know about mechanical ventilation is as soon as you have to be aggressive with mechanical ventilation, things start going wrong and they continue to go wrong. So what is the ECMO circuit? It's actually a pretty simple circuit at its basic, sort of when you break it down. You take blood from the patient, you run it through a centrifugal pump, and then you have a membrane oxygenator, and you take away the CO2 and sweep oxygen over, which is absorbed, and then you warm the blood up and return it to the patient. So that's a basic ECMO circuit. What are the types of ECMO? There's veno-arterial ECMO, which provides both cardiac and respiratory support. So you can see in the diagram, you take blood from the venous system, run it through your ECMO machine, and then put it back into the arterial system. Whereas veno-veno ECMO provides only respiratory support. You take blood from the venous system and put it back into the venous system in whatever configuration of central veins you like, which is what's shown in those images. So what are the indications for ECMO? So you're looking at patients with severe but potentially reversible cardiopulmonary disease, or as a bridge to definitive management, which is often surgical, transplant, valve replacement, etc. So these are the VA ECMO examples. For example, these are only examples, are anything like cardiogenic shock, but of acute nature, acute heart failure, and acute severe coronary syndrome, sepsis-induced cardiomyopathy, which you feel is going to be reversible, a drug overdose that's causing myocardial suppression, hypothermia, anything where you just need to buy time for recovery, or as a bridge to heart transplant. What are the indications for VV ECMO? So that's your acute respiratory failure. Commonly, as we saw in the time of COVID, your severe viral pneumonias, your bacterial pneumonias, ARDS, and seen, it's malaria season again, so we'll be seeing a few more of these very severe ARDSs. And also in some cases as a bridge to transplant. And then there's guidelines on when to consider ECMO in patients with respiratory failure. Contraindications: irreversible disease, poor prognosis, any reason why you can't anticoagulate your patient. So patients have to be carefully chosen, and the success of ECMO programs really depends on having criteria and sticking to them for which patients you choose to offer ECMO to. Just going on to this relationship between ECMO and AKI, as we said, these are the sickest patients, so you anticipate that they'll have multi-organ disease. Single center stats suggest that probably the majority of patients have AKI, 70 to 85% of patients, and that somewhere between 25 and 68% of patients end up needing renal replacement therapy. And that again depends on what your criteria are for selecting ECMO. Is it more a cardiac predominant ICU or more respiratory infectious conditions that you're treating? So what we do know also is that AKI significantly worsens mortality of patients on ECMO. So it's important that we have this time to reflect on what we can do for patients who are presenting with both. The mortality, the significant mortality that you see from acute kidney injury in the ECMO patients and the severity of disease, it's all probably tied up with the presentation, the sepsis, the hemodynamics, the severity of disease that you're dealing with in these patients. What is the pathophysiology of AKI in ECMO patients? Well, they divide it into patient-related and ECMO-related factors. So the patient-related factors are that we said sick patients, hemodynamic compromise, decreased cardiac output, hypoxia, tissue ischemia, fluid overload. We'll talk a little more about fluid overload and how deleterious it is. And then the fact that these are patients who've likely undergone very aggressive resuscitation, use of vasoactive agents, nephrotoxins, contrast agents, all of these insults to the kidney, sepsis, recurrent sepsis, systemic inflammation. And then this concept, which is a lecture on its own, which is a concept of organ crosstalk. We're learning more and more about how the organs talk to each other. And it's so many different pathways, including the neurohumoral pathways, etc., where these organs are impacting each other's work all the time. And when something goes wrong in one organ, you often see it reflected in the others. The ECMO-related factors, also quite significantly related to hemodynamics, ischemic reperfusion injuries, pulsatile versus continuous flow. With VA ECMO, you often use the continuous blood flow, and acute changes to cardiac physiology. What's quite interesting, actually, is that there is some postulation that ECMO, particularly VA ECMO, may actually improve oxygenation and perfusion, so it may not all be bad news for the kidney once the patient is on ECMO. And then it's the circuit. These are not biocompatible membranes, so there's inflammation, there's platelet aggregation. Your platelets drop almost immediately once you start a patient on ECMO. Coagulation problems, hemolysis, thrombosis, etc. So patient-related and ECMO-related physiological factors that are involved. So going on to how we combine these two, let's talk about when you start dialysis in a patient on ECMO. So, and why? So the first thing is, mostly it's continuous renal replacement therapy. The guidelines are that you can start any therapy you like, but it seems like most often you'd be going for CRT because you have hemodynamically unstable patient where the control and the sort of the options offered by CRT are superior, and any of the options that Dr. Savadow has discussed you can use with ECMO. What are the indications to start dialysis? So similarly to non-ECMO patients, it's your emergent indications, your refractory acidosis, hyperkalemia, fluid overload, and all your indications for emergency dialysis. But together with that, commonly RRT in patients on ECMO is started for fluid overload or the prediction of fluid overload, and that makes up more than half of the patients who are started on CRRT. And then AKI and correction of acid base. So how they found that was, it was called the KIDEMO study, and they sent out questionnaires to all the centers who do ECMO just to get an idea of what their prescribing practices were for CRRT. I wanted to spend a moment talking about fluid overload. Fluid overload, we're learning more and more, is the enemy of patients in critical care. Obviously, we have other enemies too, but this is one of the ones that is of severe concern. What happens as your patient becomes more fluid overloaded? All your systems are affected by this process. You get congestion of your organs. We know about the lungs with the increased pneumonias, ventilator-associated nosocomial pneumonias, ARDS, etc. All the lung complications. The heart is working against a higher afterload. You get more arrhythmias, more failure, especially sort of in those acute DCMO presentations with sepsis. And then all the other organs, you get a waterlogged kidney that doesn't do as well as it should, the same with the liver, the gut, you're not absorbing medication, you can't feed them early, which we know is one of the important aspects of survival. The brain is affected with encephalopathy, etc. Abdominal compartment syndrome, wound healing. I can go on for a very long time on this. There's many, many areas of the body that are affected by fluid overload. And the important thing with fluid overload is that the studies are starting to show just how significant the effect is on outcomes. So probably for every liter, and this is sort of a conservative estimate from the study, some have shown higher, for every liter that your patient is positive in that critically ill setting, your mortality goes up by about 10%. And it's very easy to become fluid positive, right? You've got to give them food, you've got to give them medication. There's a whole lot of things that you're addressing, and you've done this aggressive resus where initially it may not have been so easy to manage the fluids very cautiously. So fluid overload is very much a predictor of outcome. To extrapolate that to ECMO patients, there was a study that showed that on day 2 of ECMO, a positive fluid balance was associated with independent mortality when they corrected for everything else. And what was more worrying was when they looked at having corrected that fluid balance by day 7, that did not improve outcomes. So it's not even just about getting the fluid management right over time, it's about starting and maintaining the fluid management. And the reason I went a little bit off tangent and talked about fluid management is because there was a lecture this morning talking about timing of renal replacement therapy, and we know that in general ICU patients, in general patients with acute kidney injury, there hasn't been a lot of evidence to suggest that we should start early dialysis. Having said that, it's hard to extrapolate that to ECMO patients, which are quite a specific group of their own. There aren't any very large studies, but there were single center studies that said if you could start your CRRT earlier in your ECMO patients, you had better fluid balance, you could feed them earlier, and sort of nutrition was better, chest x-rays cleared faster, and you actually got them off ECMO faster. There's one meta-analysis that actually showed survival benefits to earlier initiation. But we don't, again, have all the data to support this at this stage. So looking at how to integrate these circuits, what do you do with the two circuits? And this is sort of it's quite an interesting problem because of the pressures, and we'll go through that just now. There's 3 different options to integrating your two systems. So you can just have 2 separate systems and they each neatly stay in their own box and do their own thing. So you run your dialysis separately from your ECMO. That's number 3 on this list. The advantage of that is that you have much more control over each of your systems. Disadvantage is everybody who works in an ICU will know that you're always running out of access points for central venous access. And there's also a bleeding risk if you have an ECMO patient fully anticoagulated and you now need to put in a Quinton line. Then the second one is to use an inline hemofilter, where you just put a hemofilter, a hemodiafilter into your ECMO circuit. It's cheaper than other modalities, but it's much more difficult to control your ultrafiltrate, so it's not one that we use very routinely. And then the third is to figure out how to connect these 2 machines to each other. So as promised, let's talk a little bit about the pressures. So you have 2 systems. You have this ECMO, which is a high-pressure circuit. You have a centrifugal pump, which needs to initially generate negative pressure to pull blood at 3 to 6 liters per minute. And it generates a pressure of -20 to -100 millimeters of mercury. And then after the pump, you need positive pressure to drive the blood through the oxygenator and back to the patient. And it goes of sort of 100 to 500 millimeters of mercury, usually around 300 millimeters of mercury. So a very high pressure system. Then you have CRRT, which is a gentle, sweet system with pressures of 0 to 20 millimeters of mercury, the same as the CVV pressures. And it has pressure alarms, because when the pressures go off, as you know, things start to go wrong in terms of clotting, or there's worries for air embolus, etc. So now how do you combine these 2 circuits? You have to figure this out in such a way to prevent life-threatening complications. The ones that we worry about are air embolism, flow disruption, and hemolysis. And I think if you talk to different ECMO techs, they may have slightly different opinions on what works the best, and there doesn't seem to be a lot in the literature to say exactly what the best way to connect these systems are. The 3 diagrams on that page are a little bit small, but they give you 3 of the common configurations of how the 2 machines are connected. But one of the common ways is to put the CRRT arterial, the access, connected to the ECMO after the pump, which is the positive side, and then to put the outlet or the return line into the negative part of the pump. And that way you reduce your risk of air embolism. Newer machines are better at, the newer CRRT machines are better at adjusting to ECMO. Some of them do it automatically, others there's a setting to do it. We'll see what this mystery machine tells us tomorrow. But I think it's something that is used more and more, so they need to work together. It's just a picture of people sticking lines together in a patient. And then anticoagulation we've talked about, so I won't spend much time on it. But we know that ECMO activates inflammatory and coagulation pathways, so you need anticoagulation most of the time. CRRT usually doesn't need more than what ECMO is getting, so you usually get away with what your ECMO anticoagulation is. And the options, as have already been discussed, most commonly used is unfractionated heparin, which you need to monitor. Low molecular weight heparin is used in some centers. And then if you can't use heparin, then direct thrombin inhibitors. Problem with them is there's no reversal agent, so if you start bleeding, you run into trouble. What's interesting is there's a couple of papers that have come out now about the concept of adding regional citrate to your CRRT machine. And it seems to really prolong the filter lifespan and reduce your risk of clotting without any negative outcomes to the patient. So this is an area that possibly we should be looking at. What are the outcomes and complications of ECMO plus CRRT? Essentially, it'll be the complications of all of it. The vascular access complications, the connections, we've talked about air embolism, bleeding, thrombosis, vascular injuries from putting in the access, and then all the hemodynamics that are going on here, the instability, the effects of those fluxes in blood pressure, the arrhythmias, interference of flow between the two circuits, hemolysis, turbulent flow, bleeding, we've said coagulopathy, the risk of emboli and stroke, electrolyte problems. The two big electrolyte problems are potassium and phosphate, which you need to look out for. And another question that's arisen is, what are the pharmacokinetics of your medications when you're dealing with these circuits? And we need to answer that question more fully. And then temperature regulation is another one. Outcomes, it's hard to say. Some of the studies say 80%, other studies say 39%. What they all agree on is that it's worse if you develop acute kidney injury, and it's worse with the stage of acute kidney injury. So if you need dialysis, your outcomes are worse. And I think your outcomes depend, again, on what kind of patient cohort you're dealing with. What are the predictors of outcome? Fluid status, as we've mentioned, has been shown in several studies to be a significant predictor of outcome, mortality as well as morbidity, and lactated CRRT initiation. What's interesting is that the studies suggested that CVVH had a lower mortality than CVVHDF. But again, I suspect that this reflects the severity of illness in the patients and the choice of dialysis mortality. The renal recovery of patients who survive is generally quite good, probably because a lot of this is acute and reversible, and more than 90% of patients survive. Interestingly, some of the studies showed 100% survival in patients given VA ECMO, and they attributed this to the better oxygenation and oxygen delivery to the renal vessels that you see with veno-arterial ECMO. So just to end off, what are the future directions? I think there's still a lot of work that needs to be done in figuring out how to combine all these life-saving modalities in the critically ill patient. But the first question is, how do we prevent acute kidney injury? There's a question we're always asking. It becomes specifically relevant in a patient who's got such a high burden of disease and such high mortality. So that's something to look at. Along those lines really is also early prediction of which patients are going to develop acute kidney injury and require renal replacement therapy. What's the optimal time for renal replacement therapy in ECMO patients? And how do we safely combine these two machines? What will be the developments that tell us how to use these two life-saving therapies together? What's the optimal anticoagulation? And as we said, what are the further data on pharmacokinetics and medication dosing in patients receiving these two modalities? So this was just a brief overview on ECMO and RRT. Thank you for your attention.
Thank you very much, Dr. Gloria Teki. We are going to go over to the question and answer sessions. I will just request that people that have got questions, please just come nearer to the mics. They are on the passage, and then just keep your questions very short and to the point, and also indicate to which speaker you are directing your questions to. Is there no questions for our speakers? Yeah, there's a question.
Good
Thank you
afternoon,
very much,
everyone.
sir.
Oh, sorry. Good afternoon.
You may
everyone.
continue.
Yeah. I would like to know maybe what's the benefit of the pre-dilution on a patient that is on ECMO, because the patient is on anticoagulation, and most of the time when we do the anticoagulation, we want to preserve the filter. Because at times you find that maybe when we do the ECMO, it gives a negative pressure on the machine, and we end up having a backflow maybe to the pre-dialysate bag or pre-dilution bag. So what is it that we want to achieve when we do the pre-dilution on an ECMO patient, especially CVVH modality? Thank you.
Okay. We'll give over to Dr. Teki to answer that. Yes, Dr. Teki is going to be answering that. Can I just please request that we all just come nearer to the mic so that we can just, so everyone just got a question, can just already come nearer to the mic.
Thank you. I think that with any other circuit, it's to do with flow and to prevent clotting, to add pre-dilution, especially if you're using low flows. But I'm not sure that answers your question fully. Is there anything else? Yeah. I think it's really very similar to a non-ECMO patient.
Yeah, thank you. Like with any filtration, so you basically try and, maybe I'm not familiar that much with the ECMO technology like Dr. Teki, but what I can say that you're increasing your convectional clearance. And convection comparing to diffusion would basically increase the higher size middle molecule clearance in hope that we're removing more inflammatory molecules as such. Why I'm saying in hope, because it's really difficult to prove in a clinical practice. And we heard some comments about it, the fact this morning as well.
Thank you very much. The next question.
Maybe have advice or experience with regard to the Echo 2R and the Omni machine and the inline circuits for CRRT with the Echo 2R facility?
Yeah. No, unfortunately, we don't have experience, but we're looking forward to it, yeah.
We do have time for one last question. Oh, okay. The question is, what is the quality of life of patients on ECMO?
I think the survivals are obviously, the first question is the outcome from ICU, the time to discharge. And usually it's quite a long road because you have all your critical illness complications and the sequelae that go with it. So it's quite a long road to recovery. The renal recovery is good, but overall the patient quality of life, I think it depends on sort of what the initial insult was, the duration in ICU, the number of organs that were affected, and the recovery can be very long, I think, for these patients.
Thank you, colleagues. We've reached the end of our session. Just another big thank you to our three speakers. Give them a hand. If you do have any questions coming up, maybe ask to them over a cup of tea. And then just a reminder to all the Renal Care Society members that tomorrow evening at 5:15 we'll have our AGM right in this venue. Thank you. Enjoy your tea.
next to you.
If the world was ending, I'd wanna be next to you. If the party was over and our time on earth was through,
I wanna hold you just for a while and die with a smile. If the world was ending, I wanna be next to you. If the world was ending, I wanna be next to you. I wanna be next to you. Sun is going down, time is running out. No one else around me. Steady losing light, steady losing my mind. Over shadows and gravity. Without you, there ain't no place for me to hide. Without you, there's no way I can sleep tonight. But I do love a little bit of peace and quiet. Without you, I keep slipping into my dreams. But there's no you and I. Love is how when I cry. I love you and I need you to set me free from all of these bad dreams. Waiting on the other side. Love is how when I cry. I love you and I need you to set me free from all of these bad dreams. Please come around, help me settle down. Heaven's having some cloud. Hey, what you waiting for? Something physical. I can do this by myself. Without you, there ain't no place for me to hide. Without you, there's no way I can sleep tonight. I do love a little bit of peace and quiet. Without you, I keep slipping into bad dreams. There's no you and I. No sound when I cry. I love you and I need you to set me free. All of these bad dreams. Waiting on the other side. No sound when I cry. I love you and I need you to set me free. All of these bad dreams.
tell me if there's a problem. Rather you let me know, so I can work on it, so I can work on it. Honey, if there's a problem, rather you tell the truth. To put my mind at ease when I make love to you. And I shouldn't feel like this so soon. Shouldn't feel like this so soon. Honey, if there's a problem, we can take it slow. And if you want to, baby, you can take control.
gasoline and groceries. The list goes on and on. This 9 to 5 ain't working. Why the hell do I work so hard? I can't worry about my problems. I can't take them when I'm gone. Here comes the 2 to the 3 to the 4. Tell them bring another round, we need plenty more. Two stepping on the table, she don't need a dance floor. Oh my, good Lord. Someone pour me up a double shot of whiskey. They know me and Jack Daniels got a history. There's a party downtown near 5th Street. Everybody at the bar getting tipsy. Everybody at the bar getting tipsy. I've been boozy since I left. I ain't changing for a check. Tell my mom I ain't forget. Woke up drunk at 10 a.m. We gon' do this shit again. Tell your girl to bring a friend. Oh Lord. Here comes the 2 to the 3 to the 4. Tell them bring another round. We need plenty more. Two stepping on the table. She don't need a dance floor. Oh my, good Lord. Someone pour me up a double shot of whiskey. They know me and Jack Daniels got a history. There's a party downtown near 5th Street. Everybody at the bar getting tipsy. Everybody at the bar getting tipsy. Everybody at the bar getting tipsy. Here comes the 2 to the 3 to the 4. When it's last call and they kick us out the door. It's getting kinda late, but the ladies want some more. Oh my, good Lord. Tell them drink some. Someone pour me up a double shot of whiskey. They know me and Jack Daniels got a history. There's a party downtown near 5th Street. Everybody at the bar getting tipsy. Someone pour me up a double shot of whiskey. They know me and Jack Daniels got a history. Got the bottom of a bottle, don't miss me. Everybody at the bar getting tipsy. Everybody at the bar getting tipsy. Everybody at the bar getting tipsy.
20 in my hands. Oh, baby, your touch, it hurts more than hangovers. No, that bottle don't hold the same regret. And my mother says that you're bad for me. Guess she never felt the high we're on right now. And my father says I should run away, but he don't know that I just don't know how. Well, if it's unhealthy, then I don't give a damn. Cause even if it kills me, I'll always take your hand. And it's unhealthy, they just don't understand. And when they try to stop me, just know nobody can. Still gon' be my man. Hey, 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 hey. Still gon' be my man. Hey, hey, hey. Oh, this party high gives me sleepless nights. It's a million times what I need you again. And I realize love twice as wide. It might look like pain, but to me it's bliss. All my friends they say that you're right for me. Guess they never felt the high we're on right now. And my sister says I should run away, but she don't know that I just don't know how. Well, if it's unhealthy, then I don't give a damn. Cause even if it kills me, I'll always take your hand. And it's unhealthy, they just don't understand. And when they try to stop me, just know nobody can. Still gon' be my man. Hey, 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 hey. Still gon' be my man. Hey, hey, hey. Still gon' be my man. Still gon' be my man.
my brother is blessed. Pray him for love. Pray Virginia wins. Pray I judge nobody and forgive me my sins. I pray we make it. Pray my friend to pull through. Pray as I take it, unto others I do. Pray that on your love, we pray with every breath. Though I'm in the valley of the shadow of death. And so we pray for someone to come and show me the way. So we pray some shelter and some records to play. So we pray we'll be singing bye-bye, yeah. Pray that we make it to the end of the day. And so we pray. I know some men that happen this way. And so we pray. I know someone that's something the best. And so we pray. I know someone will feel no pain until we make it to the end of the day.
I pray that love will shelter us from our fears. Oh, I pray you trust me. Let me wipe off your tears. Confront all the pain I felt inside with all the cards we were dealt in life. Pray I speak my truth and keep my sisters alive.
When the rise to the top gets lonely and everything moving slowly, man, I know my life ain't regular. Don't know if I settle down when everyone want control me, but I direct my own movie. Yeah, I know my life ain't regular. Leave it all to the power above. Ways heavy on my mind, it's still like I let it shine. What you do with your time's gonna make or break your life. When the rise to the top gets lonely and everything moving slowly. Yeah, I know my life ain't regular. Leave it
Street Brazil. Well, this year's gonna be called Calle Ocho. Que hola gata, que hola omega. And this how we gonna do it. Dale! 1, 2, 3, 4, 1, 2, 3. I know you want me. You know I want ya. I know you want me. You know I want ya. I know you want me. You know I want ya. I know you want me. You know I want ya. 1, 2, 3, 4, 1, 2, 3, 4. Rumba, sí, ella quiere su rumba. Rumba, sí, ella quiere su rumba. Si es verdad que tú eres guapa, yo te voy a poner gozar. Tú tienes la boca grande, dale, ponte a jugar. 1, 2, 3, 4, 1, 2, 3, 4. Stick to the track on my way to the top. A pit got it locked from goose to the locks. R.I.P. a big in Parker that he's not, but damn he's hot. Label flop, but Pit won't stop. Got her in the cockpit playing with bits. Now watch me make a movie like Albert Hitchcock. Enjoy me. You know I want ya. I know you want me. You know I want ya. I know you want me. You know I want ya. I know you want me. You know I want ya. 1, 2, 3, 4, 1, 2, 3, 4. Rumba, sí, ella quiere su rumba. Rumba, sí, ella quiere su rumba. Si es verdad que tú eres guapa, yo te voy a poner gozar. Tú tienes la boca grande, dale, ponte a jugar. 1, 2, 3, 4, 1, 2, 3, 4. Mommy got an ass like a donkey with a monkey, look like King Kong. Welcome to the crib, 305, that's what it is with the women down here. All the they don't play games, they off the chain, and they love to do everything and anything. And they love to get it in, get it on all night long. Dale. You know I want ya. I know you want me. You know I want ya. I know you want me. You know I want ya. I know you want me. You know I want ya. 1, 2, 3, 4, 1, 2, 3, 4. Rumba, sí, ella quiere su rumba. Rumba, sí, ella quiere su rumba. Si es verdad que tú eres guapa, yo te voy a poner gozar. Tú tienes la boca grande, dale, ponte a jugar. 1, 2, 3, 4, 1, 2, 3, 4. Baby, you can get it if you with it, we can play. Baby, I got cribs, I got condos, we can stay. Even got a king size mattress we can lay. Baby, I don't care what they say. I know you want me, you know I want ya. I know you want me, you know I want ya. I know you want me, you know I want ya. I know you want me, you know I want ya. 1, 2, 3, 4, 1, 2, 3, 4. Rumba, sí, ella quiere su rumba. Rumba, sí, ella quiere su rumba. Si es verdad que tú eres guapa, yo te voy a poner gozar. Tú tienes la boca grande, dale, ponte a jugar. 1, 2, 3, 4, 1, 2, 3, 4.
Can I call you baby? Can you be my friend?
Return to the Mac. Get up what it is, what it does, what it is, what it isn't. Looking for a better way to get up out of bed instead of getting on the internet and checking a new hit me get up. First shot, first strut walking. A little bit of humble, a little bit of cautious. Somewhere between like Rocky and Cosby's for the game. Nope, y'all can't copy yet. Glad moonwalking, and this here is our party. My posse's been on Broadway, and we did it all way. Chrome music. I shed my skin and put my bones into everything I record to it. And yeah, I'm on. Let that stage light go and shine on down. Got that Bob Barker suit game and Plinko in my style. Money, stay on my craft and stick around for those pounds. But I do that to pass the torch and put on for my town. Trust me, on my INDEPENDENT. This hustling. chasing dreams since I was 14 with the 4-track bustin'. Halfway across that city with the back crush shit. Labels out here, now they can't tell me nothing. Yeah, yeah.
All the crazy shit I did tonight, those will be the best memories. I just wanna let it go for the night. That would be the best therapy for me. All the crazy shit I did tonight, those will be the best memories. I just wanna let it go for the night. That would be the best therapy for me.
Sometimes I get a good feeling, yeah. I get a feeling that I never had before. No, I get a good feeling, yeah. Oh, sometimes I get a good feeling, yeah. I get a feeling that I never had before. No, I get a good feeling, yeah.
Yes, I can. Doubt, better leave. I'm running with this plan. Pull me, grab crabs in the bucket, can't have me. I'll be the president one day. January 1st. Oh, you like that gossip? Like you the one drinking what gossip.com. Now I got a word for your tongue. How many Rolling Stones you want? Yeah, I got a brand new spirit speaking and it's done. Woke up on the side of the bed like I won. Talk like the wind in my chest to that sun. G5 in the US to Taiwan. Now who can say that? I wanna play back. Mama knew I was a needle in a haystack. A whole body boy, plus way back. I got a feeling it's a rap. ASAP.
Sometimes I get a good feeling, yeah. I get a feeling that I never had before. No, I get a good feeling, yeah. Oh, sometimes I get a good feeling, yeah. I get a feeling that I never had before. No, I get a good feeling.
The mountain top, walk on water. I got power, feel so royal. 1 second, I'ma strike oil. Diamond, platinum, no more for you. That adrenaline, never giving in. Giving up's not an option, gotta get it in. Witness, I got the heart of 20 men. No fear, go to sleep in the lion's den. That glow, that spark, that crown. You're looking at the king of the jungle now. Stronger than ever, can't hold me down. 100 miles gunning from the pitcher's mile. Straight game face, it's game day. See me running through the crowd full of melee. No trick plays, I'm Bill Gates. Take a genius to understand me.
Oh, sometimes I get a good feeling, yeah. I get a feeling that I never had before. No, I get a good feeling, yeah. Oh, sometimes I get a good feeling, yeah. I get a feeling that I never had before. No, I get a good feeling.
rough, but lately I've been doing better than the last 4 cold Decembers I recall. And I see my family every month. I found a girl my parents love. She'll come and stay the night, and I think I might have it all. And I thank God every day for the girl He sent my way. But I know the things He gives me, He can take away. And I hold you every night, and that's a feeling I wanna get used to. But there's no man as terrified as the man who stands to lose you. Oh, I hope I don't lose you. Please stay. Decisions as I go to anywhere I flow. Sometimes I believe, at times I'm rational. I can fly high, I can go low. Today I got a million, tomorrow I don't know. Decisions as I go to anywhere I flow. Sometimes I believe, at times I'm rational. I can fly high, I can go low. Today I got a million, tomorrow I don't know.
Good afternoon, colleagues. We are going to start the next session. Okay. Afternoon, colleagues. My name is Vusim Kajwa, and I'll be co-chairing with Marisa Horn. And we are going to be sharing the session, which is deemed sustainability, water sustainability and renal care. Over to you.
Okay, I just want to share you the house rules. Please mute your cell phones. Scan the QR code for your CPD points only once a day. You will find them scattered around the venue or in the exhibition or the registration side. Please join us for the opening session in Injabulo at 5:15 this afternoon. This will be followed by the welcome reception in the exhibition hall, Khotla. And then the Discovery Wellness spots are in the exhibition foyer. They are accepting walks-in, so you don't need to be a Discovery member to actually be checked, to do your wellness check.
The first session is a pre-recorded one, which will be presented by Aisha Laher, who is the Vice Chairperson of Water Institute of Southern Africa and a water consultant for private hospitals. Over to you.
Good day, ladies and gentlemen. My name is Aisha Laher, and I'm here to speak to you about deterioration in water quality in South Africa and the implications for hospitals. I'd like to begin with an introduction to myself. My name is Aisha Laher, the Director of AHL Water. I have a BSc and a Master's in Water. I'm a professionally registered scientist. I have more than 18 years experience in water services, process, operations, management and water quality. And I serve also on the board of the Water Institute of Southern Africa, and I've served on the board of SACNAS, the South African Council for Natural Scientific Professions. My presentation overview is as follows: problem statement, water quality in South Africa, water quality in hospitals, solutions, and our scope of services. Beginning with the problem statement, a bit of an overview of what is currently happening not only in South Africa but in the world. According to the World Health Organization, while public water supplies are used with expertise, that is often not the case with water supplies within buildings. A general perception can be that water systems in buildings connected to public supplies are safe, ignoring the potential for contamination, both chemical and microbial, and growth of waterborne opportunistic pathogens within the building water supply system. So the COVID-19 lockdown highlighted the risks associated with stagnant water in buildings. There was no disinfection taking place while buildings were locked down, and there was were exposed to risks. Secondly, there is the regulatory authorities in most countries. They have oversight of public water services, but this is very difficult and more challenging when you need to regulate independently owned businesses. It's actually impossible to do that. Thirdly, building water supply systems are often managed by general maintenance staff and they don't have an understanding of water quality. And lastly, deteriorating municipal water quality, intermittent supply and insufficient supply also presents risks to water services in buildings. I want to just give you a brief overview of what the legislation is in South Africa so you can understand what the requirements are. So in South Africa, we have the National Water Act, Act 36 of 1998. And according to that, the Department of Water and Sanitation, DWS, is the custodian, the minister is, of all our water resources, and they are responsible for ensuring the resources are protected, they are used, developed, conserved, managed, and controlled. And they're also responsible as the Department for Oversight and Regulation. Under the National Water Act, you have the National Water Services Act, which talks about potable water. And the local governments, that is your municipalities, are responsible for the provision of water services, and they are the designated water service authorities in every municipality. Under Section 9, the DWS, the department, must provide appropriate norms and standards for regulation, and the Water Services Act also speaks about oversight and performance monitoring and Blue Drop and Green Drop compliance, which looks at the operations and maintenance of plants and water quality as well. I will explain that. Under the norms and standards of the Water Services Act, you have the National Drinking Water Quality Standard, which is the SANS 241 for potable water. This standard tells you, gives you a list of specific determinants with set limits, but it also looks at risk-based monitoring and an annual risk assessment required with incident reporting if there are failures against the set limits. And that is what the responsibility is of the Water Service Authority, to comply with the SANS 241 and to provide your water of that acceptable limit. However, although the response of the regulation is by the Department of Water and Sanitation, the standard does not extend to private buildings. So once the water enters the building, the regulation is not, the SANS 241 is not applicable, and the responsibility is on, the onus is on the property owner to ensure that the water is safe, there is no further contamination, and that wastewater is disposed of correctly. I want to just touch on the National Building Regulations and Building Standards Act, because that provides the promotion and uniformity of laws relating to the erection of buildings and the area of jurisdiction of local authorities for prescribing building standards and for matters concerned therewith. So why I'm talking about this, because these building regulations will speak about how your internal water reticulation network looks like, and it is regulated by the National Register for Compulsory Specifications, the NRCS. They're an entity of the Department of Water and Sanitation, of Trade and Industry, and they administer compulsory specifications, the SABS 10400, which talks about how you set up your building internal reticulation network of all the standards applicable to plumbing services, etc. And it is regulated by a building control officer that is employed by the municipality to ensure that when a building is built, that you do comply with these regulations and your internal reticulation network is compliant with that. But it only looks, the building control officer only speaks about the legislation prior to occupation, and the area of jurisdiction does not look at the internal water supply system, and they do not enforce any of these regulations because they're not applicable to water quality. The interesting thing is the National Regulator for Compulsory Specification says that water quality is not a risk to them. They believe that nobody has died from a leaking pipe, so they have not covered water quality in their building regulations. So we have a situation where the National Drinking Water Quality Standard for potable water stops where the building enters, and there is no regulation in the building to govern water quality. One of the other items that we have to look at is Legionella. There is a standard for Legionella monitoring within your building, but it is a voluntary standard, unfortunately. So the SANS 893 is there for you to conduct Legionella monitoring, to do risk assessments, to train your staff, but it's only voluntary, so you as a building owner can decide whether you want to comply with it or not, and there's no enforcement if you do not. There is also an issue with control of Legionella because you need 60 degrees temperature of the hot water systems to control your Legionella. But if you have to also put in thermoregulatory valves at taps so that the 60 degrees water does not come out of the tap because there's a risk of scalding to people if they use that temperature. But there is no regulation on what kind of thermoregulatory valves you must put in place, etc. So this is a risk that you have to look at, balancing the risk of Legionella growth. The temperature is not high enough versus that of scalding. The next point is about water quality in South Africa, so I want to just speak a bit about that. Externally, what is the issue with water quality? According to the Blue Drop report, I'm going to explain to you what that is. Only 49% of systems in South Africa have good water quality, and 51% have unsafe water. In addition, once the water leaves the municipality, there is also some contamination in the reticulation network, and there's also a lack of reliable supply. Anyone living in Johannesburg knows that, and it's due to aging infrastructure, loss of pressure, intermittent supply, and that also leads to water quality issues because you get ingress of contaminants when there is no supply. Also long residence times in retention in the network, so there is insufficient disinfection. Illegal connections can also give contamination, theft and vandalism, and also lack of maintenance. So there's a number of issues when the water gets to you. So municipalities, I want to talk about Blue Drop and Green Drop compliance. There is a legislation that is put in place by the Department of Water and Sanitation. The Blue Drop program is put in place to identify and develop core competencies within the water sector that will ensure water quality compliance. So there's a Blue Drop program that is run by the department where audits are conducted of all municipalities against key set KPIs based on legislative requirements, and that also includes water quality compliance. These audits are conducted of all the municipalities every second year. It was not taking place for a number of years, but it is now resumed. And the latest results are then published for you to have a look at, and I will give you the results that were published in the 2023 Blue Drop report, which has got very interesting information in it. So you can download that and you can have a look at that information. So the Blue Drop report evaluates municipalities against a number of KPI, and this is the grading for all the water service authorities in South Africa. So we're looking at either those that are in a critical state or those that are in a very good state, and that's the blue ones that we're looking at. So remember, this was an evaluation done in 2023 of all the municipalities in South Africa with regards to their water services provision. It looks at water quality, it looks at monitoring, it looks at asset management, it looks at skills, it looks at financial management as well. So it includes water quality. So if you just look at the map that is provided here, there's very few blues that show excellence in the country. There's a lot of reds and yellows, and there are more than 277 systems that are municipalities where water quality, water services is in a critical situation. If you look further in this report, it also talks about water quality compliance. So the national water microbiological compliance in the country is very poor. As you can see, more than 50% of the water supply systems in the country are not safe to drink. There is also compliance for acute health determinants is also not looking good. Acute health determinants means that if you these are other chemical determinants that can be in the water, and if you ingest them, you can get sick and you can die because these are acute health ones. So the compliance is not good where that is concerned as well. And remember, this is the 2023 results. And then there is also chronic health determinants that are monitored, but these look quite good, that it seems like there is good monitoring. But there's an issue with this. So there's two things that are monitored in the Blue Drop, and according to the SANS 241 drinking water quality, it's the actual quality of the water against the set limits, but also that you monitor the required number of determinants, and you monitor the required frequency. Because if you have given me one set of analysis that says you have got no chronic health determinants, I can't trust that, because you were supposed to monitor on a monthly basis. And you can see this table is also taken from the Blue Drop report. And what I'd like to point out to you is the percentage compliance monitoring. That means, is the municipality monitoring the required number of determinants as per the required frequency to evaluate the quality of water at all points in the network? And if you look at the compliance, it's very low here. So compliance monitoring is a monthly monitoring that the municipality must undertake and provide that information to the department, and the number of points that they monitor depends on the population. And that means these results that we see here is actually based on very low number of points, of sample points. So they're not monitoring correctly, and with the data that we have, the results are also not so good. So we are sitting with a huge problem with lack of information, and the current information showing the water quality is not safe. So what do we do about this? So what you can do is, you can go to this website. It's the Integrated Regulatory Information System of the Department of Water and Sanitation. You can click on the link, and it will tell you, it will give you all the water quality data in your area so that you can see what is happening. This is the information that is uploaded directly from the Laboratory Information Management System of a lab, an accredited laboratory that is appointed to do this this monitoring, and they upload it so you can trust that data, and it's updated every month. So I have just clicked on one of the links, so you can go to that link and click on overview, and this is what you will see. This tells you what the acute health compliance is of all the provinces, and the guide is easy. We want blue, and you can see there's very little blue. The MRP value tells you about the monitoring compliance, and you see that is very low as well. So you've got poor quality results based on lack of information, and you cannot trust them. You can further click onto each and every one of them, and you will get the results for that province. And I have just clicked on it and showed you what the Gauteng one looks like, and you will see there is some reds over here. You can further click onto the municipality itself, and it will tell you all the supply systems and what the quality is, and that is updated on a monthly basis. So please go and see whether you have clean water coming into your supply system or not, and this information is available to you. The link is in the presentation. So I'm going to talk a little bit about water quality in your hospital. So within your hospital, you also have problems. So you've got lots of things happening in your building. So I'm not going to go through all of this, but you will see that there are issues with point of entry. You can have contamination. You can have issues with your water in your solar system. You may have booster failures. You can have issues with your hot water system with thermal stratification, risk of scalding. You can have issues with your cold water system where the water is stagnant. You can issues with outlets where you've got these point of use applications where there's contamination, they're not working properly, there's no maintenance. You can have all kinds of issues associated with your pipe work. You have dead ends, you've got cross connections, you've got faulty pipe works, you've got pipes that are aging, etc. And you can also have issue with your treatment system. So you may have poor water quality coming in. You can also have water that is deteriorating within your supply system if you are not looking after it. So when I was looking at this water quality for buildings and looking for you in particular with regards to dialysis, I was trying to do some research online, and I came across this from the CDC government because I was trying to understand what is dialysis and what is the water uses that you need for dialysis. And can you imagine, there was this question that was asked, can we dialyze patients during a boil water advisory? And they said, no, you cannot. So what is shocking to me is that we've got water quality failures in South Africa with more than 51% of our water supply systems are not safe to drink. But have you ever heard a boil water advisory in any of those areas? I have not. And there is no boil water advisories that are issued by municipalities as reported in the Blue Drop system as well. So this is a huge risk. You don't know whether the water is safe. There is no boil water advisories. And what this boil water advisory also says that when you have a pipe break anywhere in your reticulation network, say you're living in Johannesburg, there's a pipe break, we know that happens every day. When the pipes are recommissioned, they do usually a shock treatment of chlorine that comes through the water supply system because they need to kill the pathogens that may have been introduced while they were working. They need to issue a boil water advisory because that chlorine is dangerous to dialysis patients. But if we don't know there was a pipe burst and we don't have that, then you are definitely on the back foot with regards to water quality for dialysis patients. So looking at water for dialysis, minimum standards, I learned that there's two kinds of dialysis when I was doing this. There's HD and HDF. And I believe that I've also learned that there is different standards with regards to the quality of water that you need for dialysis. So there's very strict limits with regards to the quality of water that you need specifically for dialysis, because this will definitely present a serious health risk to your dialysis patients who are already immunocompromised, and they need to stay clear of any pathogens. So the water that you need is supposed to be for dialysis is very clean water. So there is a standard that is the minimum requirements that is covered under your South African Renal Society guidelines, and it's got particular allowable counts for total viable counts. It's got a level for action level for total viable counts when you need to act. It's got an allowable level also for your endotoxins. So these are the limits that is according to the Renal Society's guidelines. But then there is also stricter guidelines that is in place that comes in from international best practice, usually for the HDF standards, but is recommended, and that is according to your ISO 23500. And as you will see, the limits are much more stricter than what there is for your dialysis. So it's important to understand that if you are putting water into your treatment plant, you're using municipal supply of water, and you need to ensure these limits. You need to understand what the actual type of treatment that you have, what kind of system that you have in place. So there's definitely specialized requirements for the type of dialysis that you have. There's stricter limits for HDF due to the infusate that goes in there. Your South African standards are based on the minimum requirements applicable to the HD process. And when you are getting water for your dialysis, you definitely, I think, require specialist knowledge of the dialysis process, standards, and treatment technologies. Because it's quite a complicated process. You need to understand what limit are you working with, what are you trying to achieve as well with regards to this. So some solutions I'd like to just propose. So solutions for water services challenges in buildings. You can do a water quality risk assessment to identify if you have water quality risks in your hospital. You can do routine monitoring, incident management, and then you can also do additional treatment to get the water quality, if it's poor, to potable limits. So you can do some on-site treatment, point of application, etc. And obviously with regards to your dialysis, it depends on the type of dialysis, the water quality limits based on international best practice, or do you want to use the South African standard? And I think what's important here is the cost of the water treatment, because if you want the stricter limit to ensure the safety of your patients, but it comes at a cost, so you need to weigh the cost of your water treatment for dialysis versus your patient's health. And always remember that when you do any of these treatment, you have to ensure there is legal compliance, there is design assessment of the systems, there is Blue Drop operational compliance with regards to the National Water Act for operating such systems, and also some management and O&M contracts that is applicable when you're putting in specialist water treatment processes. So I just would like to show you for an example of how you do a water quality assessment in your building. You can use the data I've showed you under IRIS. That is the website of the department, and it categorizes the water quality based on colors. And what you can do, you can use this information and classify the water quality based on where you are located. And you can get something like this. You can have risk category A, where you've got good quality water in your building. in your hospital, so you don't have to worry too much. You just do some routine monitoring to verify the safety. Or it can be that your water quality, you need to address that because there's insufficient data and you don't know what the water quality is, so you need to develop some kind of monitoring program. Or you can also say that according to the IRIS information on the Department of Water and Sanitation's website, the water is not safe. So what you would do then is you would implement monitoring and some kind of treatment. So this is an example of a water quality monitoring program that you could possibly implement if your water is not safe. So you go to the department's website, you see that the water is not safe to drink in your area and you are worried about that. So you can implement an internal monitoring program to verify the safety of the water and also to maybe implement some kind of water treatment processes. And what you can also do is something that I find quite useful that I advocate to my private clients is the use of the iLab water testing kit. It's a kit that's similar to a swimming pool kit, but it's not a swimming pool kit, people. It is tests that are can be conducted by anyone on site. There's a booklet, there's a dashboard in which you upload your results and tells you if the water is safe or not. But these tests are very strict. They've been based on international standards. And it's what's very helpful. It's a valuable kit to verify if your water is safe, and it will tell you if there's pathogenic organisms. So one of the kits is a Petri film. It tells you if there's microbiological contamination, your water quality. Your manager can do it. He just takes a sample, he puts it on the Petri film, leaves it for 48 hours, and if there's spots, your water is not safe. So it's just a good way for you to monitor that internally. And once you see that it only monitors a certain number of determinants. But therefore, when you see that there is failures, it tells you that you must take your water quality, you must send it to an accredited lab and verify the safety of the water, and then you know what to do. But it's a good way to check the water quality at your hospital. So I just want to conclude by talking about what we do as a private company. We give services to water and wastewater to private companies as well. We do water quality assessments, water quality compliance monitoring in buildings. We develop monitoring programs. We develop incident protocols for buildings. We also do site-specific water augmentation. We can advise you on a water risk mitigation strategy. We can do feasibility studies for you for whether you want to use groundwater, augment water, upgrade your treatment supply system. We do legislative requirements for all of these water treatment plants, operational models, operational excellence, whatever you need to do to actually implement an alternative water system. And we also give O&M support by doing manuals, strategies. We evaluate treatment technologies. We do contract reviews if you're appointing a service provider to do any water treatment for you. And we also do water safety plans in buildings. Some of our clients include Netcare. I've been working with them for the past 7 years, helping them develop a national water risk mitigation strategy to augment water supplies, advising them on the operational requirements, the legal requirements, reviewing service agreements, level agreements, bylaws, compliance, etc. I work with Murray and Roberts Water to provide water during the 2010 issues. We supplied in Cape Town, so we supplied a containerized water supply system for a hospital in Cape Town. I've done other private companies, Martitech, Organica, GSK. We've done legal compliance audits, independent reviews of the technology, helping them with legal compliance audits as well. And then I've also been the main author for Water Research Commission report into water use efficiency and water safety in buildings. And in that publication, I can send the link if you want to. There's a great guideline to how you conduct a water risk assessment of your building and how to identify the risks and to mitigate the risks. And there's a whole lot of detailed procedures on how to do a risk assessment for yourself in your building and procedures for best practice for disinfection and for checklists. So that's all for me. Thank you very much. I hope that I've provided some information. You're welcome to contact me if you need any other information about water quality in buildings or any assistance in answering questions in this presentation. Thank you.
Okay, and our next speaker, he's Francois Ackerman. He's got more than 20 years experience in the technical field. He's from National Renal Care Cape Town. And his talk is going to be about advancing sustainability through continuous innovation about raw water usage. Johan? Francois, sorry.
Just figure this thing out. Afternoon, everybody, and thank you for the opportunity this afternoon for me to share a couple of projects that we've recently done and completed within NRC, but more specifically around the water portfolio. But as we heard this morning, green dialysis, sustainability, carbon emissions, and the list goes on. It is this massive, big, daunting task. But and this morning, a colleague of mine actually sent me a message, and he said to me, in the words of Obama, the former president of the United States, get that one wrong. We are the first generation to feel the effect of climate change and the last generation who can do something about it. And that's quite big words. And we as an organization has also taken that to heart. And we've unpacked our sustainability and we've looked at what we can do to reduce our footprint, to reduce our carbon. And yet, it is a daunting task. It's a massive, big task. And we've broken that down into smaller categories to actually understand where do we want to put our focus, and what is the end results that needs to be. Environment. If there's a drought, everybody looks at renal, and renal is the highest water uses in hospital. And we looked at it. How can we assure our landlords, how can we assure our stakeholders that we are in actual fact utilizing water sparingly and that we can actually account for every drop of water coming into our facilities? We also looked at electricity. We've looked at economical within our facilities. What type of lights do we use? What type of geysers do we install? And are they as economical as possible? And we've looked at waste, and we've looked at our waste generation, and what do we do with it? But all those points is categories on its own, and I can possibly be here for the next 2-3 hours just discussing that. So based on water, I would really like to share a couple of points that we have gone through now. Talk about sustainability, and this was in a major drought in the Western Cape. Now, there's a couple of things wrong there. Sustainability, diesel truck carting up water up and down, not the ideal way to go. But now, you can't see me, but I'm standing right behind the truck. And the day when I was standing there, the thought dawned on me. There's 10,000 liters of water, raw water, that I'm looking at. How do I assure that every single drop of that water is used correctly? And we went back to the drawing board, and we looked at water as a critical point within our dialysis facilities, within any dialysis facilities for that matter. And we looked at the various categories, and we looked at how much water can I store to assure that I can give continuous dialysis. Secondly, we looked at alternative water sources, drilling, getting water, extracting water, balls, etc. But the question again came up. We've got 10, 20, 30, 50,000 liters of water sitting there, but how do we know we are in actual fact using it sparingly? And then possibly, I think the point that should have been number one is ultimately the quality of water that we do produce and the quality of water that we treat our patients with. Just to quickly recap on buffer capacity. It's a very complex thing to keep water and to store water. And one thing that we've learned, and sorry guys, I'm from the Western Cape, visiting your beautiful Joburg a little bit, but when we look at the drought in the Western Cape, and the last point there, theft and sabotage, one of the points that stood out to us a lot. Because remember, when there's a severe drought, when there's water outages, water becomes the most sought after commodity. And we went back and we looked at the source of our water, and we said, when we do use water, how do we produce it? How do we produce our water? What systems do we use? And how do we account for all our waters? And yes, the predominant system that we unpacked was based on your direct feed systems. We all know direct feed system. Water is brought in, we produce it, and we send it straight to the loop. Returns back, and we reprocess it again. We then looked at the very old traditional post tank system, or indirect feed system, also known, and we looked at that, and we also went and looked at your more intelligent systems, the fancy big systems that can control your water. But the biggest question around that was, what do we do with our existing infrastructure to still be able to reduce our water usage and our thirst for water? And we unpacked it a little bit more. And went and we looked at the direct feed system. And I'm not going to give you a lecture on different RO systems here today, but some of the points, and if you look at the advantages and the disadvantages of it. Advantages, yes, there's ample advantages. And bearing in mind, this is just a couple of highlighted points. This is not even the criteria behind it. But the biggest disadvantage point that is shown there is continuous water production, irrespective of your patient count. To translate that better, if I've got a 10-bed dialysis center, one patient, my RO still produces the exact same amount of water. All this buffer capacity you've got, you are burning through it quite rapidly for one or two patients. Or otherwise, the moment you switch on your RO, it starts producing water, irrespective if you're dialyzing. We then went to one of our sites and we took a direct feed system. And the brief there was quite simple. What is the best possible utilization that we can get out of that system? And there you can see 49.38%. That was our best utilization ratio that we could achieve out of it. And this was based on almost a 3 months long study. Technicians continuously on site, calibrating the machines, making sure how much water we push through our membranes, our regen time periods, etc. And initially, we were running around the 30%. And they were able to push that up to 49%. Max. We then went and we said post-tanks. Isn't post-tanks then the solution? Because bearing in mind, as I mentioned earlier on, existing infrastructure and what do we do with it? And the first thing that came to mind, again in the middle there, and the advantages, supply and demand only uses required volumes. So in other words, I've stopped producing unnecessary water. I'm using that what we are actually producing. That is the volume of water that we're using. And we asked the question, how do we marry the two? How do we bring in a post-tank system or indirect feed system and marry it with our direct feed system? And we did a study at another facility in Eersterivier. Directly after the installation, now the bottom section there, that is all the additional plant equipment that we installed based on our existing plant. And immediately we achieved an 81% utilization ratio on our plants, which is massive. And we will carry on a little bit now, and I want to share with you what we found. Now, firstly, we went and we ring-fenced specific centers within the organization so that we can focus on them. And that's specifically in the units where you still got a useful life on your existing RO plants. All the rest were replaced with new ones. But when we looked at it, our average water usage across the isolated or the identified plant rooms, 18,000 kiloliters of water that we've used. But also what we've seen is your usage of it is uncontrolled. It spikes, it jumps up and down. Some months you'll run around the 20,000 kiloliters, other months it'll drop down as low as 15,000 kiloliters. There's no control. And again, we heard this morning as well with regards to green build. You have to be able to get a stable line. And there you can see, if you look at the first thing, that is your spikes that you get, and that is based also on a direct feed system. And this was a study that we did 14 months prior to commencing the change over into this new system. And as you'll see there, we're running at quite a high volume, but also running majorly uncontrolled on it. We started then with the implementation of the project. Initially, doing a desktop study on it, it sounds easy. It sounds, clap a pump or two down there and we're good to go. But it became much more complex than that. We continuously have to do training. Our technicians, our engineers installing it, had to be trained up on the different systems. We had to train them on how to reconfigure an RO plant. Because remember, your footprint increases. You don't, and none of us really got all the real estate to put massive big plants in, so you still got a very small section, and you still need to be able to fit all those groceries, everything into that section. And we had to do a lot of trainings. We had to import all the equipment to do it. But that was during the installation. about a 90-day period that it took us, but the whole project, the installation project, especially in the outlining areas, took us about 6 months to complete it. Directly after it, we saw, within the first couple of months, we saw a decrease in our water utilization, our raw water utilization, that dropped down to about 28%, that we've reduced our water that we are pulling off the grid. Dropped it down to 13,000 kiloliters. However, we still saw spikes. The spikes wasn't gone. There we can see it dropped down, but it's all over. It looks like someone with a glass of water driving over a gravel road. You just can't manage that when it looks like that. And we went back, and our engineers went back, and they tested pressure, tested settings, and they looked at what are we, again, looking at all our membranes, looking at the loop pressure, fixing up leaks, educating the staff on when to switch on, when to switch off equipment. Don't run your RO hours before the time, etc., etc. And once we did that, and initially on a desktop exercise, I estimated between 5 and 8% that we can still save additionally. And yet when we ended with that, when we were able to flatline it and actually control our water usage, we saved an additional 12.48% water on top of the 20-odd% that we did. That gives you, as I mentioned in the bottom there, over the 24 months, 100,000 kiloliters of water. And I put that in perspective. We all watched the Olympics earlier this year, that long, big, massive swimming pool. 40 of them I can fill up with the water that just as one organization was able to save, to push back and to be more green on that. All right. There you can see our line nicely starting to smooth out, and it's busy being controlled on that line as well to ensure we're running there. Patient safety still remains our biggest contributor to this, and this is also as I've mentioned there as well, all the additional tests that we do. But also, what I've omitted to put in there is testing municipal water. We've just heard about municipal water now again. To also test your municipal water, because we generally only test your RO water and your product water. But do we realistically know what water and what is your municipal water coming into your plants and into your systems? Because that does have a direct impact on your water usage, on your water quality. Okay. And like I said, I'm trying to shorten the presentation a little bit here for you. But the last point there, and the conclusion that I want to leave you with, if you can measure it, you can manage it. That is possibly one of the biggest criteria that, and again this morning we heard the exact same thing. All right. Thank you very much. And I would like to leave you with words from our former president, South Africa.
Thank you, Mr. Ackerman. What an insightful presentation. I'm introducing our next speaker, Dr. Reinhard Hess. Dr. Reinhard Hess is a chemical pathologist from Pathcare. His special interests include endocrinology, cardiovascular disease, risk reduction, and laboratory informatics. He believes that the true worth of pathology services lies not merely in the generation of data, but in its ability to deliver the value to healthcare providers and ultimately patients.
Thank you very much for that introduction, and thank you everyone for this opportunity. I really appreciate that I can give you this talk. It's a privilege. As you can see, I'm a chemical pathologist, and during my training, which was here at WITS, we had this senior consultant, very wise, almost like a Yoda figure, that would give us registrar's advice. And one of her advice was, when we were going through physiology, is study the kidneys well, because if you know the kidneys well, the physiology and the pathophysiology, then you know 50% of chemical pathology. And I believe that is true. And I believe that for this audience, I don't have to convince you that, seeing that all of you are involved in kidney care and you know how detrimental deterioration in kidney is in a patient's health. So why is that? So obviously the kidneys are involved in quite a number of systems. First and foremost, it excretes toxic substances, but it's also involved in bone and mineral health, involved in plenty of hormones that gets produced, fluid balance, water balance, electrolyte balance, and of course blood pressure is also very key to, or the kidneys are very key to blood pressure and water handling in the body. So you can imagine that if there's injury to the kidneys, if the nephrons start dying off, and especially if they get to a critical low limit, then all of these processes which the kidney are responsible for will start suffering. We start seeing things like uremia, because you can't excrete urea and other toxic substances. You start seeing mineral and bone disorders. You start seeing metabolic acidosis, anemia, hypertension and fluid overload, electrolyte abnormalities, and then all of the above basically causes cardiovascular disease risk increase, nutritional issues, as well as increased infection risk, and plenty others. Here's just 9 of them that I've mentioned. Again, I don't think this comes as a surprise to anyone in the audience, because you've worked with these patients, you see the effects that kidney disease has. So it is then also not a surprise that from a laboratory perspective, we are quite involved in testing in kidney disease. So in the initial phase, obviously before a patient even knows he or she has kidney disease, we're involved in screening, diagnosis, workup of the etiology, as well as the staging. And then once it's confirmed to be chronic kidney disease, we obviously are involved in monitoring and planning, detection of the additional risk factors, and that can be infections, diabetes, dyslipidemia. And then ultimately, in which most of this talk is going to be based around, is in the end stage. As you know, these patients that are on end stage on renal replacement therapy, they need monthly bloods, and quite a lot of them. And we use these bloods to check for complications, and we use these blood results to check for the quality of the dialysis care. And of course, there are also other bloods that gets done throughout various stages of a kidney disease patient's life. Obviously, when a patient goes for procedures, there's bloods to be done. A very important point, maybe I'm biased because I'm involved with the therapeutic drug monitoring for PAF care, but remember, renal patients do not handle drugs the same way as patients with normal kidneys. So we've developed assays. We can test for over 15 antimicrobials at drug level, as well as more than 10 anticonvulsant drug levels. And I think especially in a critical care setting, and especially patients that are getting dialysis or that have impaired renal function, it's critical to know what levels you're actually reaching in the serum to see the effect. And of course, seeing that the theme of the session seems to be centered around water, and there's water on the table, and two previous speakers has talked about water, I felt I can't be the odd one out. I must just mention that PAF care, believe it or not, other than blood, also tests water. We have our own water testing laboratory that already does work in for many renal units to test to see if it meets compliance standards for dialysis quality water. So if you haven't been using us for that yet, now you know you can. Okay, so all of these involvement that we have with chronic disease patients is quite nicely illustrated in the brilliance of African Renal Society chronic kidney disease or chronic dialysis guidelines. And this is basically a table that shows you what blood should be done when for patients that are on chronic dialysis. And we've basically, so you can see there's quite a number of blood results throughout the year. And these are all guideline-based testing, and we've taken sort of that as a blueprint and made it a bit easier for the doctors to request these bloods by basically mapping it on the South African Renal Society guidelines in our laboratory forms. So it's very easy to see which bloods the patient are due in a certain month. And then, of course, you can also at the back order any of the other bloods that you would additionally like above the ones that are prescribed by guidelines. Now, obviously, now we create a lot of data because we're measuring a lot of bloods on these patients. And as the gentleman or the previous speaker mentioned, there's a very famous quote that says, you can't manage what you can't measure. He said it in a positive. You can manage what you can measure. This quote has been ascribed to a gentleman called W. Edwards Deming, very famous statistician. It has come under some scrutiny, especially from the business world, and in LinkedIn, people are raising this and saying, oh, sometimes you can manage stuff without measuring it. But I think where people miss the point, or the important part, is this. What do you do with the data? Yes, you can measure things, but do you use that data to inform something? And let's just go through a quick example. Here we have data. I don't want to pick on anyone here in the front, but what do we do with the data? Okay, so we said yes, you cannot manage something by not measuring it, but you can also not manage by just measuring. You need to interpret and act on that data. As an example, 5.9. Remember Oscar Pretorius' lawyer, was it Barry Rue? He wouldn't say things, he puts it to you. So I put to you 5.9. 5.9 what, right? 5.9. No, there's your data, it's 5.9. Act on it. No, you can't, because that's just data. We need the data to be transformed to information. Now we go one step further. We say, okay, the serum potassium of the patient is 5.9 millimole per liter. Already more helpful, right? Because that's information. But still we can do better, knowledge. The serum potassium is 5.9, and note it's in red, millimoles per liter. The reference ranges for the normal human population should be between 3.5 and 5.5. Okay, now suddenly you can deduct that with knowledge this is higher than it should be. Still we can go better, insight. Yes, the serum potassium is 5.9, the previous potassium was 5.2, and the urea and creatinine concentrations has also increased. Now suddenly, 5.9 becomes a very insightful metric. And then, lastly, and this is more from a clinician side, wisdom, to know when to do what based on the insights that we're giving you. In this case, it might be something like, yes, it's 5.9, it used to be 5.2, but the patient is actually due for dialysis today, so we'll just sit tight and measure afterwards and see what it does. So that becomes wisdom. If you go too far and you just use your own creativity, you get a conspiracy theory, which I don't recommend, where you say things like, there's no such thing as potassium, only unicorns. So we're going to stop right before a conspiracy theory and end at wisdom. That's insight and wisdom. That's the motto of this talk that I'm giving. Okay, so testing in chronic renal disease. We've already mentioned that you have this initial phase. We actually just want to see, and by the way, I'm sure you know the stat, but it's for that only 10% of chronic kidney disease patients are actually diagnosed. The other 90% are walking around and we don't know. If you haven't tested recently, you might be one. So it's very important in the initial part to actually screen people. And we, as you very well know, KDIGO advocates that we screen by doing creatinine, and then enzymatic creatinine is the best one, and obviously the one that PAVCare offers. And then we apply the CKD epi equation, which is again the advocated one, to basically get the EGFR as an indicator of your estimated glomerular filtration rate. You use that, and you use your albumin creatinine ratio, something else we measure in the urine. And the two of them together give you insight as to whether this patient is the risk classification for developing chronic kidney disease, and you can also then eventually make the diagnosis of chronic kidney disease over a 3-month period. And then based on this category, okay, you can make the diagnosis, you can know when to refer a patient to a nephrologist, and you can also know how often you must monitor a patient. We got this question a lot from especially primary level care providers, GPs and so forth, telling us, okay, my patient has chronic kidney disease, but when should I do what? When obviously we're doing nephro-friendly things, but when should I start referring and so forth? So we basically use the KDIGO guidelines and we program that into our lab information system. So whenever a patient has a serum creatinine and has a urine albumin creatinine ratio, we just apply the KDIGO guidelines and we classify them based on their risk score for albuminuria and their risk score for the EGFR. And then together, as you might very well know, these two give you a risk indication. And we actually show this on our lab report to show the doctor clearly at what stage of risk this patient is and over a time period if it deteriorates, and at what point the doctor should rather refer to a nephrologist for further care. So this is just the start, because as you can obviously see, that was for diagnosis. Now we're moving on to patients with established chronic kidney disease, and there's much more data here, as you can very well see. So again, data is just data, or even information is just information. We want to really get to the level of insight or wisdom to really change patient outcomes. So the first thing that we did is for dialysis units, we now have a monthly overview report available. So for all of that blood that I showed you in the previous page that you can request per month, for each unit we automatically summarize all of their patients. So on the left, the blacked out areas are patient names with their ID numbers and other details. And then on the right, you can see all of the bloods that that patient had for the month. Obviously, the red is high and the red with the block around is very high and blue is low. So immediately just on an overview, you can see if this is your unit, oh, this patient has anemia and should be acted upon. This patient has hyperkalemia and should be acted upon. This patient actually didn't have PTH this month. Why? Let me go and follow up and make sure that it is done. So that is the first thing that we've done to go from a level of data to actually actionable insights. But still, we went one level further because that doesn't really address the full question about quality of care indicators. And we looked at literature to look at what in a dialysis setting is regarded as good quality care. So there are a few metrics, and you might in your unit have your own metrics, but by and large we look at anemia and iron stores, and there we use hemoglobin and ferritin as surrogate markers. And then dialysis adequacy, where we use the urea reduction ratio. We use bone mineral density, there we use phosphate, calcium, and PTH. And nutrition, we use albumin as a surrogate marker. And then hyperkalemia, of course, we look at the serum potassium. There are, of course, others that you could include here that would probably also be of benefit. And for each one of these, literature defines a level which is deemed to be acceptable for a patient of chronic kidney disease. Of course, we do not expect patients of chronic kidney disease for all of these metrics to be at the level of a normal, healthy patient. Certainly, some of these metrics will never get to that level, but there is still a level of quality that we can provide them, that we should measure them against. So the question then is, okay, if we classify them in target or out of target, what do we do with that? Well, we create a nice dashboard for you. So we've basically I'm going to zoom in this, don't worry if you can't read this. We've basically created dashboards of all of this data on a unit level to basically say, did these patients meet the criteria that we just said on the previous slide, and what percentage of patients are actually meeting the criteria, and what are your problem analytes? So let's dive into that. It actually operates on 3 levels. You have your individual level, you have your unit level, and you have your organization level. And let me break that down for you. On the individual level, you want to identify patients, individual patients in need of intervention. So that's quite similar to the previous one that I showed you, except this one uses specific cut-offs that are based on literature for chronic renal disease patients. And again, on the left-hand side, we've just blanked it out by showing patient A, B, C, and so forth, but there would be the names of the patients. And of course, in green would be markers that meet the quality criteria, and in red, markers that don't meet the quality criteria. So again, you can immediately see which patients are at risk, or which you need to act on, or which have missed tests. If I can just use one analyte as example going through, look at HP. So you can obviously see there's 3 patients there who has an HP of less than 10, which is the cutoff we used here, and that specific patient has an HP of 7. So if you look at this report, you might say, wow, okay, is this patient taking ISO, EPO? Should this patient, are they losing blood from somewhere? Should they get a transfusion? And you obviously use this form to go and zoom in on that patient. Then on a unit level, you can also use this dashboard or this data analytics to identify care gaps in need of intervention. So what do we mean with that? So we basically look at all of the patients in a unit, and we say, okay, again, using the example of hemoglobin, which is convenient because it's the very first metric, what percentage of patients in this unit for this month had adequate hemoglobin levels, meaning more than 10? And as you can see, in this particular unit, it was not so good, like 45% or so. So somebody, if this was your unit, you might look at this and say, okay, why is only 45% of our patients achieving adequate hemoglobin levels? Maybe there's an issue. And again, on an organization level, you can actually compare multiple units against one another if you are managing more than one unit. And this is sort of a carrot-stick situation. You don't just want to punish those doing bad, but you actually want to learn from those doing good. Because again, if you look at this, Unit 1 doesn't have very good HP control or HP levels, quality levels, but the other units are slightly better. So maybe the unit manager of Unit 1 would want to go and see from Unit 3 what are they doing differently that they can maybe implement to learn from them to improve. So that then basically brings us at our take-home, just to summarize. As my consultant said, or I think you would all agree with her, that chronic kidney disease affects multiple aspects of health. And therefore, you need a lot of lab tests for these patients, and lab tests creates data. But data needs to be, and that data is needed to screen, monitor, and manage. But data is only data unless you apply some kind of knowledge or informatics to it, and then you can actually transform the data from just data to actionable insights. And last but not least, better insight results in better patient outcomes, which is, I think, at the end of the day, why we are all here. Thank you very much for your time. Appreciate it. Just one last thing, if you are interested in using these lab reports and you use PathCare, want to use PathCare, you can speak to your local PathCare representative and we can email them and give you access to the data from your unit, or create it and email it to you and give you that access free of charge. It's all part of the service. Thank you. So now is it time for questions? Yes, any practice. But any practice, but obviously these metrics are more applicable for dialysis patients. But do you do dialysis in your unit, or? Okay, but if they do dialysis, any unit that does dialysis would benefit from this. It's more, the market is more the dialysis group, so it doesn't matter where the dialysis takes place, it will be of benefit. Sure.
Thank you, Dr. Reinhardt. The floor is open now for any questions. Please, not everybody.
Okay. Afternoon, everyone. So I didn't want to create dialogue there without people hearing at the back. Sorry. I just wanted to ask, in regards to those pathology results, let's say there's many reasons GPs don't refer patients to nephrologists ahead of time. One of the reasons sometimes is they're a bit scared to know when is the proper time. So just in regards to your blood results, if I'm a GP and I have a practice and I do the blood results of these patients, can I get those particular results, or is this a new thing PathCare is doing?
No, so the first part, the KDIGO scoring system, where it shows the risk classification, that we've been doing for 2 years about, and that basically classifies the patient based on risks. And the report says when a patient becomes in a high-risk category, the GP should consider referral to a nephrologist. The latter part of the dialysis quality indicators, that's a relatively new project that we've only launched about a month ago. So we're still rolling that out, but it's free to everybody that uses PathCare that wants it. But obviously, we can only work on PathCare data, so we'd have to be a PathCare client. You can talk to me afterwards, but any one of your marketers, all of the marketers are aware, and they can set you up. Thank you.
Good afternoon. Mr. Ackerman, welcome to South Africa. My name is Cedric. I wanted to know, firstly, I'm not sure if it's an ignorant question. Do water care technicians still exist, or are they unicorns? Because I'm asking this because obviously you work for a company that's a pioneer in dialysis in South Africa. And then maybe you might be much more organized. And thank you for your presentation on the pre versus post tank on that, on how we can save that. My question is there a certain number of sessions or dialysis stations that you would advise a dialysis unit to invest in that method, seeing that you're saying it's got high capex costs, versus costs? It's obvious. Essentially, we are all to save water, okay, and then also for better outcomes. My first question that was based on that, we're not sure, because when I want to verify when someone is a nurse, I go to SANC. When I want to verify when someone is a cleantech, I go to HPCSA. But for the water care people that come and do the water for us, and it's not that we're playing ignorant, there's been a prevalence of many independent dialysis units, some of them in what you might call rural areas, and then we're not sure how to benchmark this according to the legal one, because all we are concerned about is the patient outcomes. More than nothing. Yeah. Thank you.
Thank you for that. I'm going to try to answer your question the way that I understand it. So yes, water technicians, there is the water technicians out there. Yes, it is becoming a very scarce market, and to also get proper technicians trained up and to actually understand water. Water is not just a liquid, it is something that you need to understand. Then with regards to the post-tank systems or indirect feed systems or even your intelligence systems, there's no real benchmark based on your size of your clinic. The biggest factor that, however, that you need to factor in is when you start talking about a post-tank, what is the volume of water that you work on your post-tank? Producing 10,000 litres of permitted water is not the way to go. That's not ideal. But when you basically got to look at the volume of points that you've got in your unit and how long are you going to take to actually utilize the water in your post-tank. Because you also want to prevent that product water to stand for too long also. I hope I'm answering your question with that.
Hi, I'm Alistair Williams, I'm a nephrologist. The data talk about PathCare is fantastic, and I like that a lot. My question is about the ownership of the data and who can decide who to release the data, whom to. If you look at PathCare, the nephrologist, the renal unit, and the patient. So if you've got a unit of 30 patients and there are 4 nephrologists involved, and who can actually decide or who needs consent for the data to be made available to any of those involving parties?
Yeah, thank you for the question. I think, especially in this era, data privacy or data protection becomes more and more important. So, firstly, when patients sign a consent to draw blood, they do give permission for the treating healthcare workers and the laboratory to look at it, but only in that, and to use it, and they can use it anonymously, but obviously not outside of that trust network. So we would never divulge that data beyond that. So the data that we do make available for units would only be that unit's data for that unit. We won't send that data to another unit. So it will have to be the same organization or the same unit getting access to their data and not somebody else's data. Secondly, everything is anonymized that we share, like in presentations and so forth. Obviously, for the actual healthcare provider, it's not anonymized to be able to contact, but anything outside of that, when you just look at statistics or compare it between units, you can't see the names of the other unit. You can just see, broadly speaking, what percentage was in range or out of range. You can only see the patient level detail of your own patients.
Francois, how are you? Sharp. Kumotso here from Mediclinic Renal Services. I just want to ask something concerning the water. So let's say, for instance, this unit, it disinfects its RO every month. But then the issue is that after testing the water, they see that the results, they come back positive for bacterial growth. What might be the case?
Bacterial growth in your system, there can be numerous areas for it. What we have found is even your piping, the volume of connection, the volume of points, and the volume of air that is left into it or let go into your system. Also, what we found in our cases is sunlight. Sunlight and water doesn't mix, not in this environment. So where you do so first of all, when the results do come back positive, we generally try to do a re-decon or re-clean CIP as soon as possible, and that's generally within a 24-hour period after we've received our results. Then from there, and thank you, Pathcare, for the testing, normally we do a 7-day culture test. But then what we do ask Pathcare then is to do a preliminary 2 or 3-day test for us initially so that we can just see, is there any growth, yes or no. That's all I'm interested at that point. So once that happens, we then go back and we do a much deeper clean, but also we assess the entire system.
So will I be right if I say that we don't buy a new RO? Will I be correct if I say we don't buy a new RO?
No. No, the suppliers will possibly tell you that, but no, you don't need to buy a new RO.
Good afternoon. Yes, okay, I'd like to know if you would consider using the borehole water for dialysis, if it meets the standards for drinking water. Because we have tried it, but we found that although the RO takes it, but it tends to have very high conductivity at some point, and then the RO shuts down. Thank you.
Yes, bore can be used successfully, and we have applications where we are using bore water extremely successfully. However, bore water becomes very tricky because you don't always know what you actually pull out of the ground. To give you an example, we've done a bore some time ago. We had 80 meters. We had extreme high levels of E. coli in the water. So the rule of thumb is if you use bore water, you first got to treat the bore water to potable standards before you even send it through to your RO plant. So yes, a bore is a very, very tricky thing because of the quality of water that we want. I can also share that we've done a whole, especially during the drought periods, where the water was so bad quality that we actually had to close completely and stop using it. But yes, the short answer is you can use bore, but you have to invest in regular testing of your water coming out of your bore, coming through your portable system, and again testing at your actual RO plant. Thank you.
Thank you so much. Because of time constraints, I think it will be wise to close the session. We would like to thank the both speakers, Mr. Ackerman and Dr. Hiss, and to thank you. I think this was a proper successful talk. Thank you.
I think there's another one, but Kevin doesn't mind that.
She's falling asleep. I'm trying to be so quiet. She doesn't notice I leave. Oh, my love, I'm saving it all for you. Oh, my love, I promise I'll be back soon. I keep her photo in my pocket, so I can stare at her beautiful face. And when the world gets darker, how I softly whisper her name. Oh, my love, I'm saving it all for you. Oh, my love, I promise I'll be back soon. Be back soon. Be back soon.
'Cause I'm so used to being so upset with myself. But then I came apart like a puzzle and back together with your help. Watch the shades from you fall down and make me a new kind of light. And I feel more like myself while I'm so colorful now. While I'm so colorful now. While I'm so colorful and now I feel my emotions. They're flooding out me like an ocean. Well, now I'm so alive and I got all this time. I've been so used to being so upset with myself. But then I came apart like a puzzle and back together with your help. Watch the shades from you fall down and make me a new kind of light. And I feel more like myself while I'm so colorful
start. I'm dying in emotion. It's my world in fantasy. I'm living in my dreams. You're my heart, you're my soul. I keep it shining everywhere I go. You're my heart, you're my soul. I'll be holding you forever, stay with you together. You're my heart, you're my soul. Yeah, I'm feeling that our love will grow. You're my heart, you're my soul. That's the only thing I really know. Let's close the door and believe my burning heart. Feeling alright, come and open up your heart. I'll keep the candles burning, let your body melt in mine. I'm living in my dreams. You're my heart, you're my soul. I keep it shining everywhere I go. You're my heart, you're my soul. I'll be holding you forever, stay with you together. You're my heart, you're my soul.
Been here so many times. We gotta find some common ground. This whole love ain't working out. I'm sick of giving you grace. I try to find a new headspace. So try to find a new way to go. But I always come back to you. I just want you here.
Ladies and gentlemen, can we kindly take our seats for the syllabic session to begin?
And I waited a lifetime. Well, it feels like
Good afternoon, everybody. We'd like to get the opening ceremony started. Please take your seats if you don't mind. Well, here we are. To all our colleagues, esteemed guests, and all delegates, on behalf of the Renal Care Society of South Africa, we'd like to welcome each one of you to the South African Renal Congress 2024. We will once again have the opportunity to share knowledge, to foster collaboration, and also to inspire innovation in nephrology. It's been wonderful to see all the familiar faces, but also the number of new faces have been very exciting. Seeing all the new ones coming into nephrology, it's really fantastic, and I think tomorrow we have quite a few joining as well. If this is your first South African Renal Congress, extra warm welcome to you. So the theme of this year's Congress is the fourth industrial revolution and nephrology. Advances in technology have allowed us to imagine. Imagine a world where access to quality renal care is expanded to all who needs it. Imagine a world where that renal care is tailored to each individual patient's needs. Just imagine. Advances such as artificial intelligence and electronic health records enable healthcare workers to make decisions that are data-driven. And the future certainly looks exciting. Over the next few days, we will engage in thought-provoking discussions. We'll hear from leading experts, some of whom are the best in the world in their specific field. We'll explore the latest advancements that are shaping renal care. This Congress is not just an opportunity to learn, it's a chance to connect with like-minded individuals, to challenge our perspectives, and to ignite new ideas. Please allow me to extend my heartfelt thanks to everyone who is involved in making this event possible. To all our keynote speakers, to the local organizing committee, to all our amazing researchers who submitted abstracts. I am pleased to announce that we've received a record number of abstracts for this Congress. And of course, most of all, to each and every delegate. Without you, this Congress would not be possible. So a very, very warm welcome to each one of you. Over the next few days, I encourage each one of you to participate, to ask questions, and to share insights, and to share knowledge among ourselves. Let's make this Congress a memorable one. Once again, welcome and enjoy the next few days. Thank you very much.
Ladies and gentlemen, esteemed colleagues and honorable guests, it's my distinct pleasure to welcome you on behalf of the South African Nephrology Society to the SANS RCCSA Congress for 2024. We gather here today not only as specialists in nephrology, but passionate advocates for kidney health, united in our mission to advance knowledge, share insights, and foster collaboration in our field. This year's theme of artificial intelligence in nephrology reflects our commitment to staying at the forefront of research and clinical excellence. Over the next few days, we'll explore advancements in nephrology, ranging from novel therapeutic approaches to integration of technology into patient care. We are fortunate that we have a remarkable lineup of speakers who are leaders in our field and ready to inspire us. We are proud to feature a joint International Society of Nephrology, African Association of Nephrology, and SANS session, as well as a joint South African Transplant Society and SANS session to improve inter-society dialogue. Let's take this opportunity to learn from one another and to enhance our practice to improve patient outcomes. A special thank you to our sponsors and partners whose generous support has made this event possible. Your commitment to advancing nephrology is invaluable. As we embark on this journey together, let us remember the impact our work has on our patients.
The knowledge we gain here will resonate beyond this Congress, shaping the future of nephrology in South Africa and beyond. Thank you for being here. Let's make this Congress memorable and an impactful experience for all of you. Welcome. I have the great pleasure to introduce our plenary speaker, Professor Vivek Jha. Professor Jha is the Executive Director of the George Institute for Global Health in India, the Chair of the Global Kidney Health at Imperial College of London, and the past President of the International Society of Nephrology. Professor Jha is recognized as a global expert on the burden of kidney disease and its socioeconomic impact in low to middle income countries. He's an established clinician scientist who has led large-scale collaborative research projects and has a track record in translating research findings into clinical practice. He's published over 500 peer-reviewed papers and 34 book chapters. He'll be speaking on a topic that he's passionate about. His title is Environmental Change, Changing Biodiversity and Infections, Lessons for the Kidney Health Community. Let's welcome him to the stage.
Thank you very much, Dr. Diana and Dr. Murray, for those words of welcome. And I'll also start by thanking the leadership of the South African Renal Society and the Scientific Program Committee of this Congress for giving me this distinct honor of speaking to you in this opening plenary session. As Dr. Diana pointed out, for the last few years, one of the topics on which I have been increasingly interested in is to look at the intersection between what is happening to our environment and its link to kidney diseases. Hope this works. Okay, all right. So I'm pretty sure that you're all familiar with this word, climate change. And you must have heard this repeated over and over again, that climate change is the greatest public health challenge to the 21st century. We have all heard about the fact that climate change is leading to increase in global temperatures, and the rising global temperatures have been linked to an increased risk of development of several types of chronic diseases, including kidney diseases. And the spectrum of kidney disease is not limited to chronic kidney disease, but also encompasses acute kidney injury and increased risk of development of stones. What my goal over the next 40 minutes or so is to take you beyond just climate change, increasing temperatures, and looking at other elements of environment change that we are all experiencing, but we don't talk often about. So here you see this slide, and it talks about the various other dimensions of environment change that we are experiencing, which also have an impact on kidney health. So in addition to heat, which is there at the top, you also see on the left alterations in biodiversity, which we will dwell into in some detail during the course of the next half hour or so, but also try to link it with other challenges and other alterations that humanity is causing, such as increasing urbanization and industrialization, and of course a number of other factors which are impacting humanity as a result of the ravages of environment change. Just stepping back, it's worthwhile just introducing this term to you, the Anthropocene. What is the Anthropocene? It is a proposed geological epoch in which we are currently living, which starts from the commencement of significant human impact on Earth's geology and ecosystems, which includes but is not limited to anthropogenic climate change, which is the point that I made a little bit earlier as well. Let's now hone into this specific topic of biodiversity. So what is biodiversity? I think as the word suggests, it is indicative of the variety of life that we have on this earth. And how do we describe this variety of life? In all its forms and in all its interactions. The interactions are extremely important, as we will realize in the coming minutes or so. So when we think of diversity, it could be at several levels. it is genetic diversity. Genetic diversity determines how each one of us in the room are different from each other, even despite belonging to the same species. And this you can extend to the entire life forms on this planet Earth. And then the species diversity, which we are much more familiar with. We are able to differentiate different species, humans from the non-human primates to other types of primates and non-primates, etc. And then finally to the ecosystems. And the ecosystems represent a variety of habitat types in all over the earth, including in land and in water. It's important to realize that biodiversity supports a range of ecosystem services. And what are these ecosystem services? They are all those factors which contribute to human well-being, and some of them are shown here on the figure on the right, that they perform a number of functions which include supporting human health, and the support of human health could be in the form of its impact on, say, biodiversity, habitat, photosynthesis. They help in provisioning of human health by making availability of raw medicines, a number of raw materials, medicines, food, water, etc. They have regulating functions such as climate regulation, flood control, cleaning water and air through a number of mechanisms. And then, of course, biodiversity has its cultural dimensions as well, which range from spirituality to recreation to education and so on. So what we are going to focus on is the loss of this biodiversity. The loss of biodiversity has been defined by the Convention on Biological Diversity as the long-term or permanent, both qualitative and quantitative. I think it's, again, important to emphasize on these two dimensions of biodiversity loss. In reduction in the components of biodiversity and their potential to provide goods and services to be measured at all levels, global levels, regional levels, and national levels as well. This slide will show you, I think this is very thick with numbers, but it's really not important to look at these individual numbers, but if you are interested, this slide will be available to you and you can look at them in detail. But it's important to look at the bigger picture, which says that billions of individual populations have been lost all over the planet, with the number of animals living on Earth having plunged by half just in the last about 50-55 years or so. And the various other type of numbers are those that you can see on the left of this slide. Even if we just concentrate on the vertebrate population, between 1970 and 2016, the vertebrate population size has dropped by about 70% worldwide. This is amazing, and this is not something I will not be overstating if I say that to most of you, this figure will come as a big surprise. This is not something that we often anticipate, right? And what are these threats to the Earth's biodiversity? They are all shown here on the right. And most of them are as a result of human activity, as we will see in subsequent slides as well. Climate change is something that we have already talked about, but human activity leads to increase in pollution. We are altering the way we use land, and we exploit the seas, and we, of course, overexploit other animal species as well. If we go down into the details of the various types of activities that humans engage in, which have an impact of biodiversity, you can see them here. All of these, deforestation, hunting, farming, habitat loss, use of fertilizers, fishing, they have a direct impact on other organisms in the world all over the place. So let's just try to take a macro view of where we are compared to where we were, let's say, 10,000 years ago. So 10,000 years ago, this is how the Earth was made up. About 57% of the Earth's surface was forest. This is non-ocean surface. This is land area. So 57% was forest, 42% were grasslands, and there was about 1% area which was made of fresh water. And let's now see how it has changed over the course of the last 10,000 years. So we move ahead in time, going to from 10,000 years to now we are at 1900 to 1950 to 2018. And you can see how it has changed. So from 57% the forest area has shrunk 38%, and you have now two big tracts that did not exist before and which are entirely created by human activity. We now have an area that is needed for animals to graze because those animals serve human needs, and then we started growing crops. All the area which was grassland and which was forest has now been taken over by areas that are now required for grazing and crop development. And of course, urban areas are something which are completely new as well. The other thing to appreciate is that this loss of biodiversity is not uniform around the world. Since the time we started to measure it, we can see that the parts of the world that are relatively underdeveloped are seeing a greater loss of biodiversity. One of the reasons for this is that the loss of biodiversity can be largely linked to the process that we call the process of development. So the developing parts of the world are currently undergoing the process of development, and that process of development involves indulging in the kind of activities that result in loss of biodiversity. Whereas development took place a long time ago in other parts of the world, such as North America, Western Europe, etc. So over the recent times, the loss of biodiversity in North America and Western Europe has been relatively low, but the greatest threats are present in those parts of the world which are currently developing, which includes continents like Africa, South Asia, Southeast Asia, Latin America, etc. Latin America has seen the greatest drop in biodiversity because of a huge amount of exploitation of the forest areas, such as the Amazon rainforests. And here are some figures once again. More than 1.1 billion square kilometers of a total of 6.7 million square kilometers. So just about 1/6 of the Amazonian rainforest has been felled over the last about 40 years or so. So we started with climate change, and this slide is meant to depict the point that climate change and loss of biodiversity are increasingly linked and feed each other. So in the center, you see a number of changes that are taking place. Some of them are more directly linked to climate change, whereas the others are more directly linked to change in biodiversity. But through other mechanisms, which you can see in the top or bottom of the slide, they all feed into each other. So climate change worsens loss of biodiversity, whereas loss of biodiversity has a positive feedback loop on climate change as well. And so if we don't break this circle, both of those adverse effects that are harmful to overall humanity, including human health, are not going to get stopped. Now, let's transition to looking at the impact of biodiversity on human health. So here are just a few figures once again for you. All of us, as a general statement, all of us depend on biodiversity for our health, but some depend more than the others. And here comes the question of equity to access to biodiversity, just like we talk about equity in access to all the services. So 1/3 of the world population already lives in areas which are under moderate or severe water stress. The numbers that you have there live in areas that are directly affected by desertification. More than 3 billion, which is just under half of the world population, depend on marine and coastal biodiversity for livelihoods and subsistence. 60 million indigenous people around the world are almost wholly dependent on forests for their livelihoods and the rest, even their cultural activities. 70% of the world population relies on medicinal plants in some form or the other, and about 350 million directly depend on forests for subsistence and income. So the question is, how does ecosystem change affect human health? And the panel in the middle is something that we have already touched upon in some detail. But if you look at the panel on the right, you can look at the example of health effects. The health effects from the loss of biodiversity can be direct, which are related directly to floods, extreme weather events such as floods, heat waves, water shortages, landslides, and increased exposure to ultraviolet radiation, etc. Then health effects can be mediated indirectly through ecosystem. which include altered infectious disease risk, which is the focus of, which is going to be the focus of the next part of my presentation, then but also compounded by reduced food yields, depletion of natural medicines, mental health effect, and effects of aesthetics and cultural improvements as well. Some of the health effects are not direct and not immediate, but they will show up much, much later. And these are the health impacts of livelihood loss, population displacement, including people needing to move on to slum dwelling, conflicts, inappropriate adaptation, and mitigation. The first thing to say about the link between infectious disease risk and biodiversity loss is that the environmental change shifts the host environment and pathogen equilibrium. And here you can see some of the postulated pathways through natural environment, both natural environment change, but also social environment change. A number of actions take place which result in altered relationship between the host, pathogen, and environment, which will lead to both increased frequency and vulnerability to established infectious diseases, but also to emergence of new infections. So this is something which is really important, and we'll see some of that in a minute. Let's look at the ecology of infectious diseases in relation to biodiversity loss. I'm not sure how many of you appreciate the fact that most of the human infections are actually zoonotic in origin, which means that they originally came from non-human animals. Most pathogens are also host generalists. What does it mean? It means that they have the ability to infect many species in an equal way. So they don't specialize into any one species. On the other hand, host species differ in their invasiveness, their susceptibility to infection, and potential to transmit infection. Please keep this fact in mind because we'll come back to it in a minute. And the hosts that are most likely to acquire and transmit infections are going to be abundant, widespread, and they are resilient to anthropogenic perturbations. So if there are all this anthropogenic climate change, what will it do? It will lead to persistence or actually preferential widespread adaptation of these hosts, which are more likely to acquire and retain infections. So certain mammalian orders, we all know that rodents, for example, are overrepresented as pathogen sources. There are many types of infections which are transmitted through rodents. And there are certain animals with fast life histories. And these animals are associated with commonness and resilience to disturbance, such as we all have heard that if there is a nuclear catastrophe, cockroaches are the ones which are most likely to survive. And so they breed fast and they're very resilient to disturbance. And they also exhibit lower resistance and higher tolerance to infections, which result from trade-offs between reproduction and self-defense. So what does it mean? In the end, it means that these reservoirs species are likely to persist when the diversity is reduced. So the reservoir species which are more likely to get infection, which are more likely to transmit infections, are the ones that will persist when we see increasing environment change. And here are some data, and these data looked at the effects of biodiversity on the patterns of infectious disease and outbreaks in the Asia-Pacific region. And in this study, data were collected from 1950 to 2015 or so. You can see the number of total outbreaks and the number of outbreaks which are specifically associated with diseases. You can also see the sharp increase in these numbers over the last about 30 years or so. What these authors found, that the number of infectious disease outbreaks, the number of zoonotic diseases with outbreaks, and the number of waterborne diseases with outbreaks, they were all associated with a number of explanatory variables which directly lead to loss of biodiversity, be they temperature, loss of forest cover, and so on and so forth. So you can see the p-values are highly significant for all of those. And these are some very specific correlations in the total number of outbreaks between the species at threat. So as the number of species at threat increases, the number of outbreaks goes up. The number of residual threat and the zoonotic outbreak also grows up. On the other hand, as the forest cover goes down, the number of vector-borne diseases grows as well. And here is an interesting fact. one of the first examples of how humans started to do something which directly resulted in environmental perturbations leading to increased susceptibility to disease is when humans started to tame fire, which is really historic, right? So what happened as a result of human taming of fire was that humans started to congregate around fire, they started to socialize around fire, and fire led to emission of smoke and increase in temperature, which increased the risk of damage to the respiratory tract. And this particular slide shows you the increase in risk of tuberculosis and directly links it to human taming of fire. So when humans started to control fire use, before that, the risk of tuberculosis in all kinds of living beings was more or less the same. But when humans started to tame fire, there was respiratory damage, which caused Mycobacterium tuberculosis to specifically localize those individuals with the damaged respiratory tracts. And as humans started to socialize with each other, there was an increasing chain of human-to-human transmission as well, which led to preferential increase in risk of Mycobacterium tuberculosis in humans. So that is something which is very interesting. The other, I'm not sure if any of you have seen the movie called Contagion. And this movie talks about the famous Nipah virus outbreak in Malaysia. And this was directly linked to the deep deforestation that took place in Malaysia, which drove the fruit bats out from the forest into the edges. And when they came to the edges, they started to invade the farms of the farmers who had their farms around the edges of those forests. And when they started gorging on the fruits which were growing in the farms, their droppings fell down, and some of their droppings were actually consumed by the pigs which lived in those farms. And those pigs were then subsequently came in contact with humans, were eaten by humans, leading to outbreak of Nipah virus, which is normally present in bats but doesn't cause anything, but it caused significant illness in humans. And since then, we have known that there are a large number of other infections as well, which result from climate change and biodiversity loss. And here are some of those mechanisms. They could be as a result of increasing interaction between humans and animals. There could be change in the behavior of vectors. There could be change in the way humans interact with water. And there could be, obviously, a new category of humans which are called environmental refugees, who are also especially susceptible to certain kind of infectious illnesses. And so this slide shows you in a summary. Again, this is a very busy slide. So this shows you a link between the various environmental perturbations shown on the left, and the possible mechanisms and the arrows to the mechanisms which go in all directions, which are shown in the middle figure. And on the right, you see a number of infections which have likely increased as a result of loss of biodiversity and environment change. And the top box shows you the various infections that involve kidneys directly. So, just focusing on a couple of specific infections, malaria and dengue. So there has been actually, as a result of loss of biodiversity and climate change, a longitudinal expansion of Anopheles mosquitoes to many countries where they did not exist before, which include countries of Europe and in China. There has been a longitudinal expansion of Aedes mosquitoes also, and these Aedes mosquitoes are carriers of dengue. Anopheles carry malaria, as we all know. There has been expansion of the Aedes mosquitoes to higher altitudes where earlier they did not survive, but now they can because the temperatures have gone up. There has been an increased malaria transmission suitability at higher altitudes in many parts of the world, and they're shown there. Plasmodium vivax malaria, which when I was a medical student, it used to be called benign malaria. But we now know that Plasmodium malaria, people who come with Plasmodium vivax malaria do not always have a benign course, but they also develop many kinds of organ involvement. So there has been a change, subtle change in the pathogenicity of Plasmodium vivax as well. And new species of Plasmodium, such as Plasmodium knowlesi, have been identified, especially in Southeast Asia, in Thailand, Malaysia, etc., which have emerged as human pathogens. Increased dengue transmission suitability is one of the worst kept secrets over the last 10 years or so, and it is going to become one of the biggest public health threats in the coming years. On the other hand, interestingly, because of the change of rainfall patterns in Western Africa, there has been a drop in suitability to malaria transmission in certain parts of Western Africa, not all over Western Africa. And this slide shows you the change in dengue cases and malaria deaths and annual mean land temperature change over the last, between 1993 and 2013. And here what you can see in the red boxes, the increase in dengue transmission, which is in 600%, 700%. On the other hand, interestingly, there has been typically a drop in malaria transmission. Why is that the case? That is because the global health community is much more aware of the risks of malaria and has taken a number of steps to reduce the risks due to malaria, whereas dengue has been largely invisible. So in one way, dengue is one of the most neglected tropical, or no longer tropical in fact now, diseases, which has the likelihood of leading to the largest number of years of life lost in the coming 10 to 20 years. And it can be directly attributed to environment change and loss in biodiversity. But then this is not limited to only mosquito-borne illnesses, but illnesses that are transmitted through other organisms also are being affected. For example, here we look at hantavirus disease. As we discussed a minute ago, rodents are one of the most common species that transmit infections, and they transmit hantavirus. And so what, in this particular experiment, what the investigators did is that they looked at a scenario where they looked at two types of hosts. So there was looking at the density of hantavirus host animals per site. They took two sites where there were hantavirus host animals, and from one site they removed those host animals. And what they found is that the sites from where the resistant hosts were removed, the density of hantavirus host went up, and the mean density of seropositive animals also went up. Whereas the control sites where there was no removal of resistant hosts, the density of hantavirus hosts went down, and the mean density of seropositive animals also stayed low. So that's the direct evidence, experimental evidence, that perturbation of biodiversity does increase the risk of infections. And now, if we move from a virus to schistosoma, which is, Africa is one of the continents where schistosoma is most prevalent. We know that the life cycle of schistosomes and the survival and fecundity of the snail are sensitive to both temperature and salinity. And studies have shown a 20% increased risk of Mansonia in Eastern Africa, and new epidemic Schistosoma japonicum areas have been identified in China where it did not exist before. A specific experiment which showed that overfishing of mollusk-eating fish lead to an increase in snail populations in Lake Malawi, because the fish that used to eat snake were humans were fishing them. Moving on to another zoonosis, which is leptospira, which is a very, very common cause of acute kidney injury and possibly chronic kidney disease also in many parts of the world, including in Asia. And here you can see a direct relationship between the leptospira incident and terrestrial mammalian species. So as the number of terrestrial mammalian species goes down on the left of the x-axis, you can see that the incidence of leptospira goes up on the y-axis here. So there is a very direct link there as well. And this is an interesting data. So until about 10 years ago, we used to think that leptospira causes only acute kidney disease. And once individuals recover, they are back with their normal kidney health. But we now have data from many parts of the world, including from Taiwan, where they looked at the risk of chronic kidney disease by measuring GFR and comparing it with IgM anti-leptospira antibody titer. And they found that individuals whose anti-leptospira antibody titers are measured at baseline, and again after 2 years, those who had highest antibody titers exhibited a drop in the eGFR, suggesting that leptospirosis could be responsible for chronic kidney disease as well. And moving on, looking further expanding this hypothesis, this research has been done in Central America, where the researchers found that the leptospira seroprevalence differed amongst job categories and was highest among certain jobs, such as sugarcane cutters, who are most predisposed to development of what is called the CKDU of unknown etiology. They had higher NGAL concentrations compared to those who, so seropositive sugarcane cutters had higher NGAL concentrations, and NGAL, as we know, is an indicator of tubular injury, and chronic kidney disease of uncertain etiology is supposed to be a disease of tubulointerstitial compartment. Now, let's move on to there are many countries in the world, especially the developing countries, who think that this is not their problem. But they need to also wake up and realize the fact that the areas that were most vulnerable to the spread of infections are now on the fringes of tropical and subtropical regions. And they are increasingly compounded by poverty, fragile ecosystems, population growth, and of course, in many parts of the world, we have under-resourced health and social security systems. And here you can see that there are now reports emerging from many parts of the world of infections that did not occur before. For example, here in Sri Lanka, and the first report of Aedes mosquito emerging in Central Europe. And this is a modeling exercise which was done by researchers which looked at the Aedes aegypti, which is an Aedes albopictus mosquito transmission, and these are the mosquitoes that transmit dengue once again. And this looks at the transmissibility in two scenarios. So there is this so-called RCP 2.6 scenario. So RCP is a term which is used by the Conference of Parties in deciding what will happen if the humanity was to tackle climate change in a certain way. So 2.6 is business as usual, right? So it's business as usual. As you can see, that projections show that starting from the time of the study to 2050 to 2080, the risk of dengue transmission risk due to Aedes aegypti is going to increase. But it doesn't have to be so. If we take maximal measures to reduce greenhouse gas emissions, which is called RCP 8.5, the risk of transmission of these mosquitoes is going to come down from the current which you see on the left to the figure that you have on the right, which indicates projections in 2050 to 2080. The other type of populations which are as increasing threats are these climate refugees. And we know that some of the human displacement events have been really due to climate over the last many, many years. And this is data just from 2016. And since then, we have seen COVID-related migration events, especially in my country, which was one of the biggest human migration events since the time of India's independence. Migration triggered by climate change and related factors also increases infectious disease risk through a number of mechanisms, which are shown here. But the point is that Sub-Saharan Africa, Southeast Asia, and Latin America are going to generate almost 150 million climate migrants by in the next 25 years or so. And we need to be prepared to deal with the issues that will come with this mass-scale human migration in different parts of these regions. So coming towards the end, I think it's important for us to recognize that environment change and loss of biodiversity touches upon a number of sustainable development goals. We do live in a sustainable development era, and here you can see a number of sustainable development goals, 1, 2, 3, 6, 7, 8. So all of these are directly affected by environment change and loss of biodiversity. Out of these, only one has been linked directly ascribed to health, which is as Sustainable Development Goal number 3, but all the others will also directly impact through their indirect effects on human health as well. What is also the sad part is that even though climate change is now a well understood term, and if you go and talk about climate change in any society, any gathering, etc., people will understand what do you mean. But not enough is spoken about loss of biodiversity. And here you can see the number of newspaper articles published per month on biodiversity or climate change. And the green colored section is obviously the biodiversity, and you can see the number of articles published on biodiversity remained more or less static between 1919 and 2016, with small increase towards the end, whereas the number of articles on climate change has gone up in an exponential manner. And if we extend this analysis to more recent years, you would have seen the number of articles on climate change go up even more. So what do we need? We really need to take a system dynamics approach to reduce infectious disease risk in the context of climate change and biodiversity risk. And we have to look at the holistic aspect, holistic issues that give rise to environment change and biodiversity risk, which is not something that just you and I sitting in this room can do, but the entire societies have to really be mindful of it and take action so that we are able to reverse some of the land use change. We are able to take the adaptation and mitigation measures that are required to combat climate change threats that we are seeing. We have to be mindful of the socioeconomic conditions, identify the individuals or the groups who are in particular risk from the threat of environment change, loss of biodiversity, and its impact on human health, both through infections, but also indirectly through other means as well. And of course, travel and trade are a big part of it. In many ways, and I'm not going to show you that analysis, it has also been shown by countries as they open up their travel and trade, they indirectly and paradoxically increase the risk of loss of biodiversity and increase the risk of threats of climate change. Why so? Because the industry comes in, and the nefarious impact of industry, various types of industry which encourage consumption, conspicuous consumption, which potentially has an adverse effect, a further adverse effect on the environment and biodiversity, can continue to perpetuate this vicious cycle that we spoke about. So we need to look at the socio-ecological perspectives for prevention of biodiversity loss, and we have to look at these two main things on the top: management of human-wildlife interactions, and take steps to ensure that we prevent emergence of zoonosis and control what happens. And that really is a matter of direct interaction with nature and society, which is influenced by a number of both actors, and we are all actors that play a role into it, but then the ecosystem functions that I spoke a little earlier about are also things that come into play. But those ecosystem functions are, many of those are directly controlled by human actors, right? And all of that are influenced by local knowledge, existing social practices, the institutions of social norm, and our legal and economic frameworks. Like I said, many of these changes are taking place because societies want to develop. And development is a good thing. There are a number of advantages that all of the societies accrue as a result of development, and there lies the tension between the societies that have already reached what is called a developed state and societies that are still in the process of development. What is the responsibilities of those? Because most of the contribution to the climate change, the environment change, the loss of biodiversity that we see today has been made by the societies which call themselves developed world, right? but the societies that are bearing the brunt of all of that are those that are living in the developing world, and so therefore the climate financing, etc. Those are very complex issues that are being discussed, but unfortunately in many of the COP meetings, the one is coming up very shortly now, these issues are discussed, but unfortunately no consensus is reached. So then, as health system players, we have to embrace increasingly the concept of what is called One Health, in which we look at health not in isolation. We have often, for example, we are here renal physicians and renal health practitioners, that we often focus on kidney health, but as we become less specialized, we need to become perhaps more generalized, not in terms of physicians, but also as participants in various social activities and social functions, and become aware and responsible for a number of other elements that we thought we were somewhat far from, such as environment and also animal health, looking at health ecosystems and the health of animals as well. And we think of society, how do we coordinate? We build capacity in all the players, all the actors that we spoke about, so that they become aware of this interaction that is currently taking place and will continue to take place. And as I said, if we continue to proceed with business as usual, the likelihood of the worst coming true sooner are faster than we will anticipate. In the end, all of this is going to have the greatest impact on our future generations. So this responsibility that we have is more to our future generations than to ourselves. And so it is in their interest that societies today need to take action. It is happening, so there are good news stories as well. So as a result of all this recognition, certain things there are good news stories as well. So poaching, sea turtles are now increasing as compared to a few years ago when they were under threat. So therefore, in conclusion, I'll leave you with this slide, is that there are a number of interactions. Again, this is a complex slide. There are a number of ways in which humans interact with environment, which leads to change in a number of factors, which leads ultimately to adverse impact on human health. We as kidney health professionals are concerned on kidney health, but we also appreciate the fact that kidney diseases don't occur in isolation. They are linked with other conditions as well. Often kidney disease has been lumped in the basket of non-communicable diseases and linked to diabetes, high blood pressure, cardiovascular disease, etc., which is true. Those links are absolutely well documented. But we also need to appreciate the fact that the kidney disease is also linked to a number of other conditions, which are socioeconomic factors, which are infectious diseases, which are linked to the level of development in which various societies live, and how they're able to access and respond to various threats that they face, etc. So I'll stop here, but before that, I will also like to invite you to the upcoming World Congress of Nephrology in New Delhi in February 2025. Thank you very much for your attention.
Thanks, Prof. Jha, for a thought-provoking talk. I'm sure there are going to be some questions. Are there questions from anyone in the audience? I can start. Do you think we're past the point of no return? No.
I think that will be the worst place to be in, or even to think that we are in that place. There are a number of modeling approaches. As I showed you, one modeling approach in which if the society does its best, which is the RCP 8.5, where will we be? There are a number of other intermediate modeling scenarios also, but obviously all of those intermediate modeling scenarios come with increasing doom and gloom. Every year there is this conference of parties, and starting from the Paris Climate Agreement, they have come up with commitments to certain targets and so on, and they keep getting pushed, which is unfortunate. but we are certainly not at the point of no return, but we will reach the point of no return unless we get our act together very fast.
Are there any other questions? Oh, Prof. Tishara?
Going on the other extreme, are there any low-hanging fruits that we should be looking at right now?
For sure, there are a number of low-hanging fruits, and it depends on who is, at what level are we thinking? Are we thinking at the level of an individual? Are we thinking at the level of a society? Are we thinking at the level of the government, etc.? And different, as I said, there are different actors, and different actors have their own spheres of influence, their ability to make change. I think the biggest change will happen at the level of policy. There is no doubt about it. So as members of a society, it is important upon us to recognize this, first of all, as an important threat, and to do all that we can. And it may sound like something which is very far-fetched, because ultimately we have to impress upon people or the members who represent us and who have the biggest influence in the government to take steps which are otherwise difficult to take, right? But in terms of individual, at individual level, of course, we can take steps, and we come back to the point of what can we do as nephrologists, let's say, or kidney health professionals. There are a number of things that we can do which can have a positive impact on the environment. One of the things that we can do is the thing that we often talk about, but I'm pretty sure that most of you have not thought of it in this way. Kidney disease prevention has a positive environmental impact. How? Every time a person develops a disease, they will require to visit a hospital, they will require taking medicines, they will need certain investigations, they will need expensive treatment. If they develop end-stage kidney failure, they will require dialysis. All of these, even a visit to a hospital comes at the cost of environment. It has an environment cost, right? So one of the things that we as a society can do is to prioritize prevention, disease prevention. Of course, that's if we want to leave a long-term impact on the environment. In addition to the fact that it has individual health benefits, healthy individual, of course, is a healthy individual, and in the intermediate, they contribute more to the society as well. And then I'm not going to discuss all of those in greater detail, but we talk about what else can we do in our hospitals, for example, improve the way we deliver dialysis to our patients. And Dr. Vacharajani and I were talking outside, how can we better use water in the dialysis system? How can we optimize the modality of dialysis delivery and so on? So there are a number of steps that we can do. As an individual, of course, we can also take other steps in our own lives. For example, using more active transport rather than motorized transport, using, say, bicycles and walking more. Of course, that is not always possible. Changing how we eat, moving to more plant-based diets than animal-based diets. So there are a number of things that we can do as individuals, but also as members of bigger groups, which include professional groups, but also include larger social groups.
Yes, here at the front.
Yes. In the presence of us going to Mars, going to the moon, what are the plans? What are they?
Sorry, I didn't understand your question.
We are going to go to the Mars, and invading other planets like the moon. What are the impacts?
Right. Very interesting question. So the question is, for those who did not hear, is that many of us are trying to get to the Mars, trying to get to the moon. Why are we doing this, right? And what are the implications? Of course, one is that, as someone said, we do these things because they're there, right? I mean, why did you climb Mount Everest? Edmund Hillary said, because it's there. So they climbed Mount Everest. So just because humans, and again, Jack Kennedy is often quoted that we do things because they're hard, not because they're easy. When America launched its moon mission, etc., in the 1960s. So that's one way of doing it. But then there are some others also who say that at one point, when Earth is going to become unlivable, we will perhaps go to Mars and live there. So that is another way of looking at it. But I think you raise a good question. What is more important to us? This is not to say that aspirations to go to Mars are wrong or are completely wrong, but I think they need to be balanced against all the other things that we need to continue to think about in more immediate future.
Thank you. This is a good time to bring up that the ISN is running an initiative about the public awareness of kidney disease and how low it is. And they're trying to get 1 million signatures by the end of this year to try and force global leaders to take kidney disease seriously. So we will be distributing via social media the ISN petition, if you'll all sign and get other people to sign so that we can try and get kidney disease to be a priority.
Yeah, thank you, Nina. I think it's also worth pointing out that there is an ISN booth here, and you can actually walk up to the booth and you have the opportunity to sign the petition right there as well. And we have a representative from the ISN sitting in the hall, Mara, who will be very happy to help you in that.
Perfect. The next thing on our manifesto is, the next thing on our agenda is to sign the manifesto. So the next item is the signing of the ISN and ISPD home dialysis consortium manifesto by SANS. So this home dialysis manifesto is an initiative by the ISN and the ISPD to try and push for more dialysis, but is home-based, PD as well as hemo, but particularly for PD. So it'll be signed by our new president, Professor Nikki Wern, and Professor Vivek Jha. And we're going to sign the pages up on stage and then have a photograph with Dr. Brett Cullis as well. Please all, will you come up? And Dr. Wadi, what was I thinking? We're just having a photograph of this momentous occasion. That concludes our session. Thank you. I invite you all to attend the welcome cocktail function down in the exhibition hall now. Thank you.
You out my sight, you're always just behind. These thoughts across my